still time, right?
There's still time. I think they will. I am. I don't know if there's any WhatsApp group or anything, but
No,
if we can give
he-
instructions on that.
there is one called the C Hall or some such thing. No, there was a group called Hall C.
I'm not a member of that. I think they've not added me or anything. I just logged in on my own.
Right. And yours is the which talk? Yours is number 7, right?
Number 7. Yeah, 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 yeah.
In
I
fact,
was just
bolo?
trying to see if my. I mean, we'll just do the normal share screen. There's no background for it, isn't it? I mean, we
Oh,
haven't received
they
any.
haven't given any virtual background. Yeah.
That's fine. Perfect. 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 All well, Dr. Uma? How are things?
All good, all good. How are things at your end?
Yeah, it's very cold here.
It is. I mean, it must be colder than Delhi, right?
I don't know. It's like it's really cold
Ah,
for this time of the year.
yes, it is. It is. Right, right.
Nobody else has joined in Navi, I
I
think.
Dr. Radhika said, I don't know, OT or OPD or something. She said she'll come and go beach May. She's the chair, right? And I don't see Jaya or Abhishek yet. The
Okay.
moderator and the convener hai nahi abhi. In fact,
Madam,
the
Dr.
program. हाँ बोलो.
But after my talk, I'll just go for some time. I have my OT, so I
No
put it on
issues,
hold
no issues
as
at
yet.
all. अभी Rajat wanted to go to the airport, so he wanted his talk first. वो भी आया नहीं है अभी.
Who's that? Who?
Rajat, and his talk was number 4, I think, 5. So he wanted to do it first,
Okay. Okay. All right. Fair
or
enough.
something like that.
Fair enough.
He hasn't come. The first speaker is Arjun Srirampur. He is here, I think.
Who's
Yeah,
there?
Arjun.
Okay.
Arjun Srirampur, you're there, right? Arjun, you're here? Dr. Arjun? They're all muted, I suppose.
Yeah.
I can see.
It's not showing here. Dr. Pranita Sahai is there. Dr. Anil Verma, I can see.
Anil Verma,
Those names
Pranita
there.
Sahai, Manthan, Arjun Srirampur, Shilpa Jain. They're there. So the first talk was,
Yes. Yeah.
and I think Anita Sethi is also not there. In fact, I'm having it on my phone, the program.
Yeah. That's correct.
All virtual. Dr. Parmeshwar is here. His talk is number 11th. है ना? Dr. Parmeshwar? Yeah. So I think the first speaker is also here. I think when Radhika and Jaya join in and Abhishek, I think we can start. I suppose. There's still 8
Correct.
minutes left. है ना?
Yeah.
In fact, I'm doing it from home because I have OPD. I can't. I mean, I've
Oh,
taken.
yeah.
Can't between patients do this, right?
True. True. Very true.
आप कर सकते हो, but OPD के बीच में नहीं.
Yeah, that's
It's
correct.
difficult, yeah. We still have time. I think normal screen share only, I suppose, है ना?
I can try that.
You want to try your whether your screen sharing is okay? Jaya is there. What is Jaya saying? She says good morning, but where is she? Yeah, you're able to screen share, right? Good, good.
Yeah.
Yeah, Amit, we can see it nicely, nice and clear.
Great, great.
Fantastic.
Perfect. I'll just quit that then.
Okay. Jaya is in Hall C, which finishes at 10:30. So Jaya may not be able to join in here. Sujata said she was not aware of it.
Not aware.
I don't know what she was not aware of. But yeah, she says, sorry, I was not aware about it. Oh dear.
So she won't be presenting essentially.
No, pata nahi, I have no idea what she means by not being aware about it.
I'm just going to go off the video, madam, for some time.
Oh, sure, no issues at all. As soon as Dr. Radhika joins, we can
Yeah.
probably start. Abhishek nahi hai, Jaya probably not join.
Fair enough.
Yeah, yeah.
Fair enough.
Hi, Dr. Radhika. This is Dr. Uma. Dr. Radhika Natarajan. Can you hear me, Dr. Radhika? Radhika Tandon is there. Hi, Dr. Radhika. Huh? Okay. Huh? Correct. Oh, I see. Okay. Okay. Who's Suma? I see. Is it so? Because they're not there. Abhi, I can see Manthan, Parameshwar, Arjun Srirampur, Pranita, Anil Verma, Radhika Natarajan, Amit Gupta, Shika Jain, and Arjun Srirampur. They are there in the thing. हाँ, ठीक है. Yeah.
Hello everyone, how are you? Hello Dr. Kalekar.
Hello, madam.
Hi. So everyone is here. Good. I'm so happy to see you.
Good morning, ma'am.
Hi, hi. Hi Arjun.
Hello, ma'am. Good morning. Good morning, ma'am.
Morning. Hi Pranita, nice to see you.
Good morning, ma'am.
Dr. Namrata,
Yeah.
Dr. Radhika was saying that she's in the OT and she's having some connectivity issues actually.
Okay.
So she's still trying to join in.
I think she's joined in.
नहीं, वो she was trying. I don't
Okay,
know.
okay, okay, okay.
Problem हो रही है.
Okay, okay.
Yeah. So I think आप जब शुरू करना है बता दो.
आप शुरू कर देना time से. When she joins, she can join in, and in case her talk is not held in this session, I will put it to some other session tomorrow
She
then.
can still join in for
है
the
ना?
talk. So she's still trying to join in.
Okay, okay, okay.
And Jaya is in hall K. She'll join in at 10:30.
Okay, okay.
That is the issue there.
Just start off, Uma.
Yeah, sure.
Morning, madam.
Hi, Amit.
How are things?
So, and
Busy?
Amit is not going to present. He said somebody else is presenting instead of him.
Okay, perfectly all right.
Right.
No problem.
So we start off, right?
Okay. Yeah, yeah.
Thank you.
All right. Mm.
So Dr. Radhika has joined. Hi, Dr. Radhika. Now you are.
Yes, can you hear me?
Yes, ma'am.
Yeah, sorry. So, you know what? The thing is that welcome everybody to this very important session. I am going to excuse myself for about 45 minutes because, we had this trouble with the nurses' strike and there were some carryover cases which had to be done. So I'm going to finish that and then I'll get back with you. And Uma has been kind enough to fill in for me, and I will get back to you in about 45 minutes.
So Dr. Radhika, start with Arjun.
Yes, please start. Yes, please start. Yeah. Okay.
So, good morning, everybody. Thank you, Dr. Radhika. We have this nice session on corneal ulcer demystified. And there are several beautiful talks on all kinds of keratitis, which we are facing for so many years. And still we haven't uncoded the mystery yet. We start with Arjun Srirampur, who talks on clinical diagnosis of various corneal ulcers based on the alpha ulcer morphology. So over to you, Dr. Srirampur. Can you share screen?
Yeah, thank you, ma'am. Thank you so much. Are my slides visible, ma'am?
Yes, Dr.
Yeah.
Yeah,
Should I start?
yes.
A very good morning to one and all.
Yeah, thank you.
At the outset, I would like to thank DOS for giving me an opportunity to present here today. Today, I will be talking about eliciting clinical signs of a corneal ulcer and how to come to a working diagnosis based on the clinical appearance of the ulcer. Firstly, the most common organism to cause a corneal ulcer is a bacterial corneal ulcer, and out of which Staphylococcus bacterial ulcers are very common. So these Staphylococcus bacterial ulcers are common in corneas with compromised surface in the form of bullous keratopathy or dry eyes. The ulcer is usually round or oval in shape with a clear and distinct margins, and the surrounding cornea is clear and not hazy or edematous. Sometimes these ulcers can look like an abscess within the corneal stroma. The next common organism to cause a bacterial ulcer is a Streptococcus. So Streptococcus can lead to corneal ulcers in his patients is having history of trauma in the form of corneal abrasion, or patients having a history of infection of a lacrimal sac in the form of dacrocystitis. These ulcers are deep-seated and they can rapidly progress to form a corneal melt or a corneal perforation. And also they have excessive AC reaction when compared to ulcers caused by Staphylococcus. Next is a rare and unique corneal infection, which is termed as infectious crystalline keratopathy, which is caused by Streptococcus. So this is a chronic and indolent corneal ulcer characterized by plaque-shaped interlamellar arboriform crystalline deposits on the cornea. And these plaque-shaped crystalline deposits are caused due to biofilm which forms around the Streptococcus because of excessive use of topical steroids. So these form of corneal ulcers are seen in patients having the history of keratoplasty or using excessive topical steroids, or very rarely in eyes with herpetic or neurotrophic keratitis. The next common organism which can lead to a corneal ulcer is a gram-negative bacilli, for example, a Pseudomonas corneal ulcer. So these ulcers are rapidly progressive, which can melt the corneal stroma within minutes to hours. And excessive stromal necrosis can lead to desmetocele or even perforation of the cornea. So these patients have a mucopurulent discharge, which is in the form of yellowish or greenish discharge, and the ulcer can also present in the form of ring ulcer, and the infiltrate is usually greenish or yellowish in color. And the surrounding cornea is not crystal clear, it is usually ground glass, and you can see a lot of haze and edema around the corneal ulcer. So this is a form of a GNB keratitis on the post-keratoplasty eye. You can see that there's a lot of necrosis and melting of the graft at the temporal half of the graft. Next, rare organism which can cause a corneal bacterial ulcer is atypical Mycobacteria. So these ulcers are usually chronic and slow-growing ulcers, and the patient usually give a history of long duration of symptoms ranging from months or years. So patients give a history of waxing and waning course of the ulcer, sometimes these patients use topical steroids which can lead to a waxing and waning course. usually there is a history of trauma or a corneal surgery to the eye, and these ulcers are infiltrates, look like a non-suppurative ulcers in the form of solitary or multifocal infiltrates. And sometimes there can be folds on the Descemet's membrane, which can lead to an appearance of a cracked windshield appearance. So this is about an atypical microbat. Next rare organism which can cause a bacterial corneal ulcer is nocardia keratitis. Again, these patients give a history of a long duration of symptoms with an indolent waxing and bearing course, and patients give a history of injury to the cornea with a contaminated soil. And these infiltrates look like a pinhead lesions into the corneal stroma, and sometimes these pinhead lesions are arranged in the form of wreath, and these are the typical features of nocardia keratitis. Next, corneal ulcer, which is commonly seen as a dendritic corneal ulcer, and it is usually seen with a viral keratitis in the form of herpes simplex keratitis or herpes zoster keratitis. So the dendrites is formed due to the active replication of the virus within the epithelial surface, and these dendrites have a linear branching pattern they can have a terminal bulbs or without a terminal bulbs, and they usually stain positive with a fluorescein stain, and the edges of the ulcer stain positive with a rose bengal stain. The next form of corneal ulcer which is seen is a geographic corneal ulcer. This is seen in eyes with a herpes simplex epithelial keratitis. The ulcer edges are scalloped with a broad-based fluorescein stain positive surface, and this is commonly seen in patients who use topical steroids when they have an epithelial dendrite and they start using topical steroids. Excessive use of steroids can lead to a replication of the live virus within the epithelial cells, and then can lead to a geographic appearance of the corneal ulcer. The next form of corneal ulcer which is seen in viral keratitis is a metaherpetic keratitis. It is usually seen due to neurotrophy or excessive drug toxicity. The ulcer has a horizontally oval epithelial defect with a smooth borders, or it can have a heaped up edges at the borders of the ulcer. And this is a typical feature of a metaherpetic keratitis. The next viral keratitis, which can be seen as a stromal keratitis, is a non-necrotizing stromal keratitis or interstitial keratitis. Here, the corneal ulcer is in the form of a excessive stromal edema or stromal scarring with an intact epithelium, and you can see a presence of a deep corneal vessels either in the form of a sectoral vascularization or the diffuse vascularization. Patients give a history of repeated recurrent inflammations in the eye, resolution with topical steroids, and sometimes, very rarely, there can be a lipid deposition at the edge of the leaking blood vessels. The next form of viral stromal keratitis is a necrotizing stromal keratitis, where the clinical appearance is similar to a bacterial or a fungal corneal ulcer. There is a lot of necrosis, ulceration with the presence of epithelial defect, and in severe cases, there can be thinning or perforation of the ulcer. So this is again another form of necrotizing stromal keratitis caused by herpes simplex virus. Here you can see a large epithelial defect and stromal infiltrate and necrosis of the corneal stroma. The next common form of corneal ulcer, which is usually seen in our Indian population due to the hot and humid climate, is a fungal corneal ulcer. So patients usually give a history of injury with a vegetative matter, and the corneal ulcer is usually a dry-looking ulcer with a feathery or hyphae edges at the border of the ulcer. And sometimes these ulcers can present like a corneal plaque, and if not identified and not treated properly, these ulcers can also perforate.
Dr. Arjun?
So this is again another form
Yes,
of fungal corneal ulcer in the form of a feathery
Last 2 minutes,
borders and excessive stromal necrosis and excessive hypopyon. And this is again another form of fungal corneal ulcer. In the top photo, you can see an ulcer which is in the form of plaque, and in the second bottom photo, you can see the ulcer which is looking like a horn over the surface of the corneal surface. And this is again a form of fungal corneal ulcer. You can see a small focal infiltrate in the center of the cornea and a large satellite lesion. And this is another form of fungal corneal ulcer which can present in the form of a ring ulcer. So this is another photograph showing a fungal corneal ulcer. You can see a large central ring-shaped infiltrate with stromal necrosis and melting of the cornea, and a huge hypopyon in the anterior chamber, and you can see a satellite lesion at the edge of the main ring infiltrate. Sometimes fungal keratitis can also present as a pigmented fungal ulcers in the form of a demataceous fungal keratitis. So if you see the ulcer surface is pigmented in the form of brown or black color, and it can also present like a hypopyon. So this is the clinical appearance of a pseudodendrite, which is caused by a fungus. So this has to be differentiated from a viral keratitis. In viral keratitis, we see a dendrite. So dendrite usually stains with the fluorescein stain, and usually you don't have a cellular infiltrate in the stromal surface. Whereas in the fungal keratitis, you can see this patient presented with a pseudodendrite, and you can see a lot of cellularity in the stroma, which is against a dendrite caused by a viral keratitis. Next, corneal ulcer, which we generally and regularly see, is a corneal ulcer caused by microsporidia. So microsporidia keratitis can present as a epithelial keratitis or a stromal keratitis. If the epithelial keratitis is there, so usually these spores of the microsporidia present as a discrete multiple pinpoint spores which are present over the surface of the cornea, and they stain well with fluorescein stain. And when you see on slit lamp, you can see that these spores are present as if they are stuck on the surface of the cornea. And after instilling paracaine, these spores can be wiped off and debrided easily with a 15 or 11 number. So this is a microsporidial epithelial keratitis. You can see a pinpoint multiple elevated lesions over the surface of the cornea. And after debridement with a 15 number blade, these spores, they disappear immediately. This microsporidial epithelial keratitis has to be differentiated from adenoviral nummular keratitis. So as I said, the microsporidial keratitis, the spores are present over the surface of the cornea. They appear as if they are stuck on the surface of the cornea. Whereas adenoviral nummular keratitis, the lesions are usually subepithelial, and you can see that the borders of the lesions are fuzzy and hazy, and the surrounding cornea looks, there is a lot of inflammation and edema at the edge of these adenoviral nummular keratitis. The next corneal ulcer is ulcer caused by acanthamoeba. So acanthamoeba keratitis, usually the patient give a history of swimming pool or a contamination with a contaminated water or excessive use of contact lens. And these ulcers usually present in a long duration. They have a chronic indolent course, and usually the patients are referred from one doctor to another doctor, and repeated corneal scrapings to identify the acanthamoeba.
Dr. Arjun, can
Yeah,
you
ma'am.
summarize?
Yes, ma'am. So in conclusion, identifying these clinical signs on slit lamp is important to understand the ulcer morphology and to develop our own clinical acumen. And also it helps the microbiologist to see what we are referring, because suppose we are suspecting a fungus or a microsporidia or nocardia, we need to inform the microbiologist prior so that he can stain with the special stains and look into the slides more carefully. So this is
That is a beautiful presentation with fantastic photographs. I'm sorry we had to cut you short a little bit.
Thank you.
Meetings, it's always we just don't have the timer and we cannot this one the time. So we'll have questions later if anybody has any. Do we have Dr. Anita Sethi here for her talk on circumventing resistance and choices available?
Yes, I'm here.
Yeah, Dr. Anita Sethi, can we have your screen share, please?
Okay, sure. Good morning, everybody. Sorry, I'm a little late. Is it visible?
Yes, Dr. Anita, it is
It's visible? Yeah. Okay. Respected chairperson, members of the dais, and dear friends. So today I'm going to talk about circumventing antibiotic resistance and the choices available with us. We all know the common organisms that are present in the and responsible for the infections in the eye are mainly staph, streptococcus, pseudomonas, and especially coagulase negative staph. Now, the common in the corneal ulcers, 80% are caused by staph, strep, and pseudomonas species, and most of the what happened? Yeah, the most frequent cause of perforation is pseudomonas. So, in the stories of the corneal ulcer, many of them will heal with or without a scar with our treatment. So that is a good ending. But unfortunately, there are many which will reach a very bad stage, not responding to treatment, and have all sorts of horror stories. So why do the ulcers progress? Amongst the many reasons is antibiotic resistance. And antibiotic resistance, there are many reasons for that. Many studies have been done. It is usually because we are using the antibiotics in a subtherapeutic dose, allowing mutation of bacteria. And there is some overuse or misuse of antibiotics in certain conditions. So how do we determine which antibiotics will be more effective in our cases? In an ideal situation, we would culture and look at the sensitivity, but in a corneal ulcer, we don't usually have that luxury of time. So we need to go back to surveillance studies. There are two such studies. One is the Ocular Trust study, which started in 2005. It's the ocular tracking resistance in the US today, in which 200 clinical labs participated. And they did retrospective and prospective studies, mainly on the sensitivity and resistance of antibiotics to staph, strep, pneumococcus, H. influenzae. Another really good study was the antibiotic resistance monitoring in ocular microorganisms, which was started in 2008 and is ongoing. It's a surveillance to track the antibiotic resistance. And we have got a lot of good information on the antibiotics and resistance. One of the interesting findings was that the MRSA was resistant to many other antibiotics like macrolides and even third generation fluoroquinolones. And Pseudomonas and strep, pneumonia, H. influenzae was susceptible to most of the tested antibiotics. So there was less resistance there. So if you look at the overall findings, it was found that the later generation fluoroquinolones, becifloxacillin, gatifloxacillin, and moxifloxacillin, had lower MIC90s overall compared with the earlier ones. And the resistance against the older was because there was only a single mutation required to get resistant, whereas the later generation require mutations in both enzymes and thus are more resistant. One of the significant findings was that there was a higher rate of mean percentage of resistance in MRSA amongst the methicillin resistance among the staph isolates in older patients. And the antibiotic resistant trends among ocular isolates was similar, whether it was conjunctiva, cornea, or intraocular. So now in our current treatment options, we have the penicillin cephalosporins, which are bactericidal, and the fluoroquinolones, which are also bactericidal. The macrolides and the others are not used as much in the acute conditions. Vancomycin is a drug which is being used for corneal ulcer treatment. It has a narrow spectrum, but it is very effective against gram-positive cocci, and there is not much resistance. It also penetrates into the vitreous. At a 5% concentration, it does cause burning, so we need to have a lower concentration. 2-hourly instillation, unfortunately, no drops available. We have to freshly create them, and sometimes that is not possible in smaller centers. Fortified antibiotics are one of the mainstays in the severe ulcers. They have been compared to fluoroquinolones and found that they are very effective in deep and severe ulceration where the fluoroquinolones may not be as effective. Good penetration, again, need to be freshly prepared. The fluoroquinolones are broad spectrum and bactericidal, where a very good tissue penetration and low toxicity. They are fast acting agents. And the 4th generation fluoroquinolone have a dual mechanism of action and thus are much less prone to resistance since multiple mutations are required. So the 4th generation fluoroquinolines that we are currently using is moxifloxacillin, gatifloxacillin, and basifloxacillin. Moxifloxacillin can be even used preservative-free for intracameral. Gatifloxacillin has a very good corneal tolerability and has been found to be more bactericidal with the preservative back. And basifloxacillin, after a loading dose, can be used in BD dosing. So these antibiotics are now widely being used preoperatively in bacterial conjunctivitis and are the drug of choice as a monotherapy in small to moderate corneal ulcers. So there are many studies, and if we would like to trust a study from China, unlike the apps from China, it's been found that both gatifloxacillin and moxifloxacillin are have a very good sensitivity. Most of the bacteria are sensitive to them, and gatifloxacillin seems to be almost 90%. The isolates are sensitive to gatifloxacillin, and its antibacterial activity seems to be enhanced with BAT. But there is something such as too much of a good thing. We do need to use the fluoroquinolines judiciously. The American Academy in a study found that there were the 2 most unnecessary interventions which could lead to antibiotic resistance. One is the pre-op use for intravitreal injections, and intravitreal injections have become very, very common. And there's a study that finds that perioperative povidone iodine works as well as using preoperative antibiotics. So, and since COVID also dies with povidone iodine, I think this is what we should be using for our preoperative. Just the perioperative use is good enough. And the other is viral conjunctivitis. We all tend to use an antibiotic, but maybe we should not be using the fluoroquinolones and keep them for the more serious or the more severe infections of the eye. To summarize, we must use our antibiotics correctly and judiciously to prevent resistance. The fluoroquinolones are broad spectrum, have a good ocular penetration, and the best monotherapy for small to moderate ulcers. And since multiple mutations are required, the 4th generation quinolones do not develop a resistance to the bacteria, do not develop resistance easily. And in the elderly, for deep severe ulcers, the fortified antibiotics should be used over the fluoroquinolone.
Thank you so
Okay,
much.
thank you.
Thank you so much, Dr. Anita, for a beautiful presentation. Nowadays, we are looking at mutation prevention concentrations as well as minimal inhibitory concentrations. And it is very important for different geographical areas to have their own laboratory data as to what organisms are prevalent at that particular time and which are the antibiotics which are resistant and which are useful. Like recently we found in Delhi NCR for the last 3 years, Gatti was quite resistant. And now again, the Gatti sensitivity is becoming better. So it's very important to have that data. And as you said, we have to look at, if you don't have the facility for a microbiological workup, then we should have the data there in that particular geographical area so that we can know which antibiotics to start with. And of course, unnecessary use of antibiotics in veterinary as well as general for conjunctivitis, etc., should be avoided. Now, can I request Dr. Radhika Natarajan to make her presentation on basics in bacterial keratitis and management, all the way from Shankar Nethralaya.
Thank you so much, Dr. Uma. I am Radhika from Shankar Nethralaya. Thanks to Dr. Namrata and DOS for having me here. I'll just take a second to share my screen. Yeah, so we'll just look at some of the principles of management of bacterial keratitis, since the previous speaker has already outlined the drugs that are available and the relative merits and demerits of those. We can differentiate gram-positive and gram-negative organisms to a large extent based on clinical examination, though not always. Gram-positive organisms When they cause ulcers, these ulcers are usually reasonably well localized. They're a little grayish in color. They're not bright yellow or exuberant. They have reasonably distinct borders with less surrounding edema. So basically, it is a lesser infection. Whereas gram-negative infections, when they occur, there is a lot more suppuration that is there, and a lot of exudates behind the ulcer, and ill-defined infiltrate. And these show quite rapid progression. And like the first speaker said, there could be, a few unique organisms, like shown in the panel below, where atypical mycobacteria can present with a wound infection, or you can have pinhead infiltrates in nocardia keratitis, but both of these can present variant from the typical clinical picture as well. Every corneal ulcer has to be scraped for the reason that the bacteria or any infection for that matter does not read the textbook before coming on the cornea. So there are some practical pearls about scraping, and scraping should be done unless there is a contraindication. It's better if possible to give a drug holiday before scraping to increase the yield. The leading edge of the ulcer should be scraped. Method of inoculation will be along a zigzag path so that maximum surface area is available for the organism to grow. And the epithelial defect that is there after the scraping should be measured out. Follow-up assessment of the lab report is important because after a preliminary report, the first one may be a commensal and the actual pathogen may grow later, or the pathogen may grow and there may be a mixed infection where another organism may grow later. Many times looking at the growth also is important because, for example, in Pythium, though it is not bacterial keratitis, the colonies grow very fast and they are submerged, whereas in fungal keratitis, they are slow growing and they are even on level. So looking at the growth also sometimes adds value to the diagnostics. And always clinical correlation is what matters no matter what the lab says. So in the panel on the side, you can see that the epithelial defect is so much after the scraping. So that needs to be measured for us to know whether the ulcer is healing after that. In picture B, you can see that the circle area is showing a scar. So if you scrape there, you're going to get only, neutrophils or lymphocytes. So the leading edge of the ulcer has to be scraped. The center, if you scrape, again, it is necrotic tissue. And side, the photograph in the slide C is my favorite because though it shows a white opacity, which looks like a scar, many times some infections like nocardia or acanthamoeba can produce a white infiltrate. So white is not always quiet in bacterial or in, for that matter, any infective keratitis. So if it's a very small ulcer like shown in picture A, you don't have to scrape. And the picture B shows a healing ulcer, so obviously you won't scrape. Picture C shows something which is melting on the slit lamp, so we don't have to have a perforation in that decimatose, so we won't scrape. And lastly, when we suspect viral keratitis, that is largely a clinical diagnosis, and epithelial healing is integral to the healing of viral keratitis. So viral keratitis, unless there is a doubt about stromal necrotic versus fungal, scraping is really not required. The commonest organisms in the SCUT study, which is the largest study till now, has seen is Streptococcus in the gram-positive side, and the gram-negative side, it has been Pseudomonas. That is the trend that we have seen in our hospital also, though the SCUT has seen a little more of Nocardia species than we would really see in our practice. And the virulent ones are the pneumococcus. You can see the serpiginous ulcer, which is causing a central extension, and Pseudomonas, which can melt under our watch. So these patients need to be admitted and antibiotics instilled round the clock, and they should be surveyed morning and evening till the healing starts to happen. So the treatment plan is quite simple because after all deliberations and discussions, we still have two major groups of drugs, which are the cephalosporins for the gram-positives and the fluoroquinolones for the gram-negatives. So it may be safe to say, though this is a busy slide, that the earlier generation cephalosporins worked well for gram-positives and the later ones for broad spectrum, and reverse with fluoroquinolones, where the earlier ones worked well for gram-negative and the later ones are more broad spectrum. But the couple of trends that we have seen, I would like to highlight are commensal infection is on the rise, and ciprofloxacin or fluoroquinolone resistance is also on the rise. So these are two things to be watched out for. And gram-negative agents respond equally well to fortified gentamicin, which may be a good agent to use in gram-negative corneal ulcers. So quick pearls in the management would be very small ulcers, monotherapy when it's not involving the visual axis. Combination therapy is for larger ulcers and infiltrative ones. Vancomycin is the drug of choice for methicillin-resistant Staphylococcus aureus, but it is a Brahmastra. So we can't use it indiscriminately, which can provoke a resistance. When the panel is showing resistant to all the drugs involved, there may be a scope for revisiting drugs like linezolid for gram-positive agents and imipinam for gram-negative organisms. And when there are recurrent infections, one should look for a septic focus in the nose or throat. So steroids can be given no matter what the SCUT study says to reduce the scarring a little bit. Povidone is a surface sterilizer. It will not work for deep infections. Doxy, because of MMP action, can cause less collagenolisis. Pac-CXL can be tried for moderate corneal ulcers. I quickly wrap up in about 20 seconds by showing these two very interesting pictures, where in one patient we had lichen planus, which is an autoimmune condition. Along with that, there was a bacterial keratitis. The patient responded very well to topical antibiotics, but you can see the second picture showing a leash of vessels. That provoked autoimmunity and the ulcer started melting. So we resuscitated the pannus, and there needed to be a certain immunity which makes the ulcer respond, but not the autoimmunity to kick up. And when the pannus regressed, then the ulcer again continued to heal, as you can see in the last picture. My final slide is that of this patient who had neurotrophic keratitis because of cerebral injury and fifth nerve weakness. Recurrently, he would break down, heal, you can see in the first two pictures. And when he came one time with an infection of the neurotrophic keratitis, our hearts sank. But then we found out that it was gram-positive. We treated it. To our surprise, when the ulcer healed, the scar that formed improved the hemidesmosomal attachments. And then after that, there was no breakdown of epithelium at all. So I'm not saying that bacterial keratitis is the treatment of neurotrophic keratitis, but sometimes when two diseases are in play, we don't know how one will influence the other. And so we need to watch out. So with that spectacular slide of infectious crystalline keratopathy, I close my talk on bacterial protocols today. Thank you.
That was a beautiful talk, Dr. Radhika. I completely agree that infection is not the answer to hemidesmosomal attack. Sometimes we find that in recurrent corneal erosions also, when that patient with REC develops an ulcer and scars, then the surface breakdown stops. But
correct.
Wish that on anybody, right? So that was a wonderful presentation. Thank you for sticking to time. And can you stop screen sharing?
Thanks a lot. I'll do that. Thanks a lot, Dr. Uma.
So after our Deputy Director from Shankar Nethralaya, thank you so much for your presentation. Do we have our chairperson? Dr.
My pleasure. Thank you so much as well. Have a great meeting.
Thank you. Is Dr. Radhika here for her presentation? If Dr. Radhika hasn't joined back from the OT, can I request Rajat Jain to make his presentation on HSV treatment protocols?
Good morning, ma'am. Actually, Dr. Rajat was upheld due to some unavoidable reasons, so I'll be presenting on his behalf.
Please go ahead. Yeah.
Thank you, ma'am. Are my slides visible?
Yes. Yeah, they are visible and you're audible also. Yeah,
thank you, ma'am. So I'll be talking about herpes simplex keratitis and some protocols. So some commonly faced questions by ophthalmologists are, what is the treatment of HSV keratitis? Till what point do you keep giving treatment? What is the role of antibiotics? What is the role of steroids? And what is the pathogenesis of this disease? So to answer all these questions, today we'll be discussing about the classification of HSV keratitis, some clinical pearls in diagnosis, the best management protocols, and some special scenarios. We'll not be talking about pediatric HSV because that is an altogether whole different topic. So when we talk about classification, it is very important to understand this before we start. And the treatment depends on the layer of the cornea that is involved in keratitis. So grossly, the classification looks like it can either involve the epithelium, the stroma, or the endothelium. When it involves the epithelium, it is called epithelial keratitis. When it involves a stroma, there could be two forms, the immune stromal keratitis and the necrotizing stromal keratitis. And the endothelial forms could be either focal, diffuse, or linear. So we'll grossly, if we look at the treatment for epithelial keratitis is slightly different, but the treatment for stromal and endothelial keratitis are more or less on similar lines. So before we discuss therapy, we need to know that the topical acyclovir is effective only for the epithelium, while the systemic acyclovir affects all the layers. Topical ganciclovir can be used interchangeably with acyclovir and is said to be better tolerated. When we talk about prednisolone, the acetate form is said to have better penetrability and hence better bioavailability. So coming back to epithelial keratitis, in epithelial keratitis, only the epithelium is affected and it has been shown to contain active viral cells by PCR. We use acyclovir topical, 3% eye ointment 5 times a day. And it is very important to know that nothing else is required. Ganciclovir can be used interchangeably and it has a similar efficacy. Although the bioavailability of topical acyclovir and oral acyclovir are similar and can be used interchangeably, but cost becomes a very significant factor when we think of oral acyclovir. Lubricants are routinely added, but the role of cycloplegics is very controversial in epithelial keratitis. So if an epithelial keratitis does not heal in 3 weeks, it is very important to consider revising your diagnosis. The only 2 caveats are if there is a history of steroid usage before the patient presents to you, or if there is a long duration history which was not treated. So in these cases, the patient may require a prolonged topical acyclovir, but even then, only acyclovir is needed, nothing else. So this is a patient who had a history of steroid use for epithelial keratitis. One complication we already know of geographical ulcer. These were some vague opacities that developed in anterior stromal region. So coming to the stromal part of keratitis, we have 2 forms, immune and necrotizing stromal keratitis. The immune keratitis is an immune reaction to HSV antigen, while the necrotizing form has active HSV replication and stromal necrosis. The treatment for immune stromal keratitis is only steroids, since it is an immune reaction only. There are no active viral cells. The patient presents with only corneal edema. There are no KPs, no anterior chamber reaction. So a prednisolone would work well with Homide, and the patient has to be reviewed 1 week, followed by weekly tapering of steroids, and the patient is reviewed after 1 month. Oral acyclovir can be added in these conditions. This is a patient of immune stromal keratitis. If the patient is treated early, the scarring which tends to develop is minimal. Coming to necrotizing stromal keratitis, it is most difficult to diagnose, but the most important sign is that the signs are more than symptoms. There is a prolonged history. There'll be minimal lid swelling. The patient will not be photophobic. There'll be no glare. There'll be no discharge. The patient is not in much pain. But if you see, there'll be a whitish infiltrate. There'll be vascularized surface. You may appreciate some ghost scars from previous infections. The patient usually has a perilimbal infiltrate, which is arcuate in shape, and the infiltrate is usually pleomorphic, which means the density of the opacity may be differential in some parts of the cornea. So as it consists of active viral replication, there is viral infection plus necrosis and thinning. The patient has to be started on tablet acyclovir for 21 days and prednisolone, Homide. The patient may be given antibiotic cover for 4 times a day. This stromal keratitis may resolve, sometimes leaving a persistent epithelial defect. In these cases, excessive lubrication has to be advised, and if the patient doesn't respond, it has to be followed with a BCL or a tarsography. So coming to the endothelial forms, we have 3 forms: focal, diffuse, or linear. The patient usually presents with a corneal edema and keratic precipitates. AC reaction is usually present. The edema may be in any of the forms, linear, focal, or diffuse, but again, the signs are more than the symptoms. So again, this is an immune reaction with viral replication. On AC tab, people have found virus by PCR techniques. So the patient is started on tablet acyclovir with prednisolone, Homide. Usually they respond well, tend to heal without a scar. Earlier the therapy is started, it is better, although few iris pigments may still remain. But it is important to remember that every episode of endothelitis leads to some decrease in endothelial cells, which can cause progressive decompensation in recurrent HSV. So we understand that both stromal and endothelitis forms of HSV need tablet acyclovir for 21 days. But the question is, do we need to taper oral cyclovir? So no tapering is required. However, a prophylactic dose of 400 milligram BD, the patient may be kept on this dose, especially when it is a post-graft in children, when there are frequent recurrences or the patient is diabetic or immunocompromised. But till what duration is still difficult to say, because frequently once the acyclovir is stopped, recurrences are noticed within 6 months. So these are some case examples. Any deep corneal scar, the surgeon should be a little wary of doing transplants in these patients. This was a patient who had a full-blown HSV, necrotizing stromal keratitis in other eye, and the eye was thicical. This eye had a corneal scar, and the patient was taken up for triple procedure. Full course of antiviral drugs was given for 3 weeks, followed by prophylactic dose of acyclovir for 2 years. The patient did well. However, when the acyclovir was stopped after 2 years, the HSV recurred. It was treated again. So the question remains, till what time do we continue acyclovir? These are some other case scenarios. This patient had a vascularized scar. Patient was taken up for a triple procedure, but an early rejection was noticed at 4 months, and by 6 months, the graft failed. The repeat PKP was done for this patient. Now it is 3 years follow-up down the line, and the patient is doing well with 618 vision. So it is always important to remember that there could be a super added infection in necrotizing stromal keratitis as well. So when in doubt, it is better to scrape and to treat. This is a classical necrotizing stromal keratitis patient with vascularization, a pleomorphic opacities, fingerprint or ghost scars. This is another picture of necrotizing stromal keratitis. So some common mistakes that we often make is when we give topical plus systemic acyclovir together, they have no role when given together. Topical acyclovir or vanciclovir is given together. Topical acyclovir is given for stromal or endothelial disease because it doesn't penetrate that deep. Tapering of systemic acyclovir, as we already talked about, it is not required unless in high risk cases when we give prophylactic dose. The hesitancy to use steroids. After a 1 week period, steroids can be started safely. Low potency steroids are not effective, and recurrent diseases, ACP prophylaxis is a must. So the take home message is, depth of HSV infection guides the therapy. Acyclovir ointment has role only in epithelial keratitis. Although the bioavailability of topical and oral is similar, but the cost factor needs to be considered. Prednisolone acetate has a massive role and needs to be given to control the surrounding inflammation. Recurrences are common in necrotizing stromal keratitis, but early treatment minimizes the scar and minimizes the vessels. Thank you.
That was a very beautiful presentation, Shikha, and it was quite clear. And still, we do make mistakes on diagnosis and management of HSV keratitis. If any of the speakers have or panelists have any comments to make, kindly make it. Till the next speaker is Sujata Dwivedi there to share her screen. I don't see her in the list of participants here. So our chairperson also hasn't joined in. So the next speaker would be Dr. Amit Gupta to speak on post-adenoviral subepithelial infiltrates. It's a major challenge, obviously it is. If you can share your screen, Amit. In the meanwhile, if anyone has any comments to make. Go ahead, Amit, with your presentation, treating post.
All right. Thank you, ma'am. You can hear me?
Loud and clear, Amit, loud and clear.
Thank you. So I'll be talking about treating post-adenoviral conjunctivitis subepithelial infiltrates, which is a major challenge. And I do have to disclose that, some of the things, because so much conflicting literature is there. We all have our own views, how we want to treat these. And some of what I say is going to be based on 3 studies that we have carried out in PGI Chandigarh. 2 of them have been the thesis regarding ganciclovir and as well as tacrolimus and cyclosporin, and also we have a pool officer project going on with povidone iodine. So some of this, but it's scientific data which we are in the process of publishing. So many times we see patients like this, the 16-year-old girl coming with scarring of the cornea. And every time I think I ask myself, could it have been prevented? Is there something which could have been done to decrease the severity if done at the right time? And what do I do now with this kind of patient? The important to understand is, why does it happen? So if you look at the pathophysiology of the subepithelial infiltrates, they represent a cellular immune reaction against the viral antigens. So they can stay dormant for years or months, and the corneal stroma under the Bowman membrane. And the subepithelial infiltrates can persist for such a long time. And most of these infiltrates, actually literature says that they tend to resolve spontaneously without scarring. Not everybody requires treatment. How common is it? And again, about 50 to 80% of the patients who are infected with epidemic keratoconjunctivitis, they will reveal, some kind of corneal involvement. Only 10 to 25% of patients have a severe form of the disease, which involves practically the whole of the cornea. In our own study, at day 10, we found close to 100% of the patients had some form of corneal involvement. Most of them had mild, and a few of them had severe involvement. Now, does the acute management of adenoviral keratoconjunctivitis influence the occurrence and course of these SCIs? That means, what do you do? What we do in the first 10 days of the disease, does it influence what happens to the patient later on? So, in other words, is an ounce of prevention, we know it's worth a pound of cure. So again, this is an ongoing study, and we are studying the effect of povidone iodine 1%, 5%, ganciclovir, as well as the control group. And so we found that compared to a previous study, the incidence of at least severe infiltrates was considerably less. Many of the patients had actually no corneal subepithelial infiltrates. All these patients, this is at day 10, and in all these patients, the therapy was initiated within the first 96 hours. So the lowest incidence of SCIs was found in patients receiving povidone 1%, which we have requested a particular pharmacy to make for us, combined with dexamethasone 0.1%, starting from day one of presentation to us. So the next question is, who to treat? When do we start treatment? And many of these patients come late to us. So we have to decide, is it an active or inactive? Is it scarred, or is it an active, SCI? So there's an interesting publication which says, using the anterior segment OCT. So one is that clinically, we say that if you stain, if there's some kind of a punctate staining at that corresponding to the subepithelial infiltrate, we would say that probably this patient needs to be treated with steroids or other drugs. So the SCIs which are active, they appear patchy in the anterior stroma, and along with an intact Bowman membrane and uniform epithelial thickness. So classically the SCIs. On the other hand, once they are healed, there is some kind of a plaque-like thickening of the Bowman's Bowman's membrane and a variable epithelial thickness due to epithelial remodeling. So this is, we have tried it in limited patients and not in everybody, but it does give us a good clue who to treat. Now, how to treat this patient? So we have this patient, cornea is totally scarred. How do we go about treating this patient? Now, if you look at this chart, so one of the options is antiviral agents. And I have, as I said before, that these practically have no role after day 10 in treating subepithelial infiltrates, right? And in one of our studies, we found that in patients, the ganciclovir, when it was given, it decreased the severity of epithelial involvement. So it has a role if it's given in the first 10 days, and probably after that, it has no role. If you look at the role of povidone iodine in these patients, again, studies have shown that the use of povidone iodine of various concentrations, 0.4% has been used in a few studies, combined with dexamethasone, of course, it lessens the duration, and also it has some effect on the incidence of the subepithelial infiltrates in these patients. So all these studies have, and in this particular study, which was published in 2015, it showed that in terms of, this was again 0.4% DEXA, it showed that it has been no statistically significant effect on the SCIs. So then we talk about steroids in this patient. The question is, what potency of steroid do we use, and when should we initiate? So the question is, when a patient is presenting to us, should we initiate steroids the moment the patient comes? Should we initiate only when the epithelial involvement is there? What are the indications? Should we add antiviral agents along with this or not? And for how long should we give steroids? What is the endpoint that we have to stop the steroids in this patient? A very early publication, this is from 1970. And they gave steroids in patients of EKC, and they found that these patients tend to resolve with time. And in all of these patients, they said that the SCI is resolved after steroids due to suppression of edema resulting from continuing minimal antigen antibody reaction in the stroma. So if you look at, there was another study which was carried out in animal eyes, and that showed that the adenoviral replication was enhanced once we were giving steroids without any antiviral agents. So steroids, they said, should not be given alone, and which is our recommendation in patients who are in the first 10 days of the disease. Should they be started only when we see epithelial disease? Now, our own experience is that they can be initiated with antiviral agents even earlier. And in that case, we see the incidence of the infiltrates decreases considerably. There are different types of steroids, and what has been recommended is that we can give low-dose steroids like loteprednol, 0.5%, and for more severe cases, we can move on to higher potency steroids. Important is a slow tapering of medication. That is, we should make the dose half every week or 2 weeks, and that is mandatory. Otherwise, there's a high chance of recurrence of these infiltrates. So what does the American Academy recommend? So the use of topical steroids in selective cases with corneal involvement. However, the question remains unanswered as to the guidelines and specific protocols in managing patients with SCIs with steroids or immunomodulators. Important to understand is that inadequate or complete avoidance of steroids, as is practiced by some ophthalmologists, may lead to chronic scarring or permanent disabilities in patients. So we should be reasonably aggressive once we see these SCIs to give steroids, and not say that this is viral, I don't want to give steroids. That's more harmful. That's why people end up with the kind of photograph that I was showing of the patient. The other question is that, are steroids enough in these patients? Now, it has been shown that, every time, there are many publications that once you taper down the steroid and you decrease the frequency of steroids, sometimes there is recurrence of the SCIs in these patients. So there are other side effects like due to chronic use, like glaucoma and cataract. So most of these patients require steroids for many weeks. It is not that you give it for a week, it just goes away and you stop the steroids. Doesn't work like that. So this has led to the evolution of the steroid sparing drugs, that is the immunomodulators, in the treatment of subepithelial infiltrates. Now, we all know that there is two main immunomodulators. One is cyclosporin A, and the second one is the tacrolimus. So cyclosporin A, in various publications, has been shown to be at least as beneficial as steroids. It's a nice maintenance drug to give, and in some studies, it has even been shown to resolve the subepithelial infiltrates which are not responding to low-dose topical steroids. Another publication which has shown that the symptoms were less severe had shorter duration with topical corticosteroids and cyclosporin A when compared to palliative therapy. And this might actually inhibit the onset of the SCIs. So there are various publications which show efficacy, but the data is, many of these publications, they show that there were recurrences once these drugs were stopped. So the ones in purple are the studies on cyclosporin, and the ones in blue are the one with tacrolimus. And what they have shown is that tacrolimus has shown to have a better result in patients of adenoviral subepithelial infiltrates compared to cyclosporin. And I really couldn't find an answer why, but we know that tacrolimus is much more potent than cyclosporin A. We did have do our own study of the role of steroid sparing topical agents. So we compared cyclosporin A versus tacrolimus in patients of, we presented this at the American Academy this year. And one of the key observations was that, although there was an improvement in both the groups, but we had a high rate of recurrence. This was a 3-month study. So the moment we stopped it, many of these patients had a recurrence. But tacrolimus group had less recurrences, which is 45% versus 85%. So we actually concluded that they may not really work so well. We have to keep giving them, only then we see the benefit. Is there any role of surgical management? Well, surgical treatment, a limited role of PRKs, PDKs or lamellar keratoplasty in these patients. Personally, I have no experience. I have not done surgical intervention in these patients. Most of them can manage with their life. And it has been described that you can do a PRK or a PTK in these patients. So to conclude, one thing I would like to drive home is that all AKC patients should be followed up between 10 to 14 days. Most of these patients developed SCIs within the 10 to 14 days. And the earlier we initiate anti-ACI treatment, the better is the outcome. So as the risk of scarring is reduced. So once the ACIs are diagnosed, the only treatment of steroids, ACIs is steroids or the steroid sparing immunosuppressive agents as maintenance in these patients. So are some questions answered? One, initiate antiviral agents if patient presents within 96 hours of symptoms. Certainly, yes, now. That's what we practice after our experience. Initiate steroids with antiviral therapy in the first 5 days. Probably, yes. Like povidone-iodine or ganciclovir, we do add steroids and our results are fairly good. Initiate steroids in patients with SCIs, yes. When to stop acting steroids, we use a clinical judgment, or maybe we rely on the ASOCT to for the same. We may carry on with cyclosporin A or tacrolimus for many months. Of course, steroids we have to limit, and maybe it's a good idea to switch to loteprednol, and that will give us the right answer. Thank you very much. I'll be happy to take any questions because I have to go to operate. So if I could take questions now, I just have a request.
Dr. Radhika is here. Dr. Radhika, do you have any comments to make on this before you start your presentation? Radhika had some connectivity issues. Is she here? Amit, can you stop screen sharing?
Oh, yeah.
Dr. Uma, could I ask Dr. Amit a question?
Go ahead.
Yeah, very nice presentation, Dr. Amit. I just wanted to know, are you saying that I've seen that it's only the severe, some of the patients come with a severe presentation and they are the ones more likely to go into the SCIs. Are you saying that in all patients presentation, whether mild or severe, you will start antivirals on day 5 and steroids after that?
Madam, it's very difficult to predict which patient is actually going to end up with severe SCIs or not. So currently we have a trial going on and we have 5 modalities, including a control group. But the initial results, they are suggesting that if we are adding on 1% povidone-iodine, which is tolerated much better than 5%, along with DEXA. So if, from day 4, maximum day 5 to day 10 we stop it. Our results are fantastic, actually. I mean, the incidence of SCIs is almost gone, almost to 0 or very mild, which goes away just with very minimal medication. So right now, I think this is what we are practicing. I would educate right now, but till we publish it, I can't really, ask everybody to do it.
I'm just saying practically in the mild cases of keratoconjunctivitis where we are not having any corneal involvement, should we be following this in that as well? That's my question. The mild cases.
Madam, if we have patient coming within 96 hours, I would start on some antiviral therapy with steroids. That's it.
Okay.
Irrespective of the severity. Yeah.
Okay. All right. Thank you.
Yeah, hi.
Hello. Uma.
Dr. Radhika, can we have your presentation now?
Yes, we can. I'm a little bit concerned
Radhika?
yeah, I'm a little
Dr. Radhika, can we have your presentation?
very poor.
Can you hear me?
Hello.
Dr. Radhika?
Very weak. Yes, yes. Can you hear me? Hello. 1 second. Connection is very weak.
Can you hear me now? We had Dr. Radhika. Can we have your presentation? I see Dr. Radhika here.
We
have your presentation, Dr. Radhika.
Good. From
Hello, Dr. Radhika. Can we have your presentation? Am I audible?
Yes, ma'am, you are audible, but I think we have...
Dr. Radhika is not there. She is not able to.
She is there, ma'am, but her voice is cracking. I think the connection is...
Can we have Dr. Anil next instead of
yeah,
you?
Connection is...
Can we have Dr.
Please, I'm going to shift to a desktop.
Sure.
Yes, yes,
Well,
yes.
we can have Dr. Anil to be.
Yes.
Kumar Verma on management of fungal keratitis. Are you here, Dr. Anil?
Yes, yes, madam. Hello. Hello.
Can you unmute yourself, Dr. Anil, and make your presentation while Dr. Radhika gets ready?
Okay.
Go ahead. You can screen share now.
Okay, okay. Yeah, should I start?
Please do, Dr. Anil, please do.
Okay. Okay. Morning, everybody. The topic of my today's presentation
Please start.
Management of fungal keratitis. Although it's quite a big topic, I would like to summarize it in 7 minutes. Fungal keratitis is an important cause of ocular morbidity in developing world. And if not diagnosed and effectively treated, it has a devastating ocular consequences. It constitutes up to 1/3 of the cases of the suppurative keratitis. The first case of fungal keratitis was described by Laver in 1879, and it was a case of fusarium. There are at least 70 different fungi which cause fungal keratitis. And the epidemiology of keratomycosis is climate specific. In tropical and subtropical climate, filamentary fungi predominates, and Candida species, however, is a part of indigenous human flora. Risk factors are basically in our developing countries, it's the trauma with the vegetative matter or injury with the objects which are contaminated with the soil. And in Western countries, it's use of contact lenses, basically the solution which is used to preserve these contact lenses or clean these contact lenses is the primary culprit. Fungal keratitis is most common in rural population because these agriculture workers, they are more prone to trivial corneal injuries with vegetative matter. And these fungi secrete toxic substances including proteases, hemolysins, and exotoxins. And the hyphae of these filamentous fungi or pseudo-hyphae of the yeast, these are quite large. So it's impossible for neutrophils and macrophages to ingest these filaments and pseudo-hyphae. The common pathogens are these are filamentous yeast or dipomorphic, and these are the common fungi, Aspergillus, Fusarium, Candida, etc. And nowadays we are also these few case reports are being reported with the rare fungi, Acremonium, Scedosporium, Pythium, Piscilomyces, etc. The clinical features, signs are more than symptoms, and this fungal keratitis is dry, raised, leathery, with crenatid or feathery margins, satellite lesions, thick and immobile hypopyon. Then stromal lesions are present beyond the size of epithelial defect, and we may see the immune ring or Wesley's ring also. I'll show you the picture. You can see that the first picture is of these are pseudodendrites. Then there is a sloughing corneal ulcer, then dry and leathery. Then you see that there is an immune ring, Wesley's ring, then crenatid margins. These borders are feathery borders. Then you can see that here it's a satellite lesion, and in this picture you can see multiple satellite lesions. And this is even a small ulcer with irregular margins with hypopyon. And this picture I have taken especially even in such a small ulcer. If you take a corneal scraping, you can see look pathogen in a direct microscopy with KOH wet mount. As far as the conventional diagnosis is concerned, we should always do a direct microscopy and culture. Direct microscopy is done with KOH wet mount, Gram staining, James South, calciferous white. And KOH wet mount is a very rapid and inexpensive, and sensitivity is about 61 to 94%, and its specificity is 91 to 97%. Then after direct microscopy, we can put the sample of the culture, that is SDA or blood agar or chocolate agar. And I'll show you a few cases which I have managed. The first case is a 50 years male. He was agriculturist by profession. He had a trauma with the branch of tree, and Aspergillus flavus was detected. This is the KOH wet mount film, and this Aspergillus was detected by identifying the conidiophores. Then a 35 years female, she was a housemaid, she had an injury with the vegetative matter, and Acremonium species was detected in this case. And the identification was done by seeing the mosaic pattern of the conidia in the culture. 42 years female, basically she was having a treatment of viral keratitis for last 2 and 3 months. And she was on steroids, and she was being treated in a good corporate hospital. You can see that on culture we saw that tamarind-like arrangement of conidia, and it was identified as detected as Piscilomyces liliaceus. Then this patient, 62 years male, he was a driver. He had a contact with the dust while driving, and you can see that there is a feathery margins of the ulcer, and in this lollipop-like conidiophores were detected on culture. Then this was earlier I have shown this picture is a small ulcer. We had taken a scrape, and on direct microscopy we saw that slender and these hyphae were seen, and on culture it was detected as Eulocladium species. Nowadays newer methods have been used for the diagnosis. These are PCR. The advantage of PCR is highly positive detection rate. It takes about 4 to 8 hours, and small clinical sample is needed. Then its limitations are it's quite expensive and not readily available, and it can artifactually amplify the known pathogenic organisms. So it can lead to overdiagnosis also. Then DNA sequence-based methods, xenotyping, it's basically rapid. Its advantage is rapid specific identification. It may help in explaining variable presentation and response to treatment of same genus among different patients. This may lead. This may yield an important prognostic and therapeutic information. And its limitations are that there are few laboratories where this genotyping can be done. In vivo confocal microscopy, few centers are using it quite frequently, and its advantage is that it's non-invasive. Early identification of fungal elements, it determines the depth of the infection, helps in monitoring and guidance of the treatment. Its limitations are motion artifacts can affect scanning. It depends on the patient. Then dense corneal infiltrates, or if there is a scarring, it could preclude proper tissue penetration and visualization. And we need a skilled operator. And the last, it's quite expensive. I think it costs about 60 lakhs. So everybody cannot afford to have such a costly machine. Then antifungal susceptibility test. Various studies have been done, not so frequently used in fungal keratitis, because studies have shown that there is no correlation between in vitro and in vivo susceptibility. Then limited studies have been done, and these studies have been done on only small sample. No consensus or no guidelines on the role of susceptibility testing are there. Then medical management, we have multiple antifungal preparations, these polines, pyrrolines, imidazoles, then triazoles, and these all we know that these are being commonly used. Then newer advances in the antifungal, that is posaconazole, it's a new triazole. It is being used in those refractory keratitis which are not treated either with the this natamycin or voriconazole. Then echinocandins, capsofungin is being used, mycofungin is being used. These are basically, we use them in refractory fungal keratitis. Then the other advance is that nanoparticles, are being used for sustained antifungal drug delivery, cell penetrating. These are basically, they help in penetration of the drug. Basically, they help as a carrier, that they transport the molecules across the cell membrane. And this is still under evaluation and under basically research. Then surgical treatment. Surgical treatment is basically, we use it when the complication occurs. This is therapeutic penetrating keratoplasty, therapeutic lamellar keratoplasty, then patch graft. Its limitations are graft failure. In 50% of the cases, there is graft failure. Then newer surgical treatments, intrastomal voriconazole, that 50 microgram in 0.1 ml is given in 5 divided doses around the corneal ulcer. And it has been studied that it is effective in recalcitrant fungal culture which are not responding to conventional treatment. And a few studies have shown that any intervention through normal cornea in presence of keratitis may lead to new foci of infection. Or there can be, if the person is not trained, there can be risk of anterior chamber entry. Then intracameral amphotericin may be used in deep mycosis, endothelial plaque, or thick hypopyon. Then PEG, collagen cross-linking. This is also being used nowadays, and its limitations are that it causes limited limbitis, and there can be a transient increase in the size of the hypopyon. And some people have also reported that there can be perforation also. And even after collagen cross-linking for this keratoconus, they have shown that the infective keratitis have occurred after collagen cross-linking also. Then these are management guidelines. Initially, empirically we are using natamycin. So if we suspect a case of fungal keratitis, then we should start at natamycin 5%, and we should because this fungal corneal ulcer, they take quite a long time. Even doctor and the patient both have to be patient, because a fungal corneal ulcer may take at least 5 to 6 months for a complete treatment. While you are doing a cataract surgery, it may take 5 to 6 minutes, but it may take 5 to 6 months. I can compare it with the skin department, that they are in fungal infections of the nail. It takes about 6 months. So our cornea is also like this, because it's avascular, so it takes a lot of time. So we have to be very patient while treating fungal corneal ulcers. then after it should be continued for 2 weeks. If there is no improvement, then we can go for other antifungal drugs. Like if there is Candida and Aspergillus, then we can go for topical amphotericin. Then if there are other refractory, then we can use voriconazole, and voriconazole is available as Vozole 1%, being made by, I think, Orolab. Then uh, in deep keratitis or scleritis or endophthalmitis, in fungal cases of this, we can use systemic antifungal drugs. And I think it's my experience, if we use systemic antifungal drugs with proper liver function tests, then it gives a good results. Then in advanced keratitis or severe corneal thinning or impending perforation, we can use that keratoplasty is the treatment of choice. And in the end, I would like to say that although this KOH wet mount, it's very simple, inexpensive, and very it's have a good sensitivity and good specificity. We should all have a small microscope in our OPD, so that the moment the corneal ulcer comes to you, that at least you can have a KOH wet mount. And because our sample is quite small, then sometimes it may take about 20 to 30 minutes to identify these fungi. And my advice is, even any ulcer of more than 2 mm size, in all the cases we should take the corneal scrapes, because it's basically what we are treating nowadays is we are mainly focused on the complications of the fungal keratitis, but we are not preventing it, and we are not treating it in the early stage. If we treat it at the early stage, then it gives good results. So everybody should have I think microscope, simple microscope comes with within 20 to 25,000 range, a good microscope. So it's my advice that everybody should have at least all the postgraduates should be taught like this. Okay, they should at least have a microscope in their OPDs. Thank you.
Thank you, Dr. Anil. Dr. Radhika, ma'am, can we have your presentation then?
Yes, I think my sound should be better now. I have got a wired broadband connection with my office desktop computer. I sincerely apologize to everyone for this intermittent joining, leaving, and then AV issues. But I must say I have been catching up on what other presenters have been presenting, and it is really a very good session and very informative, plus very practical. So I will be happy to present, but before I do that, there may be a few questions or comments to Dr. Anil, because this is another very important area. So anybody has any questions?
Can you stop sharing your screen, Dr. Anil? Can you stop screen sharing?
Okay.
So Dr. Anil, in your computer, do stop screen share.
Okay.
And while my screen is getting shared, maybe we can have one question.
Yeah.
Has anyone used caspofungin for fungal keratitis?
No, I have not used it. If somebody has used it, can please give comment.
Found it prohibitively expensive. That's the reason I'm asking.
No experience so far. It's a newer antifungal, and largely our armamentarium is including the natamycin and the standard antifungal agents. But caspofungin as well as posaconazole are two new drugs which have got promise. And one shouldn't forget the role of using amphotericin B also. Sometimes if one has to, one may use it. Particularly for intralesional injections, and so these are the drugs that are available, commonly used.
Just one comment, ma'am. Natamet, I usually advise my patients to change the bottle every month. since Dr. Prajna had said that Natamet can itself grow Pseudomonas. So anybody has any experience on that? Because I found the bottle can get contaminated. So like we ask the patients to keep changing the fortified antibiotics. I tell them to keep changing the Natamet also every week. So it may be a little expensive because it can get, the bottle can get contaminated early.
Yes, that's a good point. And as such, these patients with infective keratitis, often their whatever bottle they use can get contaminated because, or where the with the blepharospasm, photophobia, difficulty in putting the drops, often the tip of the bottle is actually touching the lashes. And certainly it's important when they're using the fortified antibiotics, they are having to change it after, say, 72 or 96 hours. But as you correctly said, if they're using commercially available agents, and then they have to be told to keep changing maybe after a week or 2 weeks. Personally, I haven't ever encountered this problem of natamycin bottle getting contaminated, but now that this has been brought to light, it's useful to check when the patients come. We can do some samples and see if it is happening or not. And I think it will also matter depending upon the weather and the storage conditions, depending upon how the patients are keeping the bottles. So I don't think any of us has actually looked into how any of the bottles are getting contaminated. So I think it's worth studying.
That's true. They have
Exactly.
sometimes you find no labels. The bottles are pretty dirty, and
Yes.
that also has.
So before I start, can you confirm, Uma, is my voice better now?
Very clear, ma'am. Loud and clear.
Okay. Okay. So, since mine was supposed to be only on presentation of viral keratitis, and then we have another speaker on management and the difficult cases. But I believe the Dr. Rajat and Sujata are not here. So I'm going to
presented. Chika has presented for Rajat, and
Okay.
Sujata is not here.
Okay, fine. So I'll quickly give you a case-based scenario then, try not to have any duplication of concept. So when we're having viral keratitis, the topic is herpes simplex, but keep in mind that there are certain situations where there may be an overlap because there are so many sequelae and such a variety of manifestations of viral keratitis that you can't always compartmentalize, and often you do have situations where it's actually quite confusing. So remember that there are the various viruses. Of course, it's very unlikely that one will confuse adenovirus with herpes simplex, herpes zoster, but the same principles do apply. And in pediatric age group also, it can be quite confusing because there may be a overlap in the clinical features between these various spectrum of etiological organisms. That is something which is worth keeping in mind. So coming to herpes simplex, now basically, because 7 minutes very short to condense everything. So the basic take-home message is that as far as the clinical manifestation, I'm making it very simple, not like a textbook kind of a description, but just to tell you in a nutshell that basically the manifestations you have to classify as two. Either there is the infective pathology. That means there is active viral infection, multiplication, and replication, which is producing the clinical features, or it is a immunological manifestation, an inflammatory response of the body to the foreign viral antigen. So basically, these are the two categories. And whichever classification system you may follow, you will still find that there are patients which do not clearly fit into any one. So practically, it hardly matters what terminology you use. From the patient care perspective, you need to define for yourself, is it a disease where there is active viral replication? And whenever you have an epithelial defect, irrespective of whatever you may think and whatever the cause may be, you have to keep in mind that if there is an epithelial defect, then you cannot rule out the possibility of active viral replication, and then you will go for the treatment accordingly. Another thing, sometimes the lesions are very easy to distinguish, such as a typical dendritiform ulcer, but sometimes it may be very confusing. It could be a healing abrasion. Often the patients may give a doubtful history of foreign body because they start feeling a symptom of some pricking or some foreign body sensation in the eye. they may attribute it to a foreign body going inside the eye, which may have happened or may not have happened. And then you may have a little distorted, markedly out of proportion lesion. There again, it may have been a foreign body which the patient rubbed. It may have been just been that the patient may have been on antibiotics, or sorry, on steroids, or may have had an immunocompromised state. So whenever you have a lesion like this also, you must consider that could it be an active HSV keratitis. And then you have, of course, various manifestations of immunological response, which could be stromal and which could be endothelial. And sometimes it can be a combination. So again, very simplified. Just remember, if there is epithelial disease, you will take it to be in active viral replication. It will be manifesting as an epithelial defect. You will give topical acyclovir. If it is stromal disease, largely it is an inflammatory. You would give topical steroids. However, I would like to add a word of caution that sometimes a stromal disease can be a melting cornea. So it may, if you have a stromal disease where the cornea is melting and melting away, it's completely sloughing off, that is a likelihood of a herpetic stromal keratitis, which is active viral replication. So barring that condition, other situations where there is stromal inflammation, it would be treated with topical steroid. And then when you have endothelial disease, you can have pure endothelial disease, but usually it will be associated with the element of uveitis. So it could be purely endothelitis, or it could be keratouveitis. So usually one would give oral acyclovir and topical steroids. So the decision you need to take is topical steroids. And if you have an overlap where you have an epithelial defect and you have a stromal disease, please do not give the topical steroids in that case. Only give the topical acyclovir. Review the patient in a day or two. Confirm that there is no active viral replication, and then only start the topical steroids. So therefore, just to give you a example of atypical manifestations now. So you have herpes stromal keratitis and endothelitis. And a positive diagnosis, one established, is very valuable. However, a negative diagnosis with the help of investigations may not always be very valid. So you can have false negatives, and the diagnosis can be very misleading because of overlapping clinical manifestations. Now, what can help you in such situation? One is, of course, your clinical response, the history. And if you're unsure, you can follow up the patient over a few days and then see which way the patient is going. But can the lab help us? One is the role of PCR and immunofluorescence. And I'd like to explain that over the years, it's not that these technologies have proven to be very beneficial, but they are useful in our experience in cases when you are in doubt. So PCR will be taking a sample of tears and looking for herpes antigen, and immunofluorescence antigen is looking for the actual viral antigen, which will be taken from corneal scrapings. So to give you our example, our experience, we looked at the presence of the DNA in the tear samples, and we also tried to see whether certain clinical features could influence whether the PCR positivity was reliable or not. So we had 59 patients where they were diagnosed cases of active stromal keratitis and endothelitis, which, as I explained, are the conditions where sometimes you are not sure and you would like to have it confirmed. And we excluded cases where pure epithelial keratitis was there because that is very clearly herpetic. And of course, the testing of corneal sensations is very useful. So we had a study group and we had controls which also included the contralateral eye of the 52 unilaterally affected patients and healthy volunteers, and tried to see whether this PCR test could be helpful. And along with the records, we also had photographs and the clinical response to the treatment. So as far as the clinical manifestations were concerned, we had, of course, the demographic features, but here again, we found that there was no clear-cut demographic feature which could help. So it can happen across age groups, it can happen across gender, it can be unilateral, bilateral. Previous steroid use also had no effect and no difference between the two groups, and epithelial defect, whether present or not. These were all the characteristics that we studied. Tears were collected from the outer canthus using both capillary tubes as well as a Schirmer strip, and I'm happy to share that the Schirmer strip was found to be equally effective, and it is much simpler to do. So you can fix it up with a lab that you can collect the tears and send the specimen to them to do the HSV PCR test. And we had the full spectrum of disorders, except as I told you, epithelial keratitis, active epithelial keratitis. And we found no significant difference between positive and negative cases in terms of age, sex, geographic location, etc. And patients with epithelial defect and without. And the PCR results came higher in patients who had epithelial involvement versus no epithelial involvement, both in terms of positivity. As far as clinical characteristics, there was a slightly higher rate of PCR positivity in patients who had a history of recurrence. And topical steroid use had a negative effect. Patients on topical steroid had a slightly lower positivity rate, but that was not statistically significant. And unilateral versus bilateral cases, higher positivity in bilateral cases. But again, this was just a trend. The number of cases was about 59, a good reasonable number. But you can see that it was not statistically significant, but there was a trend. So clinical features are not very helpful for us in determining which case the PCR is going to be helpful or not. So in a nutshell, only in cases where you have a clinical doubt, in those other cases, I will recommend that you send a tear sample for the PCR. And now looking at the PCR result and the response to treatment. So were we wrong in the patients who were PCR negative? Were we wrong in treating them as herpes simplex? That was the question. And here again, there was no difference. So therefore, it is again confirming that it is your clinical judgment which is supreme. In the doubtful cases, you will get the investigation done. If the investigation comes positive, it is helpful. If it is negative, it doesn't rule it out, and you will have to rely on your clinical judgment. Now, to give you a few examples, this is an example of a very subtle endothelitis, and this is how the patient responded to treatment. And the other thing is immunofluorescence in the tears was not that useful. Immunofluorescence testing was useful when you have an epithelial defect and you do a corneal scraping. So this is positive versus negative, active stromal keratitis. Necrotizing keratitis, as I told you earlier, mentioned earlier, it had a very high positivity rate. So if you have a necrotizing stromal keratitis, where the cornea is melting, there's a high chance of it being an active viral replication going on. So it was positive, as you see, in only 20% of cases. But it was helpful in the doubtful cases, and superiority may be low due to viral load in tear samples being less, and presence of epithelial involvement significantly increases the possibility of detection in tear samples. Just to give you a few unusual clinical manifestations again, clinical features and management in two patients who had bilateral simultaneously diffuse herpetic endothelitis, which is not so common. So two patients, they came with bilateral acute onset diminution of vision, pain, redness, and photophobia. One was a 65-year-old, the other one was a 55-year-old. Second patient had one past history of keratitis in one eye. A patient comes like this to the OPD, and I had shown you an earlier picture, and I'll show you a picture later on. You have an element of corneal edema. There is a very light pink flush and a ciliary congestion. You would actually think of primary angle closure glaucoma and uveitis. Sometimes some people may think of Fuchs dystrophy, though I wouldn't. But this is the basic thing that you would think of. So as you can see, very, very subtle features, a few Descemet's fold, some corneal edema, circumcorneal congestion. Now, what do you do in such a case? Of course, one would look at the angle, one would look at the intraocular pressure. But sometimes in herpes, there can be a borderline elevated intraocular pressure. Certainly the pupil is helpful because in angle closure glaucoma, it has very characteristic features. But in such a case, we found that reduced, and of course, Fuchs dystrophy will also be at the back of your mind because it could be a Fuchs compounded with a slightly raised intraocular pressure leading the cornea to decompensate. So that is the other possibility. The keratic precipitates and anterior chamber reaction would go a little bit maybe in favor of uveitis, but do look at the pupil. And the reduced corneal sensation, in my experience, is extremely useful because make it a habit to test, and you will find that the characteristics of the absent sensation is totally unique in patients with herpetic keratitis. So this is very useful. It seems very silly to say, but it's actually a very useful tool to simply check the corneal sensation. So we had so practically speaking, the only feature on which we went for the treatment was the reduced corneal sensations. The patient had a normal IOP and the other eye had a slight superficial opacity. Laboratory diagnosis was done. As I explained, PCR protocol was done and it was tested, and it came positive in second patient and was negative in the first patient. So again, as I said, if it is positive, it is supportive. If it is negative, it does not rule out, and you really do have to rely on your clinical judgment. Now, what is the treatment? When you're suspecting a viral keratitis, one will give the full dose acyclovir. Now, here again, whether 7 days, 14 days, 21 days, it's all very variable. Largely, we give it for 14 days, followed by BD for 12 months. Topical steroids were given, and adjunctive therapy was given as required, and both patients responded remarkably. So therefore, in a nutshell, I would say that rarely it can have very unusual manifestations. High index of suspicion is required, and PCR in tear samples may be helpful. Again, it is not something that I will recommend to be done routinely, but certainly I would like to leave it with you that if you are in doubt, it is worth considering. And you don't have to do much. You just have to take a Schirmer strip and collect the tears and see if you can get a lab which can test it for you. Otherwise, of course, you can proceed with your clinical care.
Thank you so much, Dr. Radhika. It was a fantastic presentation. Just two quick questions if nobody else has. What is the
Yes.
percentage of bilaterality in your series? Number two, what is the role of aqueous tap? Because as you said, the tear sample may not be very productive in terms of PCR. So what about the role of an aqueous tap in cases of endothelitis?
Yes. So if you see many textbooks, they will actually tell you that herpetic keratitis is never bilateral. Many textbooks will say that it is typically unilateral. However, that has not been our experience. We get around 20 to 30% are bilateral. However, they will not be simultaneously bilateral. Very rare, or less than 5% of cases will have simultaneous bilateral onset. But otherwise, we have found largely a lot of our patients will have some evidence of bilateral disease, either with a past attack or often they will be bilateral. And the second question about AC tap, this is a very important question because many times CMV keratitis, endothelitis, keratouveitis may present very similar to herpes simplex. And aqueous tap has been found to be very useful for confirmation of the diagnosis of CMV, similarly for HSV. However, personally, I feel it is too invasive a modality of chasing a diagnosis because if you rely on very careful clinical assessment and give your treatment and the patient responds to the treatment, I really do not feel justified in putting a needle inside the eye. It's just a personal, practical approach that I follow. So therefore, I would discourage people being too invasive in chasing a diagnosis. Unless it's something that is completely very mandatory to have a diagnosis, and definitely for CMV it has been recommended. But even for CMV, many of the cases we have treated empirically and they have responded. So it's a balance and a judgment call.
Bilaterality I asked because about 20 years ago, Dr. G.N. Rao had thrown a question to us fellows in the audience saying, how much is bilateral? And we all scratched our heads and looked at literature and found 2 to 10% in literature. You said 20 to 30, which is very high, which is not bilateral simultaneous, but even at different times, it's a fairly high percentage. So I'm sure you will publish it because literature doesn't, say that much.
Quite right. And the other thing is it also may be because we really see the cases, because this is a hospital based data, and we will all see the patients who have been gone through many stages and many hospitals and then finally come to us. So definitely that could be a reason why we have a skewed result. But yes, we will be publishing it.
Dr. Dipender, are you ready to present your toxic keratitis?
Yes, Dr. Uma, I am ready. So you can see the screen now. Am I audible?
Yes, you're audible and visible.
Thank you so much and warm good morning to all of you. So I'll be talking about toxic keratitis. We all deal with a lot of medication, and we do see patients who turn up with the side effects of these medication in form of toxic keratitis. Now, the drug-induced toxic keratitis could depend upon the preparation of the medication as such, and in the form of the preservatives that medication has, the pH balance, particle size of the medication, and also the concentration of the medication if it is being used in very high concentration. It also depends on the kind of medication we are using, because the inherent mechanism of action of that medication could itself be causing the toxicity. For example, it could be outrightly cytotoxic medication like mitomycin C, or it could be a medication like topical NSAIDs, which affect the metalloproteinase levels in the cornea. It could also be the direct epitheliotoxic effect of an antiviral medication. Certain corneal procedures like a betadine cautery or carbolic acid cautery, which are thankfully much less common now, could also be the cause of toxic keratitis. Before we begin and blame the medication, we should also look at the underlying pathology, the ocular surface situation of the patient. Many of these patients who develop toxic keratitis have an element of dry eye or a neurotropic element. They could be having a corneal transplant, or they could be an exposure of the ocular surface. Sometimes a Delin because of a persistent suture or any other reason could also be something which predisposes these patients to the toxic effects. One such example, if we see here, is a patient who developed drug deposits on the lower half of the cornea, which had undergone a transplant. These are the deposits of a combination of medication which was being used for this patient. He was on ciprofloxacin and sodium and prednisolone sodium phosphate preparation. This is a classical case of a drug deposit. These patients, if they are if you don't stop the medication, they can actually develop a plaque of these drug deposits, and ultimately you have to remove them and put a amniotic membrane graft on these eyes. Coming next, a typical toxic keratitis presents with lower half of the palpebral aperture being affected more than the upper half. Same is with the cornea. The area of the cornea which is more in contact with the medication has more injury in the form of SPKs, and also you see a follicular reaction in the inferior fornix. Sometimes if ignored or if not followed up, or if the patient is lost to follow up, and if he is continuing on a cytotoxic medication or a toxic medication, these patients may ultimately develop a persistent epithelial defect, and even in rare cases, they may undergo a corneal melt. Now, treatment of choice in such a patient would be first to withdraw the offending drug, improve the ocular surface by increasing the lubricant. At times, you can use a bandage contact lens in presence of a non-healing epithelial defect or a tarsorrhaphy. Rarely, if the patient is showing, if the cornea is showing signs of significant melt, you might have to opt for a Titanic procedure like a tissue adhesive or an amniotic membrane. So, as we saw in this slide, we had to resort to this is a patient who had an apophenic induced corneal melt, and he was a patient of retina detachment surgery, and he was being put on this medication for months, and he had a severe dry eye, developed a corneal melt which was not responding to a bandage contact lens or a tarsorrhaphy. And so what we did was we placed this tissue adhesive, and ultimately once the ocular surface improved, this tissue adhesive was peeled off, and the patient was put on preservative-free lubricants for a long duration. Now, other than iatrogenic causes, toxic keratitis could be because of some other reasons. This could be because of non-standard drugs. It could be because of certain home remedies that patients try. It could be because of accidental chemical injury to the eye, or it could be because of sometimes an insect-related injury. So I will touch upon, like, non-standard medications do have a wide range of some of them which could be very toxic, and they also have a very high level of preservatives. Certain home remedies which are tried by patients at home include Calotropis or Datura and also custard apple, which is more commonly used in South India. Now, Calotropis plant, the injury is usually when kids are playing with that and they pluck the flowers, and the milky liquid which comes out of it, that sap, if the child is not careful and if they touch their eyes with it, it can cause toxicity. It is an intensely toxic substance, and it not only causes a surface toxicity, but can also cause iridocyclitis, and it can also cause endothelial injury as well as glaucoma. This is a patient which had such an injury, and you can see intense amount of corneal edema, overlying epithelial defect, Descemet's folds, endothelial injury, as well as some element of anti-HMB reaction. And these patients do respond to topical steroids along with cycloplegics and the standard treatment. Coming next, custard apple seeds are often tried in some parts of South India for treatment for head lice, and they are intensely epitheliotoxic, being alkaloid in nature. They're very typical fimbriated edge, which is a classical presentation of the epithelial defect that they have. But these patients had a very high incidence of secondary infection, and therefore, unless you are very sure of any absence of any secondary infection, you should avoid topical steroids. Finally, a very common substance which is being used at home by patients is podophyllin. This podophyllin tincture is usually used to remove the skin warts. It is also being used in treatment of condyloma or the warts, molluscum contagiosum lesions, and even basal cell carcinoma. Now, if you see this patient here, he had a small wart in the lid margin, and this patient tried a podophyllin toxin and ended up with an injury. Now, this toxin is highly lipid soluble. It easily crosses the cell membranes, and it is again intensely epitheliotoxic and almost melts the cornea immediately. These patients can also develop endothelial toxicity if the amount of toxin exposure is a lot more. Treatment is again with intensive lubricants and topical steroids. We are all aware of insect-related eye injuries, and especially capillary hair, the caterpillar hair, which can cause a typical condition called as ophthalmia nodosa, in which the small stings or the barbs of this caterpillar hair, they keep on migrating inwards. But what I would also touch upon is one more form of toxic keratitis that I have noticed. This is in the form of a bee sting injury, rarely, but we do see such patients. And the toxic effect of the bee sting depend upon the location or the depth of the injury. In stroma, it will lead to edema and infiltrates. It can also cause endothelial damage. It can cause cataract and uveitis if it goes into the anterior chamber. This is an intensely painful condition, and the problem comes while we try to remove this sting, because this sting has barbs which are unidirectional. It's like a spear, and if you pull it out, it invariably leaves behind some part of the sting. And there is a cocktail of toxins in the bee sting, and these toxins they cause intense toxic response in the eye. Therefore, most of these patients will require a topical steroids, but once only we have to rule out any secondary infection, then we have to start the topical steroids along with the cycloplegics. One such case in which we had experienced the bee sting injury, and this patient had a bee sting which had gone and was projecting into the anterior chamber, and we removed this bee sting. We have to enter inside the eye, and then we have to pull it out, because if you try to pluck it out as it was done before, it got broken, and with more and more interventions, when someone tried to take it out, it just kept on traveling inside. Therefore, we had to actually go in and remove the stinger. And this was necessary because the patient had a limited response to steroids, and the keratitis was not resolving. And once the stinger was removed, there was a very quick relief, and the patient also improve, but it left its mark, and you can see the stinger here, and it has that bar appearance, and therefore it's like a unidirectional bar. So once you try to pull them out, it usually breaks. It doesn't come out in total. So this patient ended up with significant and permanent endothelial damage. His specular counts had gone down to less than 800. Thankfully, he is still holding on for past 5 years or so. But this is one such case that we wanted to highlight. So to summarize, toxicity depends on the kind of medication being used, the quality of the medication, the underlying pathology of the eye, and also at times it could be because of the outright toxic exposure of the eye to any chemicals. Thank you for the patient listening. With that, I would summarize and stop.
Thank you, Dr. Dipinder. Again, very important topic. And as you correctly said, some of the medications just continue being repeated, and often it misses the attention of the treating ophthalmologist or the treating person to review what are the medications that they're on. It's a good practice, in fact, to whenever you prescribe any medication, prescribe it for a defined duration rather than leaving it open-ended. Particularly with medications, of course, steroids, everybody is sensitized, but even medications such as the NSAIDs, because these are known agents which, if used indiscriminately, can lead to several problems. So it's always good as a practice to prescribe for a defined duration.
Anesthetic toxicity also, ma'am, is another thing. The patients can keep using topical anesthetic because it gives them so much relief. So that is another thing. If they get hold of Paracaine and they keep putting it, that can cause devastating consequences. So that also has to be kept in mind, because we use it in the OPD.
Quite right.
They can just take your
That is true. And it's better to warn the patients also, because we do not know what they are thinking and what they are going to do. So it is better to warn and educate them right at the point of contact that such medications should not be used. And it's really surprising that they should be able to get the hold of the topical anesthetic on their own, and chemists may be just prescribing it. So that's important. Good. So is Dr. Meenakshi there? I don't see Dr. Meenakshi in the grid. So should we proceed with the talk by Dr. Parameshwar?
Yes, ma'am.
So Dr. Parameshwar, Dr. Parameshwar may share the screen, and this is another very important and an area which we're all looking forward to hear on corneal collagen cross-linking in corneal infections.
Okay, am I audible to all?
Yes, it's very clear. Please go ahead. And your screen is also visible. You can just put it on slideshow, and your audio is good.
Okay, thank you everyone. At the outset, I'd like to thank Delhi Ophthalmic Society for giving me a chance to talk to you all. So let's learn about a case. This was a 50-year-old lady who came to us with this kind of corneal infiltrate, which was secondary to vegetative trauma. Infiltrate was of around size of 7 to 8 millimeters. We did scraping and debridement, and we found out that it was fungal in nature. We had planned to start the patient on the antifungal treatment, and in my OPD, I generally follow patient on every alternate day. But patient said to me that, sir, I'm from a 200 kilometer far off distance, and I cannot come to your clinic every alternate day. So then we thought of doing something else to the patient, and then I offered collagen cross-linking to the patient, and patient agreed. And in the lower picture, you could see this was the picture after 3 months, and she had a best corrected visual acuity of 618, and there was a very minimum scar. So this was practically a magic of collagen cross-linking. Then we, when we learn about the history of collagen cross-linking, Wolensek was the first person in 2003 who proposed such kind of a treatment, but evidence of treatment effectivity by a 5-case series by Israel et al. In 2008, and thereafter a flurry of studies by Vadirani et al. And Carter et al. And et al. Proved that it was really an effective kind of a treatment. Aloe Italy in 2013 first time coined term PAC-CXL, and this was later accepted in 9th annual conference of collagen cross-linking in Dublin in 2013. So how does it work? It actually works on a Bunsen-Roscoe rule, which says that while maintaining the total energy, absorption of light intensity is directly proportional to the time of irradiation. So we all know that the amount of energy that we can apply on the cornea is constant. So if we increase the duration of the irradiation, then the effectivity of the linking increases in killing microbes. So what is the mechanism of action of the cross-linking? So mechanism of action is on two ways, one on cornea and another on the microbes. So if we learn on the what happens on the cornea, the cross-linking actually induces morphological change in the corneal stromal collagen matrix, which reduces the corneal melting, and cornea becomes more resistant to enzymatic digestion and the edema. Corneal strength is enhanced. Cornea becomes resistant to deeper penetration of fungal hyphae, and cornea becomes more resistant to the microbes. Also, there is decreased production of alpha SMA by fibroblast, thereby causing less corneal scar and improved final best corrected visual acuity. Also, the neurodegeneration and neovascularization of the cornea is reduced. There is improved wound healing, and there is a reduced corneal nociceptive response. That is, the pain of the patient decreases dramatically and patient becomes more comfortable. There is enhanced healing, and there is enhanced corneal surface reepithelialization. Riboflavin itself is an anti-inflammatory agent which reduces inflammation in the cornea, and riboflavin inhibits WBC recruitment, further WBC recruitment of the cornea, thus causing further anti-inflammatory action. If we study mechanism of action on the microbes, ultraviolet A rays cause direct damage to the microbes. They also reduce microbe replication. Riboflavin induces conformational changes in the components of the microbial cell wall, which increases its senescence. That is, the life cycle of the microbes becomes faster and they die faster. Riboflavin also decreases the cell size and increases the cell toxicity. The nucleic acid of the microbes gets damaged by generation of the free oxygen radicals by riboflavin, and thus the death of the microbes is enhanced. In case of fungal infiltrates, the fungal biofilm, which I'll talk about in detail later, is broken, and it enhances the effectivity of the antifungal agents. Post PAC-CXL corneas become impenetrable to the toxins released by bacteria and the fungus. So if you study what is the role of how does PAC-CXL acts in fungal keratitis, we all know that fungal keratitis is important cause of blindness in both developing and developed and developing countries. Most common species that we see in our Indian setup are Fusarium, Aspergillus, and Candida. When we look at when we did an audit of fungal infiltrates, and we found out that the fungal infiltrate was fungal keratitis treatment was very long, costly. It had involved multiple follow-ups, and in our audit, we found out that an average fungal keratitis patient needs around 1 month to 1.5 months of total treatment, 15 to 20 follow-ups. If a patient is coming to us from a 50-100 kilometer distance, his actual cost of treatment crosses 30, 40, 50,000 sometimes. So, and many of the times medical treatment is always may not be that effective, which actually keeps on increasing the cost of the treatment, and patients become frustrated and they cross from one doctor to another, and then it's actually a vicious cycle. And then uncontrolled infection may lead to corneal perforation and the spread to other parts of the eye. And many of the patients, they require corneal transplantation, which has got its own set of long and short-term complications. And then again, availability of the donor cornea may be an issue. So why we need to understand that why fungal keratitis treatment is difficult. Fungal keratitis, actually what happens is like fungus, they exist in a biofilm, which actually is like fungal cells get encapsulated in a protective and impermeable extracellular capsule. So it requires much higher doses of antifungals to break this biofilm and kill fungi. But at the start, antifungals, they have got very poor penetration into the cornea, and which coupled with fungal biofilm actually makes the treatment very difficult. Also, fungus fungus is very notorious to penetrate to the deeper 1/3 of the stroma and in the anterior chamber, which makes the treatment still more difficult. So what happens in PAX-CXL is that PAX-CXL creates hostile environment for the fungus by inducing keratocyte apoptosis. There are two kinds of riboflavin agent that you can use, 0.25% and 0.1%, but studies have showed that 0.25% riboflavin has yielded better results. Ultraviolet A rays can, with riboflavin, can effectively kill fungus. In studies, we have found studies state that number of fungal colonies after collagen cross-linkings have decreased. Need of the therapeutic keratoplasty is decreased, and the final best corrective visual acuity has improved. Amphotericin B, 0.1%, actually causes transmembrane channels in the fungal walls by interacting with the sterols in the membrane. Thus, the penetration of riboflavin in the fungal cells has increased, and it has been found out that amphotericin B has got a synergistic effect with the collagen cross-linking. In our studies, we routinely have advised amphotericin B 0.1% eye drops in patients who have undergone PAX-CXL, and we have got very good results. Also, voriconazole has been found out to have a synergistic effect, but natamycin has not been found to have a synergistic effect. There are some contrary results, as our previous eminent speakers have spoken, that there are perforations and other complications of cross-linking. But once we went through this literature, we have found out that in these patients where there was a perforation of the cornea, the application of cross-linking was at a very later stage, when there were patients were resistant to all other medical therapy, and the infiltrate was involving in the deeper third of the stroma. Some other complications which were not that threatening were recurrence of the HSV infection, but HSV could be treated easily. If we study, if we think of PAX-CXL for bacterial keratitis, generally bacteria, they respond much better to the antibacterials. Antibacterials have got a very good penetration in the cornea. So we have very rarely needed cross-linking for bacterial keratitis. But in case patients who had lack of compliance, adverse socioeconomic factors, where patients who we thought that they were going to be lost to the follow-up, we advised them promptly PAX-CXL. And then also when we in our OPDs, what we do is like we do antibiotic sensitivity to all the bacterial ulcers, and when we saw that patients had a very broad spectrum antibacterial resistance, enhanced broad spectrum antibacterial resistance to the bacteria which were very resistant to even linezolid and imipenem, piperacillin for that matter, and then we promptly advised PAX-CXL to those patients. And we actually followed Dresden protocol, that is 3 milliwatt per centimeter square for 30 minutes. Although in literature studies there is no protocol has been standardized, but this Dresden protocol in our settings has been quite effective in treating all the bacterial keratitis patients. We have seen in our studies that gram-positive bacteria are more likely to respond to cross-linking than a gram-negative bacterial infection. We also went through the literature in our settings that how does PAX-CXL make an effect on keratoplasty outcome. Keratoplasty, when done for an active infection, may require large grafts and is often complicated with early graft failure. Then many of these cases undergo second optical keratoplasties. But keratoplasty, when done for a complete complete resolution of the infection, which is more likely of after PAX-CXL, the graft size that is required is going to be more smaller. Graft rejection, both early and delayed, are very less. And especially this effect has been specially found out if keratoplasty is done 1 year after the complete resolution of the infection. There have been very limited studies about PAX-CXL used in acanthamoeba. Authors have said that it can eliminate both cystic and active forms, but because of very limited studies, it's difficult to comment on its effectivity. In our experience in my clinic, in my own hands, we have done 14 cases at our center. All cases were mild to moderate cases. None of them had involved deeper third part of the stroma. All cases, PAX-CXL was offered as a first-line therapy. 11 cases were purulent fungal cases, 2 bacterial cases, gram-negative case, and 1 was a no cardiac case. All cases showed faster resolution of the infection, faster reepithelialization rates, fewer need for follow-up, fewer medications were needed, early resolution of the symptoms was seen, lesser complications such as corneal melt and perforation, no secondary interventions such as glue BCL, and none of them had to undergo therapeutic keratoplasty. Only one patient in our case had developed endothelial decompensation because patient was slightly had patient to begin with had early corneal melt, and I think that because the corneal thickness slightly lesser, he developed endothelial decompensation. But in that patient, vision was not an issue because he had a painful kind of a blind eye he had, and after the this thing infiltrate was totally resolved, we did stromal puncture for the patient, and patient is enjoying a good cool eye, no other symptoms. We found out that final best corrected visual acuity was very good. There was very less scar and there was very less opacity. We always use Dresden protocol, that is 3 milliwatt per centimeter square. Only thing is that higher initial cost was a very limiting factor in this our scenario. So what we recommend to all our colleagues is that we should offer Pac-CXL as a first line therapy to all our patients and follow up it with required antibacterial antifungal agents. Thank you very much. If there are any questions.
Dr. Parameshwar, I would just like to ask you, how many days after presentation did you offer this treatment? Did you offer it on the day of presentation or after a while?
See, once nowadays what we are making is once patient walks into our clinic with some kind of an infiltrate, we do thorough checkup of the infiltrate, whether it's bacterial, fungal, etiologic agent, and then we assess how the economic condition of the patient, from how far distance patient is coming to me. Sometimes patient come to me from 200 kilometers and all. So when we feel that compliance to the treatment is going to be a problem, or the antibacterial or antifungal are not going to be so effective, which actually has come from my own experience, we are straight away offering cross-linking to the patient. And we have actually decreased, we have made kind of a adjustment with our the machine providers, that we are offering cross-linking as little as 10,000 or 8,000 to the patient. So the initial cost factor is also going down. So our the therapy number of therapies are going up, and the more number of therapies that people are accepting, once we tell the counsel patients properly that these are the benefits of it, patients have actually patients are giving a positive feedback and they accept it. So I would suggest that
we are doing a thesis as a randomized control trial, and we have said that 7 millimeter infiltrate and 2/3 depth, as you said, not deeper than 300 microns.
Yeah.
So what were your protocols? And Dr. Jaya has a question. Which riboflavin did you use?
See, I'm using ribocross riboflavin. It is it comes in two concentration, 0.1% and 0.25%. We have asked company, this Sunways company, to give it 0.25% concentration to us. And what happens is, like, see, what we do is the depth of the infiltrate is very important. Some infiltrate which goes up to the descemetes or it involving posterior 2/3, we are actually apprehensive about it. Although we do cross-linking for those patients as well, the long-term the results are not as good as those patients who have anterior 2/3 of the stroma. If we think about how much surface is involved, actually surface does not matter. We have seen 8-9 millimeters of infiltrate, surface infiltrate as like working as any other infiltrate. Only depth is a concern. The more deeper you go, more actually the effectivity goes down. So this is how we do it in our cases, in our studies. Hello.
Thank you, Dr. Parameshwar. I also have two questions, if I may ask.
Please.
One was that you did mention that you have used amphotericin B as an adjunct. So this data of the 18 patients that you mentioned, in all of them you used amphotericin B. Were they drops? Were they prepared freshly from the vial, or which type of? And did you use liposomal amphotericin B? Which amphotericin B was it?
after we know fungal keratitis, most like patients who have undergone cross-linking, we have always used amphotericin as a drops. We have it in our pharmacy, we use it. Those are liposomal drops. We prepare freshly in our pharmacy. I personally do it. I take a lot of care to personally do it. I don't even ask my assistants to do it. I do it myself, and that's how we are getting. We started giving amphotericin B after reading an article which said that amphotericin B could have a synergistic effect to the cross-linking, and we are getting very good results about it. And
yes, that is good. And second point was the in comparison, because you said there was faster epithelialization, faster healing. So did you have a control group for comparison, or faster compared to what? Or was it the patient's own response before and after cross-linking? What did you find that it was faster in comparison, and was it statistically significant?
See, what we have done is we have got, I have a very good infective OPD. So we have not actually randomized the patients, but the patients who refused to undergo cross-linking, when you come across the clinical experience of how patients are behaving in a cross-linking group and in patients who have not undergone cross-linking group, we have seen that the recovery is much better in patients who have undergone cross-linking rather than patients who are taking only medications. So that's
fair enough. I think that's a reasonable assessment. So it was in the clinical impression that you got. And since you have this very useful data, if you have the information available, you can compare it with the group, you can compare it with the data of patients who did not opt for the treatment. It may not have been a randomized control trial, but it can be a comparative series that will have more, it will help other people in taking a decision as to which cases to advise, and it will help everybody to have the objective comparison. So I think this was a...
We are actually... We're actually going...
Sorry, go ahead. Go ahead.
Hello. We are actually going through our records, and we are coming up like a study, like a case control study or a retrospective study, where we could assess what happened and how the results are beneficial. Maybe sooner or later we'll finish the data collection, and then we'll think of publishing it.
Because this is hard.
Yeah, for example, I also found it encouraging that you also use liposomal amphotericin B. We have been using liposomal amphotericin B in 2 MD thesis till now, and it is a good option. We're just about to send it for publication. So this is an option which is also something which is worth considering. Yes, Uma, you're saying something?
Dr. Radhika, the studies from Aravind actually said poor results in fungal keratitis. This is heartening to know that they have had good results. Because so far,
you see, Uma, just like the previous question about bilateral keratitis, stromal viral keratitis, to explain, for example, my statement was related to that particular study where we excluded routine epithelial disease and all that. So the Aravind study was also, yes, it was a good study where they did cross-linking, and they had it a subdivision. So they had seen in the subdivisions, in fact, they had found that amphotericin B was as good as natamycin as a medical antifungal. However, in that study, they have not specified which type of amphotericin B they used, whether it was liposomal or not. But yes, so two good things from that Aravind study. One is that in the sub-analysis, natamycin was equally good as amphotericin B. But in terms of the cross-linking being useful, that has not been shown conclusively. So here, and often, it is true that an RCT is a gold standard, but it is after all an artificial experimental situation. And truly speaking, in the real world, often there may be some data which may be indicating otherwise. So it's very complex. Research is very complex, and the interpretation of the results are only valid in the context of that experiment. So certainly we try our best to be as mathematical and as objective, logical, and scientific as possible. But then in actual patient care, one has to realize that there are a lot of nuances, and in the true implementation of the study findings, it is actually only relevant for that particular subset of patients, etc. But certainly this is an area which is good to keep people's mind open, and the more systematically one does the study, the better it is. But there are many concerns because patient is a human being, and also there are a lot of real world situations where you may not be able to follow the protocol exactly. So definitely one needs to do more studies and look at more results. In terms of cross-linking for infective keratitis, it still seems as if it's this way or that way, and it is not very clear which situation you should do it. As Dr. Parmeshwar tried to explain, there were this particular subset of patients where they were probably not going to come for follow-up. But one has to be very careful. One really has to be very careful, because the way things are going, people always want that everything we do should be supported by literature. It should be answerable in court of law. All these things have to be kept in mind. So if one is doing any such procedure, one should take proper consent of the patient, take the patient into confidence, explain that this is something which is, if you go to different doctors, they'll give you different answer. But this is, you've come to me and this is what I feel and this is what we are planning to do, and you are part of the process. So I think that is a sensible way, and I would suggest people that if they're trying any of these newer modalities, you must take the patient into confidence that this is what the situation is. So can we go to the next lecture, which is another very important one? Uma, is it okay to go ahead to the next one?
Thank you, madam. Thank you.
Yes. So we will now have Dr. Pranita Sahai on corneal gluing. Again, something which is very important in the armamentarium of treatment modalities for infectious keratitis. Dr. Pranita, please.
Good morning, everyone. Thank you, ma'am. Good morning, everyone. This is Dr. Pranita, and I'll be discussing on the topic corneal gluing. So the use of corneal gluing dates back to 1968 in ophthalmology, where Webster et al. First described its use for perforated corneal ulcer in 2 cases. So it has been used for almost more than 5 decades. So the 2 types of tissue adhesives that are available commercially are the synthetic one, that is the cyanoacrylate, and the biologic one, which is the fibrin glue. The cyanoacrylate glue are esters of cyanoacrylic acid, and based on the difference in their side chain have different adhesive properties. The N-butyl cyanoacrylate is the most commonly one that we use in our practice. It is a clear fluid, but often a blue colored dye is added to it for better visualization during the surgical procedure, and it polymerizes as it comes in contact with water. The other one being fibrin glue, which is, although US FDA approved for cardiothoracic surgeries, its ophthalmic use is off-label. The initial version which was used was a bovine thrombin, but with the risk of allergic reaction and infection transmission, it was replaced by human thrombin. And the mechanism of action is similar to blood clotting cascade. While the cyanoacrylate glue does not need any preparation and is directly loaded and applied on the ocular surface, fibrin glue comes in different component which needs to be prepared right in the OR before taking up the case, and takes a little bit of time for preparation, and is finally loaded on this duplet injector system and then applied on the ocular surface. So it has 2 components, the component 1 which has fibrinogen and aproteinin, and the component 2 which has calcium chloride and thrombin, both of which in combination together act as the glue. The major indications being small corneal perforation, which is less than 3 mm, and severe corneal thinning and dysmetocele. But the emerging indications are amniotic membrane transplant and limbal stem cell transplant, also anterior lamellar keratoplasty, that is SALC. So the cyanoacrylate glue has the major advantage of having a good tensile strength and is cost effective, but the major disadvantage with it is it induces a lot of ocular surface inflammation and therefore results in neovascularization in the process of healing. Also, it does not dissolve, so it persists on the ocular surface for a longer time compared to fibrin glue. On the other hand, fibrin glue induces less inflammation, dissolves with time, but has poor tensile strength and is also very expensive. In general, the procedure is performed under sterile conditions in an OR with the patient lying supine under an operating microscope under topical anesthesia, but it can also be performed on a slit lamp. This is a small surgical video showing the tissue adhesive application in a case of a desmatocele. So you can see this blue tinged fluid, which is the N-butyl cyanoacrylate. It comes in a 1 ml vial, costs around 800 to 1,000 rupees. It is loaded onto a tuberculin syringe, a 1 ml tuberculin syringe. And next we can see that the patient is clean draped and a speculum is applied, is under topical anesthesia and is lying supine under an operating microscope. With the help of a Merocil sponge, the surface is dried, the surrounding epithelium is debrided for better adhesion of this cyanoacrylate glue. And next, the same Merocil sponge, the other end can be used for taking up a drop of glue, which is then applied onto this dried up surface. And after this, the glue can be spread with the help of a Merocil sponge to the surrounding surface to prevent formation of a mound. But we should be careful that a Merocil sponge, though being safe, use of a cotton sponge can be dangerous because the cotton fibers also tend to get entangled onto this rapidly solidifying tissue adhesive cyanoacrylate glue. Following this, BSS should be applied. That also hastens the process of solidifying of this tissue adhesive, and then the ocular surface needs to be washed to avoid any toxicity. And at the end, a bandage contact lens is applied for the patient comfort, or else it can lead to giant papillary conjunctivitis and severe inflammation because of the rough surface of the cyanoacrylate glue. But often in cases of perforated corneal ulcers that present to our OPD, we do not have the time to take the patient to the OR, and the procedure can be done on the slit lamp. This was a case of an operated VR surgery with a neurotrophic ulcer. Although initially showed good response to medical therapy, a central gutter persisted and ended up in a small perforation. Seedles was positive and the anterior chambers were formed. Hence, we decided to not waste any time and proceed with tissue adhesive application on the slit lamp. So you can see a speculum has been applied very gently, and the surface was dried again with a Merocil sponge. Surrounding epithelium was debrided, and with the help of a 30 gauge needle, a drop was gently applied on the site of perforation and guttering. With the first drop, we could see that after a few seconds it did solidify, but the central gutter did persist. So I decided to put upon a second drop of tissue adhesive. However, when you apply a second drop, there is always a risk of formation of a mound and mound formation leading to an irregular surface. So it is important to spread the glue out into the surrounding surface to avoid a mound formation. And after waiting for a couple of minutes, you will see the shining surface of the glue, which has started to dry up from the periphery to the center. And after waiting for 2 minutes, when you see this shining surface, dried glue, a bandage contact lens can be applied. So this was the direct application method of cyanoacrylate glue with a cannula or a needle. The other method is a plastic disc or a patch technique with the glue, wherein I'll show you a video to demonstrate the same. So in this patch technique, you use a small 2 mm trephine to trephine a circular disc of a plastic drape, which is the non-adhesive part of the plastic drape. And after obtaining the circular disc, as you can see here in the video, multiple discs have been obtained here after cutting the drape. And you use a Merocil sponge plastic. You can even use an iris repositor, on the surface of which an ointment is applied. And to this ointment, the drape patch will now stick very well. On the surface of this drape patch, now a drop of cyanoacrylate glue is applied, and this whole complex is now gently touched upon the site of perforation, and the patch and glue both sticks well. So the advantage of this patch technique is that even in cases with a slightly larger perforation, maybe 2 to 3 mm, where you are in doubt that a direct application may not cover up the site of perforation, the patch technique will work well. And also you will have a uniform smooth surface, and the mound formation, which is a risk with direct application, can be avoided with this technique. In post-operative treatment, antibiotic and cycloplegics are must. Anti-glaucoma also is helpful as it keeps the IOP on the slightly lower side, avoiding the risk of leak from the edges of this glue site. Steroids is controversial. In cases of infected ulcers, you need to be cautious, but in sterile melts and neurotrophic ulcer, definitely steroids should be given, as it reduces the inflammation that is incited by the cyanoacrylate glue application. The patient needs to be warned that the follow-up will be for at least 3 to 4 months because the glue persists till then, and the BCL needs to be replaced every 4 to 6 weeks, considering the risk of infection due to biofilm formation. Now, other than the tectonic support that we get from the cyanoacrylate glue, it also helps in corneal perforations by arresting the stromal melting process. By preventing the epithelial collagenase from reaching the stroma, it also acts as a barrier from the inflammatory cells and itself has bacteriostatic activity. So this was a study by Sharma et al. Wherein fibrin glue was compared to cyanoacrylate glue in cases of corneal perforation, and the healing rate at 3 months, you can see, was almost comparable in the two groups, almost being 79 and 86%. However, the major difference was that the deep corneal vascularization and GPC was much less with fibrin glue compared to cyanoacrylate glue. But the major advantage with cyanoacrylate glue was that it was the cost was less than 1,000 rupees, so it was cost effective and provided good tectonic support. Other than cases of corneal infections, it can also be used well in cases of corneal perforation secondary to trauma, especially in cases of small circular perforation. As you can see in this image, the patient presented with trauma with a metallic wire. After removing the wire, there was a small circular perforation in the cornea, which was sealed well with the cyanoacrylate glue. In such a situation, applying sutures can lead to unnecessary astigmatism and also poor wound apposition. So this is a picture showing the 2-month post-op of a BCL glue for a perforated corneal ulcer. You can see the ulcer has healed well, but the cyanoacrylate glue is still sticking onto the surface. This is a 4-month post-op of BCL glue for a perforated ulcer. You can see that the glue has dislodged, but there has been aggressive vascularization. So this can be prevented by early installation of steroid drops in this patient, if is possible based on the case. So to conclude, tissue adhesives work well in small perforations less than 3 mm, and there are emerging indications for other than corneal perforation, including SLET, EMT, SALC, Desmetocel. Cyanoacrylate glue provides good tectonic support and is cheap, and fibrin glue induces less inflammation but is expensive. Thank you. With that, I'll come to the end of my presentation.
Thank you, Dr. Pranita. Very nice presentation, very useful videos and practical tips. And this is an important topic, particularly at the time of COVID pandemic, when there was a shortage of donor tissues. Many cases which required patch grafts were actually treated in many places by using glue. So it turned out to be very useful, alternative, and certainly the videos were very nicely demonstrating all the best practices to be followed when using glue as a savior of the eye. We do have 3 more presentations, so I would advise that now we can proceed with each talk. Unless there's any comment, which Uma, let me just check if there's any chat related to Pranita's talk. No. Okay, so we can go ahead with Dr. Sudesh Arya. Thank you so much, Dr. Pranita. That was really a very nice lecture. So we go ahead now with Dr. Sudesh Arya's talk. Dr. Sudesh Arya will be covering management of peripheral ulcerative keratitis. Dr. Sudesh, please.
Dr. Radha, am I audible?
Yes, yes, very nicely and clearly.
Thank you very much. Good morning, everyone. First of all, I'm really thankful to DOS for providing me this opportunity for this presentation. So I'm going to speak on current concepts in the management of peripheral ulcerative keratitis. As we know, PUK is a very broad spectrum entity. So there can be so many situations where it is very difficult to diagnose. Like this was a young adult male who presented to us with bilateral sclerokeratitis. So you can see there are lots of exudate on the infranasal part of both corneas involving limbus as well as sclera. So if you try to diagnose this condition, I think it will be very, very difficult to diagnose what it is until you go spatial and further investigate this patient. So we may think it may be infective, but ultimately what evaluation of this patient, and there was some systemic history, and on angiography we could see that in the left there was so much ischemic retina. So it was totally half of the retina was knocked out. And further, when we evaluated the patient, there was CT angiography showed left subclavian and the carotid artery occlusion. So that means this patient was fitting into vascular disease that was Takayusu sclerokeratitis, and that was proved, and it was published also. So we just gave systemic treatment, and the patient was managed systemically by the cardiovascular cardiologist, and then ultimately patient improved completely. So if you don't do systemic investigation these types of patients, then definitely you cannot manage these types of patients. Similarly, there was another patient having this type of ulcer on the periphery over the limbal area, you can see. So it will be very difficult to see what it is. But again, this patient was having pulmonary tuberculosis. So we thought that then it could be fascicular ulcer, and then a systemic ATT was given by the pulmonary department, and we gave topical steroid, and then patient improved completely. So basically, PUK, it is a diagnostic challenge because it is of multiple and varied etiology. Usually it is of destructive nature. All the lesions, they are very rapidly progressive also. So if there is an inaccurate diagnosis and inappropriate and inadequate therapy, patient may go blind also. So that's why this is a very important clinical entity. But actually what the PUK is, so it is a destructive lesion of the juxtalimbal corneal stroma, which is associated with stromal degradation. Stromal inflammatory cell infiltrate leads to progressive stromal thinning with or without associated epithelial defect. So this epithelial defect is not a must. So usually it progresses very fast in some patients, and it may lead to perforation and even blindness if not managed appropriately and timely. So what is the cause of this problem? So basically, main thing is immunological machinery for all immune response, especially on the Langerhans cells, which are on the periphery of the cornea. So there is a complement activation in the limbal area and leading to further this inflammatory process, which leads to all these problems. So if you go into the etiology, there is a long list. So broadly, we can see there can be ocular infections, which can be of any type, bacteria, fungus, virus. There can be systemic infections. Then there are non-infectious, big variety, where we can have Moran ulcer, that is the most common. Then occasionally we can have TMD and PMD. So these conditions, then other condition can be there. In the non-infectious, systemically, we can have very important rheumatoid arthritis. Then there can be Wegener's, polyarteritis nodosa. So basically all these collagen vascular diseases, they have a very big chunk of PUK. Otherwise, there can be so many other conditions. So I'm just going to go through various conditions which we saw in our clinic. So this was like patient having this peripheral ulcerative colitis due to Moran ulcer. So young patient having bilateral painful problem, and it was undermining of the edges and going from almost more than 1/3 of the cornea. So it was bilateral as well. Similarly, Moran ulcer can present in very devastating way also, like this patient came to us with almost total melting of the cornea. So sometimes Moran not only progressive circumferentially, but also it goes on the periphery also and may go into the central part also. So like this patient, and ultimately, because these patients, if they come late and treatment is not given at proper time, then this type of problem can happen. Even the keratoplasty also may not help at this stage. So Moran is very common condition. So rheumatoid arthritis is another condition which we see so commonly. So like this was a young lady who presented with total melting of the cornea. So she had systemic features, all systemic features of rheumatoid arthritis. So ultimately this patient underwent therapeutic penetrating keratoplasty just to save her eye. Rheumatoid arthritis can present in some other ways also, like sclerosing keratitis, like this was typical near the limbal area, sclerosing keratitis was there. Sometimes we have seen patient coming with perforation also, like this was a 40-year-old female. She came with this perforation and she was having this rheumatoid arthritis. So these patient, if it is a small perforation, one can go for glue and bandage contact lens immediately, or maybe patch graft, that also may be required. Another very serious condition is Wegener's necrotizing peripheral ulcerative colitis. So here you can see like this patient was having lot of corneal thinning, corneal involvement, as well as sclera, and you can see all this sclera, they are thinning area. In fact, multiple perforation sites are also there. So these patients, they require systemic treatment very vigorously and topical treatment as well. Only then you can save their eyes. So this is another very uncommon entity which we saw in our clinic. This was patient having this multiple pigmentary patches over the face and the body, mainly over the face, and he was having this total melting of the cornea of the right side. Similarly, he had some healed lesion, opacity in the left eye as well. So this patient turned out to be porphyria cutanea tarda, which is a very rare condition involving cornea and the sclera because of porphyria. And the treatment will be, if you control the porphyria systemically by hematologist, only then this condition will improve. Otherwise, whatever you do, it is not going to improve. So that is the lesson that we have to evaluate these patients systemically. Steven Johnson again is a very common condition, so they can also present with PUK, like this patient having ulceration on the periphery and center also, so they can have lesion anywhere over the cornea and periphery as well. So sometimes like this young female, she was a contact lens user, she developed infection on the upper part of the cornea, and ultimately when she came to us, there was perforation as well. So immediately we just glued and applied bandage contact lens. So luckily she became all right. Just like we discussed in another talk, toxic keratitis, so bee sting is very common. So we had, in fact, 2 children, they had this bee sting on the periphery of the cornea. So ultimately this sting has to be removed, and then treatment for toxic keratitis as already discussed in this session. So that has to be done in these children. So there are another patient, again, it was bee sting and having toxic keratitis. You can see whole of the cornea is totally, whole of the endothelium is null. So because of that, there are lots of folds and total edematous diffuse corneal edema is there. So these patients, again, we have to start treatment very vigorously. So marginal keratitis, again, very commonly we see, so like staphylococcus, they can have very small round lesion on the periphery, and then not only infective, but it can be immunological response as well. So these are also very common. So we had one patient who had this history of radiotherapy, and he came to us with this thinning and the perforation just near the limbus. So it was almost sort of melting of the cornea near inferior limbus. So we asked the history, there was history of some radiotherapy for some tumor. So ultimately we had to go for therapeutic graft immediately in this patient. So there are other non-infectious conditions as we discussed. So pellucid marginal degeneration is very common condition. So one can diagnose very easily by pentacam nowadays. Clinically, we will see there is a thinning and a bulging in the center, and there is no vasculation, and there is no lipid deposition, and epithelium will be intact in these patients. So that is very important. And similarly, there is another tearings which usually happens on the upper part of the cornea. So normally they do not perforate, but rarely they can also perforate. Like this patient was having this problem. There was marked thinning and iris was just attached to the cornea. It was just impending perforation. So these patients, they also need very large graft and immediate management. So whenever we make a diagnosis of PUK, so our first thing should be, what is that diagnosis, systemic diagnosis. So that's why there is a long list of investigation. So first of all, we should try to make some clinical diagnosis on seeing the eyes. Then after clinical evaluation, then we should make some clinical important systemic diagnosis. Then accordingly, we should advise the investigation. We cannot advise all these investigation in all the patients. So we have to have some clinical knowledge, some history, good history, that is very important. So by that, we may be able to know that maybe this is a connective tissue disease, or this is some disease in which we should go for those investigations. Otherwise, if you don't get these investigation, so even if you may be able to treat the PUK, but systemically he may have some problem, and ultimately he may have serious problem for his life also. So that's why it may be a very clue that there is a PUK, so we must rule out some systemic disease in the patient. So then what are the management principles? So basically there is a stepwise approach to all these patients. So first and the foremost thing will be the topical steroid and the systemic steroid. So that is very, very important. So even if there is a ulcerative keratitis, so normally we may be scared that it may be infective, so we should not go for steroid. But we should be very, very careful that if it is a PUK due to some systemic disease and it is non-infective, so that by experience we can know that it is most likely non-infective. Then if you do not start steroid, then there will be no improvement. So that's why steroids use at appropriate time, that is the most important thing. And then in certain situations, systemic immunosuppression, then few surgical procedures, they may be required. So topical steroid, I will say that is the first line of treatment for all these patients. Like Moran ulcer, if diagnosis is Moran and we are not giving steroid, then we are doing a criminal sort of thing. So patient is not going to improve at all. So if you give steroid, patient will have dramatic response. So there may be patient where systemic steroid we may not be able to give, or there are some other complications or contraindication. In those situations, if it is a very severe Moran ulcer or some severe grade of PUK, their immunosuppression also, they are very, very important for treating these patients. So that is another role. Usually cyclophosphamide methotrexate, azathioprine. So these three drugs, any of these can be used in this patient depending upon the type of the condition patient is harboring. Then, of course, topical treatment like prophylactic antibiotic has to be given. Then cycloplegic, all those sportive treatment that has to be given, anti-glaucoma. So that is for any type of ulceration over the cornea. But that was the specific treatment. Then coming to the specific surgical management, so conjunctival resection is very, very important. Similarly, keratoepithelioplasty, like patient has got Moran ulcer. So if you do conjunctival resection and if you do a little bit cautery, then definitely these patients respond very fast. So do conjunctival resection and start topical steroid and systemic steroid, ruling out a local infection. These patients, they respond very, very well. Similarly, some patients, they have iris prolapsing outside. So these patients, they will be better if you do patch graft also. So like this patient underwent patch graft. So in these patients, if you do patch graft timely, then they will have even good visual potential as well. So you can see these few patients where we did good patch graft and patient had good vision post-operatively. So there are a few other surgical techniques also, they are coming up, like a copy and fix technique, although we have not done, but this is a very simple technique where we can mark the host cornea, then take exactly same tissue from the donor, then you can suture it. So that is a very good copy and fix technique recently described. Similarly, tuck-in lamellar keratoplasty, again, Dr. Vajpayee, he does lots of surgery in these types of patients where you can do this lamellar surgery and there is a tucking of the graft on the recipient. So that holds graft very well and there are good results. The astigmatism part, that also will be less. So for a larger graft, this is a very good technique described. So there are a few newer treatments also, although they are being used already, but they may play a lot of role in these PUK patient, but being very costly, so they are not so commonly used, like rituximab, then infliximab, they are off and on, they can be used. But tacrolimus is very commonly available nowadays and it's very useful tool. So that can be used in few patients. So like in our department, in last 4 years, we saw lots of patients with PUK. So we just saw the demographic profile. So we could see in our setup, we had most of the patient having rheumatoid arthritis with PUK. So that is very, very common condition. So that is without being referred by all the rheumatologists. So this is patient routinely coming to us. And then Moran ulcer is another very common condition. Then infective like tuberculosis, herpetic, so they also can have. Then like vasculitis, Wegener's, Takayasu, Terence, Pellucid, then bee sting. We had two patient who had steroid-induced melting of the cornea also. So then post-SICS porphyria, so there can be unusual conditions also. So one should be always aware that there is a PUK, so what can be the systemic diagnosis? So I will say PUK, it is a spectrum of corneal disorders. If you do thorough investigation with the multidisciplinary approach, then definitely if we do surgical and the medical treatment timely in these patients, we can give fairly good visual outcome in this patient, not only cosmetically, but visually also. So we have seen if you do especially surgical part very timely and give a topical steroid and other treatment required, then definitely these patients, they behave very well and you can give very good visual results. Thank you very much.
Thank you very much, Dr. Sudesh. It was a very beautiful presentation, lot of good clinical scenarios and practical knowledge about the current concepts on a very important topic. And you correctly emphasize at the moment you see a PUK, one has to be very meticulous in looking for systemic disease, and then one should not just blindly start the steroids. Be careful what you're treating and beware that sometimes there can be infective pathology. Thank you so much. Since we have still two very important talks and we're running out of time, so we will not have any questions now. If there's any question, they may please put it in the chat and then we will take it up at the end. The next topic is again a very important area with respect to infection following graft preparation for DSEC. Dr. Jaya Gupta, will you please start? And thank you for patience in waiting for your turn.
Thank you, ma'am. I'll start my screen share.
Jaya, your voice is very clear. We're just waiting to see your screen.
Yes, ma'am. Yes, ma'am. I'm just putting it on.
Yes, we can see the screen now. Good.
Yes, ma'am. So I have a very short presentation, but I'll just be sharing my experience of Candida interface keratitis following TSEC, our experience. So I'll be presenting two of my cases. The first case, a 75-year-old male diagnosed with pseudophakic bullous keratopathy, underwent a routine uneventful DSEC in October 2018. His vision had improved from counting fingers close to face to 6/60. And 4 months later, in Feb 2019, his BCVA was 618 with +2 and +2.5 correction and a clear graft. He came back 6 months following the initial surgery, that is in April 2019, with this interface infiltrate. I do not have ASOST pictures or slit lamp pictures. These are just simple mobile phone captures that I did at that time. And I thought of very aggressive management and didn't try anything else medically, and straight away went for a therapeutic PK, and the donor lenticule was sent for microbiology workup. From the donor lenticule, the corneal button Candida species was grown. My second case, another 82-year-old male diagnosed PBK, underwent DSEC on 8 September 2019. This was his initial picture when he had a clear graft, and he came back a month later stopping medications. And this was an edematous, we had an edematous graft. Hence the family, since they wanted me to do something again for him, so I took him for re-DSEC in October 2019. In early November 2019, when I saw him, he was having a clear graft, as can be seen in this picture. But in late November 2019, he came with this picture when there were exudates on the IOL, there was a hypopyon. And in the interface, I could see some spots in an ultrasound suggested endophthalmitis. So he was taken up for core vitrectomy along with vitreous tap. Intravitreal and intracameral antibiotics were given. The lenticule was not explanted in this particular patient because the graft looked reasonably okay, though there were interface infiltrates, and multiple repeat intracameral and intravitreal antifungals were given. From the vitreous tap, again, Candida species was grown. So summarizing, in the last 3 years, I've done approximately 60 DSECs, in which I had 2 cases of Candida interface keratitis. Duration after which the infection was noted was 6 months and 2 months later in the first and the second case. Both the corneas were cortisol stored from 2 different eye banks. The donor age was approximately 51 to 58 years with a good endothelial cell count. The death to preservation time was 6 to 7 hours. In the first case, the eye bank details, I couldn't actually retrieve it. But in the second case, the first DSEC was done 3 days later following the storage. And in the second DSEC was done 5 days later following the storage. Cannot comment on the other eye used for transplant. Normally, I don't send the donor corneal rim for culture. In the first case, a therapeutic PK was done. In the second case, vitrectomy along with antibiotics, and oral and topical voriconazole was given. In both the cases, the eye was salvaged, but the final visual outcome was poor, less than 3/60. So interface infectious keratitis is a novel corneal infection that may develop after any type of lamellar keratoplasty. Onset of infection occurs in the virtual space between the graft and host, where it may remain localized until spreading with possible risk of endophthalmitis. It's difficult to treat, difficult to actually access the area microbiologically, and it may cause profound loss of vision. So 2 literature review. The first one published in Ocular Surface in 2019, where all the published reports between 2007 to 2018 was analyzed, in which they saw some 62 cases, of which 46 were fungal, 9 bacteria, 2 actinomyces, 1 acanthamoeba, and 4 indeterminate. The clinical signs noted mostly were conjunctival injection, interface opacity, stromal edema in the case of bacterial infections, and dense white infiltrates at interface with endothelial plaques, that is in fungal. The mean onset of symptoms was post-operative day 62.44 plus minus 50.07 in bacterial and 51.5 plus minus 102.42 in the case of fungal. Most of the cases required a therapeutic PK, 62.90%. Some 12.9% were treated with repeat LK and 24.19% were treated medically. The most common reason for interface infectious keratitis was concluded to be Candida albicans. Donor rim culture, in one case, Klebsiella, and 16 cases of fungal positive donor rim culture was associated with the same pathogen in interface infectious keratitis. Coming on to fungal keratitis is more commonly reported after endothelial keratoplasty, the incidence being 0.022% than penetrating keratoplasty, which is 0.012%. It may be due to transmission of fungus from donor corneal tissue to recipient, the recipient corneal ocular surface harboring latent fungal elements without clinical disease or contamination of surgical instruments. The predisposing host factors include chronic epithelial defects, loose sutures, or topical corticosteroids. The donor risk factors, which has been hypothesized, could be cardiac disease as cause of death, alcohol abuse, or prolonged death to preservation time greater than 12 hours. Clinically, what we can see is diffuse white intrastromal opacities. In 60% of the cases it was seen, or interface scattered with white to cream colored deposits, dense white infiltrates at host lenticule interface in central stroma and incision site with a hypopyon, small round white infiltrates at inferior edge of the graft with additional diffuse debris, interface debris, and asymptomatic white to cream colored interface deposits. Most of the time, the fungal keratitis, it was in the late post-operative period, that is between 1 to 4 months. In my case, one patient presented to me after 6 months and the other one 2 months. Surgical interventions tried were interface scrapings and antibiotic irrigation, intracameral or interface antibiotic injections, lamellar graft injections, exchange, and therapeutic PK. The second literature review was of 42 cases, in which 12 cases were reported after DALC and 31 cases after endothelial keratoplasty. The median time of presentation was 28 days, between 1 to 120 days. Fungi was again the most common microorganism isolated. Donor rim culture was done in 28 cases, 13 were negative and 15 were positive for Candida, and correspondence was found in all. Interface antibiotic wash risks include, I would say therapeutic PK, early excisional penetrating keratoplasty has got the highest therapeutic efficacy. Interface antibiotic wash risk would include DM perforation, graft dislocation with AC contamination. So with that, I end my presentation.
Thank you so much, Dr. Jaya, for raising this important issue. There is an increasing concern now about these kind of infections following DSEK or endothelial keratoplasty. But if you go logically and scientifically, it's a little puzzling because several issues are there. But certainly it's something that one needs to keep monitoring and following up. The Candida, again, is little unusual in our scenario because the patients were immunocompetent, they were not diabetic. And you can just see which geographic area the tissues were sourced from. So you did mention the death to preservation time, but which geographic location? So were they North India, South India? Where did the corneas come from? That's one for these two cases. It's very, very interesting to keep monitoring this information. And a second important point I'd like to add here is eye banks are also now needing to be more aware because they may be doing repeated warming cycles for preparing the DSEK tissue. And that is again one risk factor which may be an explanation why it happens with endothelial keratoplasty compared to penetrating. So in the interest of time, let's not deprive Dr. Shama of getting full duration of her talk. And this is again a very important topic on ASOCT for keratomycosis. And thanks a lot, Jaya, for that very nice, lucid description and very interesting cases. Thanks a lot. Dr. Kshama, please.
Thank you, Dr. Radhika ma'am, for giving me this opportunity to present my talk.
So we can hear you very clearly, and we're just waiting to see your screen.
Yes, ma'am, I'm trying.
And another thing I'd like to commend Dr. Jaya, that I'm glad you took at least the camera pictures. You know, one in the pursuit of excellence and chasing excellent quality images, one should not forget the use of humble equipment and to have some kind of documentation. So I really appreciate that you took the photographs, Jaya.
Thank you, ma'am.
Yes, let's go ahead with Dr. Kshama.
I would be discussing the role of anterior segment OCT in keratomycosis. India being an agrarian country, keratosis accounts for 30 to 40% patients of keratitis. ASOCT is a non-contact imaging device which provides cross-sectional images of cornea. It is akin to an in vivo biopsy. It helps in quantitative assessment of infiltrates and corneal thickness, which is otherwise not possible. The principle is based on Michelson interferometer. The OCTs which are available are time domain OCT, spectral domain, and swept source OCT. We commonly use the spectral domain OCT nowadays, which gives a resolution of about 5 microns and good quality images. These are the commercial brands which are available. The OCT which we use is Cirrus OCT, and it is a spectral domain OCT. Definitely these newer OCTs like Acacia, etc., they provide good quality images for anterior segment as compared to normal spectral domain OCTs. There are various scanning protocols available in the machine. For following these keratitis patients, a raster protocol is good because it gives parallel linear scans at equal distance. The sizes are adjustable to around 8 mm. They are good for corneal ulcers and also for DMD. This is how a normal OCT of cornea looks like. And sometimes we get these artifacts, these hyper-reflective dots which are seen perpendicular to the light beam which is incident on the cornea, and one should be able to identify these artifacts. So what are the uses? They are used for diagnosis, for planning the therapy, as well as in monitoring the treatment. For diagnosis, there are various lesions which have been described in various studies. Some are seen in any microbial keratitis, and there are few lesions which are specific for fungal keratitis, like hyperreflective stromal lesions. They show infiltrate. If you get an epithelial defect, it denotes an ulcer. Stromal edema denotes a thickened cornea, which could be due to any cause, maybe because of infiltrates as well. Now, hyperreflective material over epithelium could be due to epithelial plaque as a part of your fungal keratitis, or it could be due to drug deposits, or sometimes the fungal growth like the dematiaceous fungi which grow over the epithelium. Sometimes we get hyperreflective material over the endothelium. It may be present simply as exudate or may form a thick plaque. The hyperreflective material over epithelium and over endothelium and cystic spaces in the cornea. These are common in fungal keratitis. Whereas rest of the features, like you can even get stromal thinning or desmetocele or a scar formation, they can be seen in any type of microbial keratitis. Now this is how it looks like. These are the infiltrates. You can see the hyperreflective area in the stroma, and it is dense enough to cause the shadowing. The posterior non-visibility is known as shadowing. Here you can see the endoexudates can be seen in this area, and similarly in the vertical scan of the same area, the epithelium is defective and the endoexudates can be seen. The other use which is seen in ASOCT is differentiation between active keratitis and heel keratitis. The infiltrates can be seen as hyperreflective areas with intact or defective epithelium, whereas in healed keratitis, the margins are well defined and the epithelium will always be intact. Stromal edema is seen in active keratitis, whereas in healed keratitis, there will be stromal thinning or it will be of normal thickness. And posterior shadowing is seen in active keratitis, not in healed keratitis. So this was an interesting case. A 6-year-old boy presented to us with trauma by vegetative matter, following which he developed this type of elevation in the cornea, and he complained of watering and foreign body sensation. The fluorescein stain was negative. So we went ahead and did an OCT and found this type of lesion in the cornea. It was an isolated cyst with a diffuse increase in the reflectivity, which demonstrated the presence of infiltrate. So we kept the patient only on topical netamycin, and within 15 days the patient healed. And as you can see in the following OCT, there was a scarring present, but the infiltrate or the increased reflectivity disappeared and there was symptomatic improvement. This was another patient from a faraway place. He presented with a 2 months history of lesion in the eye. He also had a history by trauma by vegetative matter. When he presented, he has such a lesion sitting on the cornea. We were not able to scrape in this patient also, and actually we were doubtful of the lesion. So the ASOCT revealed large cystic spaces on the cornea. Due to presence of history, we advised him antifungal medication, and within 15 days the patient responded well. The cysts gradually decreased. Here you can see the epithelium became more regular. There was reduction in the edema and the stroma became consolidated. But then we lost this patient to follow. We didn't. This was another case where there was, you can see a small localized cystic spaces. These are also commonly seen in fungal keratitis. And actually in this photo, I want to say that it was a nasty looking corneal ulcer. And although this OCT shows you a nearly regular epithelium, you can see, but the thinning goes on posterior side more, because ultimately this patient perforated, and this was because of lack of assessment on the OCT, which doesn't show you the posterior thinning when it's happening fast. So it's not able to picture it. There's a dynamic OCT where you can scan whole of the lesion, and you can see where the infiltrates are beginning, where the epithelium is defective, and where you can pinpoint where the cornea is actually thinned or there's imminent perforation. This is how an epithelial plaque, which is again a feature of keratomycosis, looks like. And in the continuity of epithelium, you will get a hyperreflective lesion in the cornea, which will be slightly elevated on the top. This gradually resolves with the medical management. This was a young child of about 10 years age who presented to us after trauma by vegetative matter, and on slit lamp examination, he had 2 separate foci of infection with a streak of hypopyon. On ASOCT, the epithelium appeared to be continuous, and the epithelium was elevated because the infiltrates were deeper, and we were not able to focus it by our ASOCT because there was a lot of edema.
We have shot up our time. We have just have to conclude now.
Okay, ma'am. I'll do it fast. So we managed the patient since it was a deep keratitis. We gave intrastromal injection, and this is how the patient healed well. And in the final photograph, you can see an hyperreflective layer in the cornea with intact overlying epithelium, which shows a scarring. And this cornea remodeled at around 6 months, and this is how the patient improved. It can also be used to rule out a foreign body, as this lady presented with a history of trauma, but the OCT examination showed presence of only the infiltrates and no foreign body was seen. This was a gentleman. He got operated outside and presented to us with a buckle handle type of flap. And he also complained of pain. So to rule out whether active keratitis was present or not, we did an OCT, which showed that the cornea was disorganized but consolidated. The epithelium was intact and there was no visible infiltrates. Hence, we concluded it to be a heel keratitis. And sometimes we can get a desmatocele where there is nearly loss of all the layers of cornea except desmat membrane. It is very useful for quantitative measurements of the corneal ulcer. The corneal thickness and the infiltrate thickness, they should be measured along an axis perpendicular to the horizontal axis of scan. If there is shadowing, the CT can be measured at an area adjacent to infiltrate, like in this picture, and the infiltrate width can also be measured. When we monitor, we see the decreased corneal thickness. The hyperreflective area becomes more consolidated.
Dr. Sharma, since we have to hand over the hall,
Yes,
can
ma'am.
you just summarize?
Yes, ma'am. Thank you, ma'am. And it also helps in guiding the treatment because superficial lesions, we provide monotherapy. And if we are planning for PAXIXL, the infiltrate depth should be less than 300 microns, whereas the corneal thickness should be more than 400 microns. So ASOCT is very useful, especially in deep stromal involvement and endothelial plaques. Thank you so much.
Thank you so much, Dr. Sharma. So that was a very good overview about the application of ASOCT. I must apologize for I kept talking in between, so I did take some of your time. I'm sorry about that, Sharma. But I would like to appreciate the contribution of Dr. Uma as co-chairman, Dr. Jaya as convener, and all the speakers, faculty for excellent talks. Thank you so much, everybody, and enjoy the meeting.
Thank you, Dr.
Thank you,
Radhika.
ma'am.
So Dr. Rajiv, am I audible?
You are audible, but I can't see you, sir. Good morning.
Hello, Ji. Hi. I started the video. It's already on. I started the audio, video.
Okay, wonderful. Yes, sir.
Okay. Okay. Can we start? Are the other panelists there?
I got a call from Dr. Manisha. She will be joining a bit late.
Okay, fine. So I think we can start the session. So
Yes, please,
good morning. Yeah, good morning, everyone. So warm welcome to the first ever hybrid annual midterm DOS conference. I thank DOS, especially Dr. Subhash and Dr. Namrata for inviting me to chair the session. And the topic that we are going to discuss is the endophthalmitis. And as we all know, endophthalmitis is the nightmare for every eye surgeon. And to discuss about that, we have got 5 of us panelists. Me, Sanjay Ahuja on virtual dais, Dr. Manisha, Dr. Rajiv, Dr. Bhuvan, and Dr. Anshul. And we have got a battery of 8 eminent speakers who are going to speak for 7 minutes. After that, 3 or 4 minutes we'll keep for the discussion. And whatever time left that we can discuss the other things. So I would like to hand it over to our convener, Dr. Rajiv, to invite the first speaker. Dr. Rajiv, please. Dr. Rajiv?
Sir, just moderator Anshul is there. I just wanted to confirm whether all of us are here or not, sir.
Okay, please. Is Dr. Dr. Anshul?
A lot of people are missing, I guess.
I don't see them in the list of the participants. They're not there. Only me and you are there. None of
So shall we wait for another couple of minutes, sir, before everyone joins? Because that will make us make our
just
job
2 minutes. Okay.
clear.
Fine.
I think everybody must be busy in their OPDs, I guess.
Okay.
Yes.
Yeah.
It's such a time.
I closed my OT. I also had the OT session, so I closed the OT. I postponed it to the tomorrow and evening. Yeah.
Okay. So even I did that, sir.
That's a great, good.
So I thought today at least I'll just take out the session.
I see a list of only 6 participants only are there, including
Yes.
2 of us. There are 6 people only attending the session. None of the speaker is also there.
Good afternoon,
Okay.
sir. This is Apoorv.
Hello.
Hello.
Hi. Welcome, please.
The first speaker is Dr. Shubhra Goswami. I don't know
Okay.
whether Dr. Shubhra is there or not as yet. Ashish has joined. Dr. Apoorv is there. Bhuvan, are you there? Bhuvan?
Hi, Rajiv.
Hey, hi, Ashish. How are you?
Yes, fine.
Apoorv, hi.
Welcome, Dr. Ashish.
Yeah, thank you.
Hello, sir.
Hi.
Good afternoon.
So maybe in the meantime, shall we start with Bhuvan is there? Bhuvan is not there, it seems. Bhuvan is come. Bhuvan, please unmute yourself, my dear. Bhuvan? Bhuvan is there, but I don't see him.
Okay.
Hi, Rajiv.
Yeah.
Just
I think
a
we'll
bit.
start the session.
Yeah, Dr.
please
Shubhra is
start
not there.
the session.
Achha, so you can start with the second one, no problem.
Bhuvan, are you ready with your talk?
Rajiv, I'm ready, but can I do the next one?
Okay, shall we start with Apoorv then, Apoorv? Management of post-traumatic endophthalmitis?
Yeah, am I audible, sir?
Yeah, wonderful.
Okay, I'll just share my screen. Are my slides visible, sir?
Yeah,
yes,
please.
yes. Please go ahead.
Okay. Sorry, just a minute.
So Apoorv is a dynamic
Yeah.
surgeon, dynamic vitreoretinal surgeon from Vision Eye Care Center. And Apoorv, if you want to add 2 lines of yourself so that all of us know you.
Thank you, sir. I'm working at Vision Eye Center presently. I've been trained at Aravind Eye Hospital, Madurai, then worked as a consultant at Chitrakoot Sadguru Netra Chikitsalaya, and now I've been working at Vision Eye Center in New Delhi for the past 2 years. Thanks, sir, for the kind introduction. I'll be speaking on, should I start, sir?
Yes,
yeah, please.
Am I audible? Okay. Good afternoon, all. Thank you for the opportunity. I'll be presenting the management of post-traumatic endophthalmitis. Post-traumatic endophthalmitis, as we know, is a devastating complication of open globe injury with incidence widely varying across studies. Now, unlike post-operative endophthalmitis, this is associated with worse visual outcomes, mainly because of associated damage to the ocular structures associated with trauma, more virulent organisms, and often a delayed diagnosis and treatment following trauma. Risk factors for post-traumatic endophthalmitis being a delayed primary repair, an intraocular foreign body, especially of an organic nature, rupture of the lens capsule, which can allow entry of microorganisms to the vitreous cavity. More risk factors, other risk factors being the nature of injury itself, organic matter associated with a higher risk, laceration associated with a higher risk as compared to rupture, low velocity projectile associated with a higher risk as compared to high velocity explosives, which may undergo self-sterilization. Timely diagnosis is especially crucial so that timely treatment can be initiated. Clinical features which can lead us to suspect endophthalmitis following trauma would be pain out of proportion to the degree of trauma, any purulent exudate from the site of injury, severe anterior segment inflammation with fibrinous reaction and a hypopion, severe vitritis or vitreous opacification, and where retinal view permits presence of retinitis and periphlebitis. Imaging, a CT scan is especially important to look for any intraocular or intraorbital foreign body. B scan done after primary repair will help us look for associated features which can decide the prognosis and management in these cases, such as a coexisting retinal detachment or a suprachoroidal hemorrhage. Once a clinical diagnosis is suspected, to establish the diagnosis, we go for microbiological culture and sensitivity. The specimen may be obtained from the wound, aqueous, vitreous being especially important and mandatory. Biopsy with cutter is preferred as it provides a better yield with less vitreoretinal traction, better control. Vitrectomy sample from the cassette may also be obtained, and this sample is then sent for microbiological analysis. The common microorganisms involved being lid commensals, as in post-operative variety, staph and strepto species. Bacillus and Clostridium species are especially important for post-traumatic endophthalmitis, as these are abundant in soil and organic matter. It produce an extremely virulent form of infection with rapid onset of clinical signs and symptoms. Among the gram-negative rods, Pseudomonas is the most common cause. Again, produces a fulminant infection with rapid onset and progression. Among the fungi, Candida aspergillus and Fusarium are the important species, typically produce delayed onset of inflammation after injury with slow progression and only minor discomfort. Typically, one sees an inflammatory mass in the vitreous, which is described as snowball, fluff ball, or string of pearls appearance. Among the factors affecting visual prognosis, severity of trauma is the most important factor itself, especially a coexisting retinal detachment carries a poor prognosis. Virulence of microorganisms, as discussed, Bacillus, Pseudomonas associated with a poorer prognosis. Timely diagnosis and treatment, whether it has been initiated. Wound characteristics, a more posterior wound and a larger wound is associated with a poorer prognosis. And presence of an intraocular foreign body, which can induce structural damage, may act as the nidus for infection and also induce inflammatory reaction, as in the case of iron or copper. Coming to the prophylaxis, most important thing is to do an early and meticulous primary wound repair in these cases to prevent endophthalmitis. Now, unlike post-operative endophthalmitis, broad spectrum systemic antibiotics are preferably given in the post-traumatic variety, and they do have a role. Intravitreal as prophylaxis can be reserved for cases, high-risk cases such as a dirty wound, delayed repair, or an IOFP. Prompt treatment should be initiated as soon as a diagnosis is made. Initial empirical treatment should cover a broad spectrum of gram-positive and gram-negative organisms, and further treatment would depend on culture and sensitivity results. Now, early vitrectomy in post-traumatic endophthalmitis has been shown to be associated with a better outcome, with the absolute indications being a coexisting retinal detachment, presence of an intraocular foreign body following trauma, or a clinically severe infection which shows no improvement following initial intravitreal injection. Vas plana vitrectomy in these cases allows removal of microorganisms, toxins, and debris, improves the media clarity, and eliminates vitreous scaffold for traction. Why post-traumatic endophthalmitis vitrectomy is especially challenging? First factor being hazy media, because after trauma, the cornea may be hazy, there may be a corneal wound, there may be inflammatory membranes, cataract. Other features of coexisting trauma may be present, such as hypotony, retinal or choroidal detachment, any suprachoroidal or subretinal hemorrhage, which complicate the picture in these cases. And these are often young patients with absent PVD. So vitrectomy is more difficult, and any attempt at PVD is fraught with a high risk of retinal breaks because of an inflamed and necrotic retina. Now, this is to illustrate the importance of PVD. Thanks to Dr. Rushil from Shroff Charity for sharing the video. As we can see, this is an elderly lady presented following broomstick injury. As we start the vitrectomy, we can see that the posterior hyaloid has already completely separated from the underlying retina, and the underlying retina is healthy. So we're able to do a good vitrectomy without going close to the surface of the retina, and such a case is associated with a good visual outcome. Unlike the first case, this second case presented to us younger patient, no PVD with a coexisting retinal detachment and intraocular foreign body. So this would have a much poorer prognosis. We go ahead with a 6 mm cannula and we start to separate after the lensectomy and anterior vitrectomy, we start separating the posterior hyaloid, but ended up creating an iatrogenic break here, as these exudates were very difficult to differentiate from underlying detached yellow necrotic retina. The PVD induction from the optic disc in this case was difficult to achieve. So we go around the optic disc to peel off the vitreous exudates with the help of suction from the vitreous cutter. And where suction from the cutter wasn't enough, we had to use the vitreous forceps to remove the posterior hyaloid. And this is when the foreign body came into the view. Once we've removed the posterior hyaloid, we catch hold of the foreign body with the help of vitreous forceps, and this was then removed through the clear corneal incision. Peripheral vitreous exudates were removed. Retinal detachment was drained through the primary break, and endolaser was done around it, followed by intravitreal and silicone oil injection. Why silicone oil is preferred as the choice of tamponade in these cases is primarily because of its antimicrobial activity, and also it ensures globe stability with reduced occurrence of post-operative hypotony, provides an optically clear medium post-operatively. To summarize, post-traumatic endophthalmitis is a devastating complication of open globe injury. It's important to keep a high index of suspicion so that prompt diagnosis and management can be initiated, with early primary repair being the key. Prognosis depends on a variety of factors, as discussed already. Vitrectomy in these cases is especially challenging. However, an early, good and safe vitrectomy with intravitreal and systemic antibiotics may help salvage the eye in these difficult cases with an otherwise poor prognosis. These are my references. Thank you.
Thank you, Dr. Apoor. It was a very nice, informative presentation.
Thank you, sir.
One thing I wanted to ask was that, like, if you have to give the prophylactically some post-trauma case, you want to prevent the end of, you suspect that the patient may go like the high-risk case. Which antibiotic do you prefer in those patients? Prophylactically antibiotic.
Prophylactically, you mean intravitreal or systemic, sir?
No, whatever, but the case is there, the high-risk case is there before you, post-traumatic case. You suspect?
Systemically, we usually go for oral ciprofloxacin, 700 milligram twice a day. It is known to achieve a good intravitreal concentration in these cases, and also effective against Pseudomonas. And intravitreal, we give only in high-risk cases where there's a dirty wound, delayed repair, intraocular foreign body. We don't give intravitreal in all open globe injuries routinely.
Okay. Some people they do give the IV also, intravenous also, cefazolin, and they for 2 days, and then they can start the. Yeah, please. Sorry, Dr. Ashish.
Hello.
Yeah, please.
Hello, sir. Good afternoon. Hello, sir.
Go ahead, Ashish.
Yeah.
One thing that I would like to say in my practice is that whenever a trauma case comes to you, if you are doing the case in first 1, 2, or 3 hours, you should give a prophylactic antibiotic. Suppose 1 day has gone by, then the chance of traumatic endophthalmitis is very less. So initially, if you are repairing the wound early, then it is better to give a prophylactic antibiotic rather than wait for endoff to come and then again go ahead and treat the thing. So in my practice, I usually give a prophylactic antibiotic if I am doing an early surgery to repair the wound.
Right. Yeah. See, the Moxie, cefazolin, the ceftazidime, and the Moxie and Gatiploxacin, they have a very good ocular penetration. They pass through the blood-ocular barrier very well. So even if the eye is not inflamed, here the eye gets inflamed once there is a trauma, so the penetration becomes more. Yeah, I think even the Cipro is better than the Moxie. Like Cipro is more effective against the gram-negative, while your moxifloxacin is more against the MRSA positive ones, the methicillin-resistant Staphylococcus aureus. So I think Cipro is better, as you were saying, Dr. Apurva. The Cipro is better than the Moxie for these. It's more broad spectrum.
So
it
the
covers
reason
the gram-negative better. It covers the gram-negative better.
Yes, sir. True. So the reason why we are not giving intravitreal always in the first sitting is because often there's a deformed globe and they may be associated.
No, I didn't say the intravitreal. I said the IV, intravenous.
Yeah.
So one thing one
Broad
has to
spectrum,
remember that one should not try to apply the EVS, endophthalmitis vitrectomy study here. The endophthalmitis vitrectomy study was only for the post cataract. So it doesn't include they said there is no role of systemic antibiotics. So that doesn't include the post traumatic or bleb induced or whatever the other end of.
Yeah, there's a breakdown of the blood.
One more tip I wanted to give.
So the systemic antibiotics have a better penetration into the vitreous cavity.
Right. And one more tip I wanted to add was that whenever if you are doing the vitreous biopsy is a more of an invasive procedure. So before that, one can try the needle vitreous aspiration also. But remember that whenever you are going to aspirate, just break the suction before. Like your the piston, the barrel, you should break the suction before you enter into the vitreous. If you go straight away inside with the syringe, it may suck the vitreous more. It may put more traction on the vitreous. But if you break the section outside, just draw a little air outside and then you enter and then you withdraw the vitreous tab. Then that is better. If you are getting a dry tab, then you straight away go ahead for the vitreous biopsy.
Yeah.
Okay.
So shall we move to the next talk, sir? Now,
anybody has
ready,
to
I
add
guess.
anything? Yeah.
And
can I just add a comment to that, Dr. Sanjay?
Yeah, please.
I think in today's time, when we have MIVS and we have these 27 and 25 gauge cutters available, I personally would not advocate doing a vitreous aspiration. Because we have to understand that these are inflamed eyes, and sometimes if we have a well-formed vitreous, it's a very blind procedure that we are doing. So I think in today's MIVS time, it's always advisable to do a vitreous biopsy rather than do a vitreous stab.
Definitely.
That's what I also do, ma'am.
Yeah.
Whenever there is a indication for vitreous biopsy, you just put 23 gauge trocar cannula. It makes life very easy.
Right.
Because keeping the needle inside and then sucking it with the plunger, a whole lot of vitreous comes without cutting the vitreous, and it's very difficult to find a fluid pocket. You don't know where the fluid pocket is.
Yeah, it's a blind procedure.
Yes.
So a tab
I
would,
think with that,
we'll take up only
shall we move to the next talk? Because we are short of time. We just have finished, ma'am. We have finished only one talk till now because we started a bit late.
Sure.
So I think Bhuvan is ready with his talk. So I'll invite Bhuvan, who will be talking on exogenous endophthalmitis management, my approach. Thanks, Bhuvan.
Yeah, hi Rajiv and hello everyone. So I think there is a lot of overlap in the topics which have been given because I'll also almost speak about the same things. So I think I'll just start with my presentation.
Yeah, please share your screen. Yes.
So just the sad part is that the number of attendees are 0. So there are only panelists who are watching our presentations. So I'll just be discussing exogenous endophthalmitis, what I think should be done. And I think most of it has been discussed only. So first of all, we have to differentiate it from a sterile reaction, from exaggerated reaction. It is very essential because the management is different in both the cases, and a delay in diagnosis of endophthalmitis may result in grave outcomes. So the causes of exaggerated reactions are TAS, a complicated prolonged surgery, a pre-existing uveitis, presence of retained lens matter. All these conditions can lead to an enhanced reaction in the first post-op day. So this is a classification of endophthalmitis. I think everybody is aware of it. So I'm not going
we can't see your presentation, Bhuvan. I think you'll have to click on your presentation and make a full screen.
Can you see it now, ma'am?
No, not yet.
Not yet.
Your presentation is not opening. You can see your desktop.
But it's open here.
Okay.
Yeah, now it is visible.
Okay.
Okay. So again, these are the causes of exaggerated reaction, which I just mentioned, and endophthalmitis has to be initiated from it. So these are the clinical presentation of endophthalmitis. I think everybody is aware of it. It is a severe acute form. It could be a mild acute form which presents after 7 to 14 days, or a chronic or delayed form which occurs after about 4 weeks, and the most common cause is P. acnes or fungal infections. So it's important to differentiate sterile inflammation, as I said. So the onset is important. It is usually present on the first day, and endophthalmitis usually presents after 2 to 7 days in a fulminant case, or probably 7 to 14 days in a subacute case. Pain in endophthalmitis is usually severe. 70% of the patients in the EVS study had pain. However, absence of pain cannot exclude endophthalmitis. So presence of anterior segment inflammation, if there is severe, if there is presence of hypopyon, fibrin, we should always err on the side of endophthalmitis and treat it as a patient of endophthalmitis. And ultrasound can be done to look for the presence of any vitreous inflammation. And if it is present, then it should be considered for endophthalmitis. So I just like to stress this point. I'll stress it again and again. In the presence of hypopyon, significant vitritis, we should always err on the side of an infectious cause and treat it as an endophthalmitis. Sterile inflammation will respond well to steroids. However, endophthalmitis usually does not respond. It may respond initially, but after that it will worsen. So again, if in doubt, always consider as endophthalmitis, and we should try to obtain vitreous samples to find the causative organisms. So this is a minimum thing which can be done by a cataract surgeon. You can obtain the vitreous samples, send it for a culture, give intravitreal antibiotics, start systemic antibiotics as discussed by Dr. Sanjay, and start systemic steroids and refer it to a retinal surgeon. So how to obtain vitreous samples, we just discussed. The best way is to do a biopsy by a vitreous cutter with the enhanced instrumentation. It's always better to use a vitreous cutter. Approximately 0.5 or 0.3 ml of vitreous sample is adequate, and that can be sent for microbiological analysis for finding of the organism. So these are the various antibiotics which are used. So what is the role of steroids in endophthalmitis? The role is controversial, but the steroids help in controlling the inflammation, and inflammation is a very is a cause of the negative effect of endophthalmitis, and both systemic and topical steroids, I think, should be given for control of the inflammation to have a favorable outcome at the end of the treatment. So the EVS study was a conventional study. It recommended giving intravitreal injection if the vision is less than hand movements at 2 weeks, and vitrectomy plus intravitreal antibiotics if the vision is less than hand movements. And the inclusion criteria were patients who develop endophthalmitis within 6 weeks of primary IOL implantation or secondary IOL implantation. However, these conventional guidelines, I think they have been challenged, and now we are more towards early vitrectomy, and that is my approach. I always like to go for an early vitrectomy. The initial indications for vitrectomy were a visual acuity less than hand movements, if it is associated with a retinal detachment or foreign body, not responding to about 2 or 3 intravitreal injections. And the risk of early vitrectomy, that the retina is necrotic, it is fragile, the chances of retinal breaks, it can lead to retinal detachment. The surgery could be difficult because of corneal edema and the presence of inflammation. So why early vitrectomy? Because simply injecting an intravitreal may not control the disease. The organism, its cell wall, the toxins, endotoxins, exotoxins, all of this are quite toxic to the retina. This mixture also sinks down, settle towards the macula, and it may damage the macula. Although the inflammation may be controlled, but the visual outcome may not be good in the end. So with improved instrumentation in the machines and in the cutters, the success of vitreous surgery has also improved dramatically. This is a grading of the endophthalmitis. Initially, we would like to do according to the EVS guidelines, only if it is a grade 5. But now probably I would like to do it even in a grade 2 patient if I see if a vision is less than 6/12. I think the visual outcome is very good if you do a 25 gauge vitrectomy in such cases. So early vitrectomy, these are the benefits. It decreases the bacterial load, increases oxygenation, removes all the inflammatory structure, destructing cells and the mediators, and it can also provide a larger specimen for evaluation. So it also helps in preventing the complications that can occur because of a prolonged disease process like hypotony or phthisis bulbi. Intraoperatively, you can also do a direct inspection of the retina with the help of the viewing systems, which have also improved dramatically, and it reduces the complication of macular complications, as I just said previously. So these are the other benefits, provides a clear ocular media earlier also. And these are traumatic and blood-related endophthalmitis are usually more fulminant. The strains which cause it are more virulent. So they probably need a more aggressive treatment. as compared to conventional vitrectomy. I'll just show you two cases. Both the cases developed endophthalmitis on the same day. One patient went early vitrectomy, the other was treated with intravitreal antibiotics and then went to late vitrectomy, and there was a difference in the outcome. This is a patient which presented with endophthalmitis. So the anterior chamber.
Hello.
Hello. I think I just what happened, I don't know.
Yeah. You're still connected or no?
I'm connected, but something just went out.
Your share screen is not working, I guess.
Is it?
Yeah, the surgery is on now. Yes.
So we can see that there is a relatively clear media. The retina is also much more clear. The view is much more clear. And this we can just do probably just core vitrectomy, inject intravitreal antibiotics at the end of the surgery, and we can just leave the case there. Okay, so this is the patient received intravitreal antibiotics and it had undergone his surgery later. You can see that there is presence of the pupillary membranes which are present. The inflammation is also much more severe. In the macula, there was presence of some exudates deposited. There was signs of necrosis which was present in the necrosis. So this patient received 2 intravitreal antibiotics and the vitrectomy was performed after 1 week. So this is just a clearing of the anterior chamber. We have to clear it. It has to be a step-by-step approach. We have to clear the cornea. We have to clear the AC, remove all membranes. So as you can see from the previous case, if we compare this, there is much more inflammation. There is presence of exudates which can be seen over the retina, over the macula. There was presence of signs of necrosis also present adjacent to the disc which was present. So in this case, I decided to do a complete vitrectomy and silicone oil in the end of the case. And silicone oil I usually use in severe cases, as also discussed by Dr. Apurva. So there are so many exudates there present over the retina. Some of them I were able to be removed and some of them were not able to be removed because they were very tightly adherent to the underlying retina. So when to use silicone oil? It has been discussed by Dr. Apurva also. It's got antimicrobial properties. It helps in compartmentalization. The most important thing I think is it also provides a clear media. The next day we can have a look at the retina and it restores the ocular anatomy, prevents the hypotony due to endophthalmitis. And once the inflammation is controlled, it can be removed after about 3 to 4 months. So the indications is, again, I said severe fulminant endophthalmitis, presence of retinal detachment, evidence of retinal necrosis intraoperatively, creation of retinal breaks or dialysis during vitrectomy. So this is a case which developed endophthalmitis. This is an old video, developed endophthalmitis following a honeybee sting. So this, the sting was removed. Following that, the area that was closed. And as you can see, the patient has got a very severe endophthalmitis. This is an old video. A 20 gauge vitrectomy is being done. So after clearing of the whole of this membranes, the PPL has been done. And after doing a thorough vitrectomy and a complete vitrectomy and using a PVD silicone oil was injected. And this patient was PR inaccurate, as most of these cases are usually PR inaccurate. But the results came out to be quite fine. The end of the surgery, the patient gained a vision of about 6/18. As we can see, post-operatively, there is a clear cornea. Although there is presence of the pupil is small, there is phimosis, but still the patient has got a good vision because of the pinhole effect. So just to summarize, these are the difference in the TAS and infectious endophthalmitis, which I've just discussed. It is very important to distinguish it, and we should always err on the side of endophthalmitis and refer to a retinal surgeon for the treatment. And a treatment algorithm for endophthalmitis, which is my approach, if there is a good reflex, we can start medical therapy within first 24 hours. If there is no improvement, I would like to go for a vitrectomy. And if there is not a good reflex, I would like to go straight away for a vitrectomy. Thank you very much.
Thanks, Bhuvan. That was a wonderful talk. Sir, I think we are running short. Shall I go ahead with my talk? Because my talk also has most of the things which these people have spoken about. Then Dr. Manisha can speak.
There's a lot of overlap between the two.
I think there are all the presentations will be overlapping.
Yes.
Please,
so,
Rajiv.
Hope my screen is visible.
Yes, Rajiv, it is visible.
Yeah.
Please start.
Okay. So management of endophthalmitis revolves around intense medical treatment and surgical intervention with salvaging the eye and vision as primary aim. Before the EVS, there was widely divergent opinion regarding the usefulness and timing of vitrectomy. And it was a wonderful study which gave initial guidelines. But as Bhuvan has said, there were certain pitfalls like chronic endophthalmitis, post-traumatic and other intraocular surgeries where the patients were not taken care of. Our treatment of choice in today's world, rather than whether the vision of the patient is hand movements or worse than light perception, is mostly guided by clinical picture and course. So what we do, we choose intravitreal injections only if the retina can be visualized or there is an excellent red reflex. If, however, no retina details can be seen or the red reflex is very poor, or if there is no improvement within 24 hours after injection, and mind you, during this time, we monitor the patient very closely. We offer surgery to most of our patients as an alternative. And most patients, understanding the risks and benefit of the surgery, they opt for vitrectomy. So as the previous speakers have spoken about it, early vitrectomy nowadays is a trend. We are not following what EVS had stated, probably because of advancements in the techniques and vitrectomy and our confidence in doing these surgeries, which has become much, much safe. So intervention early than late, complete rather than partial, and reasonably good and complete surgery. It is expected to offer prevention of further retinal damage irrespective of visual acuity. So as when I said, why vitrectomy, it gives early sample for vitreous culture, better penetration and diffusion of antibiotics, and it removes the inflammatory debris which causes most of the damage in these cases. Surgical technique, I think Bhuvan has shown it very well. It is similar to a standard 3-port vitrectomy with few exceptions. Securing the infusion cannula, which we used to do in earlier times when we never had this trocar and cannula system. However, it's important to have a longer infusion cannula. These cannulas in 23 gauge and 25 gauge, they are longer than what we used to have when we used to have 4 millimeters cannula. And most of the times we are able to visualize the tip before starting the surgery. If we are not able to visualize, these are the basics which were taught to us in our fellowship times. We have to visualize the tip before starting any kind of vitrectomy. And this is more important in cases of endophthalmitis vitrectomy. Scrape the epithelium if you can't, if the cornea is hazy, epithelium is edematous. Clear the anterior chamber with removing the membranes, make a opening at the limbus and go inside, push visco, remove the membrane. And most important thing, I think this is very important. In our part of what we use reusable instruments for quite a lot of cases. And endophthalmitis cases, whenever they come to us, they are mostly referred by our fellow colleagues and they want us to charge less to manage it. So these cases, it's very imperative to use reasonably fresh cutters so that there is less drag on vitreous, which is, and the surrounding retina, which is already in edematous. So I prefer, if a patient can afford it, I prefer using a new set every time, new cutters. But if the patient cannot afford, then I use my cutters, which are ETO'd only once. So this is a video. The cannula was not visible initially. So if it is not visible, you can't start the vitrectomy. And enter the anterior chamber, remove the membrane as much as possible. Sometimes there is some blood which comes out, but that's all right. Unless you use the cannula, you can't start the vitrectomy. Remove this membrane and do the surgery. Most important part. This is another video which is showing how I go ahead with all these cases. Clearing the anterior chamber is imperative. Can't go ahead without clearing the chamber. The membrane is there. You have to remove the membrane, use forceps, use good amount of viscoelastic so that cornea is not damaged. And if the media is very hazy, I don't go for complete vitrectomy. I remove as much as possible within safe limits. This kind of cases where media is still very hazy, I don't go for complete vitrectomy. And as Dr. Sanjay Ahuja was mentioning about technique of vitreous biopsy, so I'll straight away go to technique of vitreous biopsy. We attach a 5 ml syringe to the aspiration port of the cutter or 2 ml syringe, and all the cannula are in place. Infusion port is fixed. Infusion is high. We use high cut rate. No automatic suction at this stage. You just keep your cutter there and don't aspirate. And once you have keep your cutter there with high cut rate, and once you do a cutting in a lot of after cutting the vitreous, then you aspirate manually. Once you have aspirated, that is the time you can start the infusion, switch on the infusion and continue with the regular vitrectomy. And these samples can also be sent for now here the is on. Now I can make space to visualize inside. Complete system here to should traction on the inflamed and friable retina. To avoid unnecessary traction, vitrectomy should be performed with low suction and high cut rate. Periphery, conservative. The skirt is only shaved, reducing the risk of retinal break. Should a retinal injury be caused or a large area of necrosis is discovered, we prefer injecting silicone oil.
Dr. Raji?
I think, sir, his connection is...
No, connection is gone. Meanwhile, I'll just emphasize 2-3 points here, because he was saying that the vitreous biopsy you are taking.
He's back, Dr. Rajiv has joined back.
Okay.
Sir, was I out till? I don't know.
Yeah. You just go back to that video of that.
Sir, I'll come to whether, So IL explantation is not required in.
Okay.
IL explantation is not required in most of the cases, except for P. acnes and fungal endophthalmitis. And we normally do a very generous capsulotomy to inject intraocular antibiotic near the remaining part of the capsule so that it washes the bag also. Intraocular tamponade has already been discussed by Bhuvan. I don't think I should go more into it to save the time. Thank you.
Okay. Yeah, that was a nice talk. Very informative. I was saying one thing that you were saying, the vitreous biopsy, not the vitreous tap. I'm saying the vitreous biopsy that you were doing. I think the first sample that you should take is should be before starting the infusion, and then you start the infusion. Then you take the.
That's what I said, sir.
Achha, before starting the infusion,
I
missed it. Okay.
Yes, before starting the infusion, you keep your cutter in the mid vitreous where you can visualize it without suction, just sting, then stop your cutter and aspirate manually. And then as soon as the globe starts to collapse, you start the infusion.
Okay. Regarding the endo, most of the cases that report we get, like in EVS, we had most of the cases were gram positive, and that too staph albus, the coagulase negative ones. But in Indian context, most of the studies that we'll find that they blame the gram negatives also equally. So in our cases, the prognosis will be worse, because the gram negative generally has a poorer prognosis as compared to the positive ones.
So I think I was sharing our data with Ashish once. And after doing, like earlier, we used to be hesitant till the vision drops down to LP, we won't do vitrectomy. I think Dr. Manisha would also agree. Nowadays, we are saving a lot of eyes, whether they are gram negative GNB or gram positive staph, aureus and all, because we go for early vitrectomy.
Right.
Dr. Manisha, your comment?
Yeah, absolutely, Rajiv. I think we don't follow that EVS recommendations now any longer, since we have MIVS and the technique of vitrectomy has drastically improved. So I think after having given one intraocular antibiotic injection, if we are not seeing any response, I think all of us are going in for an early vitrectomy. My only questions was, I had a few questions that, Rajiv, which cannula do you prefer? Do you prefer a 23 gauge 6 mm or a 20 gauge 6 mm or a regular 23 gauge?
Ma'am, I use 23 gauge regular ones. And if I'm not able to visualize it, then there's another flute needle which I connect it to infusion and then put inside. And because it's a pseudophakic eye, so we can always touch the lens and see. So it becomes easy.
Right.
And one more tip that I would like to say, Manisha, if you can hear me.
Please.
Once you put the cannula, now as you said, we have to visualize it. And if you can't visualize it, just put this light pipe through it. So once you put the light pipe through it, you will come to know whether actually it is going inside the vitreous cavity or you are not able to see that. So that is one of the indirect ways to see the cannula. Though he is right, we should see the cannula before we switch it on.
Right. And another thing I wanted to ask you, Rajiv and Bhuvan, was that, like Bhuvan said, that silicone oil, we all know, has a bactericidal role also. So there's a lot of controversy. I know one group really advocates that in the first go itself, you do a total vitrectomy, inject silicone oil. But I think most of us are not really aiming to first go. We do more of a debulking of the vitreous. So what is the take of both of you on this?
I normally, if I go inside and the media is okay, I go for almost complete vitrectomy, but avoiding the peripheral skirt of vitreous. And I don't inject oil unless I've created a break or I've seen some break happening somewhere. And most of the cases, they do well.
Sorry to interrupt. If the PVD
we can do, I think we can just do a simple vitrectomy, and if most of the retina is visible, there is no need of injecting a silicone oil. There is not even a need to induce a PVD also, I think, in many of the cases. But I think even the one which is the very fulminant ones in which there is a lot of probably it is either to the retina, you can also see areas of retinal necrosis, as I mentioned, and there are chances of a retinal break, or you have created a retinal break. Or probably some of the very severe ones which develop a very severe hypopyon and there are exudates everywhere. I think silicone oil will just help to control the inflammation because it helps to compartmentalize it. It does not spread it. So probably in very fulminant cases, I would also like to do a complete PVD, and only after a complete PVD, you should inject silicone oil, of course.
Yes.
Yeah, Ashish.
Manisha, I am totally against doing a complete PVD and a complete vitrectomy. What I do is that I feel that even you don't even need to see the retina. You just go inside, use your cutter for 5 to 10 minutes, and then come out, put your injections. If your injections are going to work, I'm sure your patient is going to do well. If you are going to go for a complete vitrectomy, removing all exudates, in case you end up on a break, then the things are gone because it is inflammation inside. The organism is not, fully active. And those kind of PVR changes and the game is over. So I would say that we should not go for a PVD. We should not go for a complete vitrectomy unless we suspect a fungal. And for fungal also, I would suggest that first let us, document it with microbiology and then only go for a PVD. I have burned my fingers and I have in Gurgaon, I get a lot of patients from NCR, and I've realized that if I do simple core vitrectomy, do a good microbiology and give a good antibiotic, something that works for the organism, most of the times the patients do very well.
So I think one message is very clear to everybody is that we should not really target for a complete vitrectomy with a PVD induction in the first go. But having said that, and also not with the aim of injecting silicone oil in every case initially, it is going to be much later that you take that decision. But I think it is quite case-based that where you would, sometimes you have a complete PVD with just a point attachment at the disc. So that is the time when you can actually be doing quite a complete vitrectomy. But sometimes when the eyes are very inflamed, you don't have much of the PVD. That's the time I think what Dr. Ashish is saying is something which is very logical to follow, that rather than being very aggressive and creating retinal breaks is going to like losing the eye. So at that time, probably we need to hold back our hands and just give it a, a second try with the revitrectomy later on when we have an evidence of a PVD induction.
So I think what is the safest you think for the patient, I think, and in your hands, I think.
Right.
Especially in pediatric patients, younger patients, it's very difficult to do a complete vitrectomy and very risky as well.
Right.
Anyways, it's not a complete vitrectomy. Whenever we are doing in endophthalmitis cases, you have to leave peripheral skirt as it is. And once you go, if you think that, as ma'am has said, if there are 1 or 2 points of PVD which is attached, then you just pull it off and remove the vitreous from the posterior pore. When I say complete vitrectomy, it doesn't mean the kind of vitrectomy
just
which
the PVD induction.
Only PVD induction. I think PVD induction is important if you're injecting silicone oil. If you're planned or you think that you're injecting. And just to add cannula, one thing more, rather than making a beveled entry in endophthalmitis, if you think you just make a straight entry, I think that is also a better approach to avoid going into the suprachoroidal space. We can just make a straight entry rather than a beveled entry.
So I think, shall we move to the next talk? Can I invite Dr. Manisha for atypical organisms in endophthalmitis, ma'am?
Yeah, thank you, Rajiv. I'll share my screen. Is it visible?
Yes, yes, ma'am.
So good afternoon, everyone. And I would be just talking a few of the atypical organisms that we found in our endophthalmitis cases by 3 case examples. So this is a 40-year-old male patient who presented with a sudden painful diminution of vision and redness in the right eye for last 1 month. History of an uneventful phaco, which was done about 2 months back. He was diagnosed to have endophthalmitis elsewhere and was treated with some intravitreal injection, where we really don't locate the details of what drugs were given. And this patient apparently had no relevant systemic history. So this is how the eye looked. The vision was as low as 20 by 120 and less than N36 with circumcorneal congestion, corneal edema, hypopyon, aggressive looking AC reaction with a whole layer of fibrin over the IOL. And the fundus was hardly visible in this particular eye. So we, of course, resorted to the first line management by doing an AC tap, which was sent for microbiology. And we gave a VCD as the first intravitreal injection under topical anesthesia. The patient was started on oral antibiotic and steroids. And oral topical antibiotics and steroids were also given in the form of eye drops. The patient was on a regular follow-up and he did show a resolving hypopyon with improvement in the vitreous haze. Now, 1 month later, the patient again presented with diminution of vision and circumcorneal congestion, streak hypopyon, fibrin over the IOL. The vitreous had extensive exudates with no details seen. So at this time, we had to resort for a surgical intervention and the patient had to undergo an IOL removal with a core vitrectomy and intraocular antibiotic injection. The vitreous sample and IOL were sent for a microbiological examination. Post-operatively, the patient looked something like this. He had aphakia with DM folds. The AC looked pretty quiet and the fundus, the vitreous cavity, was absolutely clear. So when the KOH mount report came, it showed some kind of looking macroconidias. And to our surprise, the organism which came out in this patient was Fusarium species. Just request everyone to please mute their mics. I can barely hear anyone.
Bhuvan, kindly mute.
Sorry.
And on the
okay, ma'am, please go ahead.
Yeah, thank you, Rajiv. And on the culture, we had these fluffy looking colonies which grew on the various culture medias, and this came out to be Fusarium solani. So the treatment, of course, all kinds of steroids were stopped immediately after an intake of a tapering dose for a month because the patient did show an initial response. And the patient was then loaded with oral voriconazole and topical voriconazole after, of course, the baseline LFT evaluation. Intravitreal voriconazole were now repeated every 24 hours for 3 days and then on every alternate day. A revitrectomy and repeat intravitreal injections were continued, and the patient drastically improved in the coming 5 months and regained a vision of 20/60 N18. But to our surprise, we kept this patient on a regular follow-up, and after having recovered completely after about 6 months, this patient comes back with a recurrence now, where the vision drops down to hand movements. There's lid edema, there's chemosis, congestion, again an AC reaction with hypopyon. And what we saw this time was that there was this ball of fungus which you could see behind the iris. So this is what I have highlighted over here. It was a very large size fungal ball which was seen typically behind the iris. So we of course did a revitrectomy, tried to clear up the exudates that had occurred. And this is something we tried in this patient, where we made a limbal opening. We inserted our light pipe through it. And to the fungal ball, we gave a double freeze-thaw technique, cryotherapy was used. And this was basically to kill the fungal elements which were there in this particular fungal ball that we could see behind the iris. The patient again was loaded with antifungals, both topical and oral. And there was a drastic response after this treatment. However, the patient started going into a hypotony, which is very often the case when we have fungal infections. So the patient underwent a revitrectomy with silicone oil injection. So now we have a follow-up of about 18 months for this patient. The vision is 21/20 and N36. The IOP is well maintained. And even if not a very good vision, at least we've been able to salvage this particular globe. And the patient has a well-attached retina. There's a slight ERM formation with silicone oil in situ. So when we reviewed the literature, the fusarium is a filamentous fungus, which is found mainly in the soil and is a very rare cause of post-op endophthalmitis. It is said to be a very destructive fungus because of the production of extracellular proteases that causes matrix degeneration. And whatever cases have been reported in literature, they are often, these eyes are lost. So my other second case is a 62-year-old male patient. He's a resident of Bihar with pain and decreased vision in the left eye, history of uneventful cataract surgery in the left eye. And the vision was pretty good after the cataract surgery, but 10 days later, he again had hypopyon with AC reaction. There were endoexudates in the cornea. And as you see in the B scan, there were extensive echos which were present in the vitreous cavity. So the patient was planned for a core vitrectomy with intraocular antibiotics. And when the sample was reviewed on microscopy, the vitreous biopsy showed hyaline hyphae with branching annelids and flat basal terminal conidias. And these were the colonies which were grown on various medias, which were like woolly colonies with outer pale and inner brown-black zones with mycelial tufts. And this is an interesting photograph where you see the IOL which was explanted. You have this huge colony of the fungus again growing by the side of the IOL. And this organism again came out to be Pseudosporium fungi, which is again a very rare species. The patient underwent an IOL removal, a revitrectomy, a silicone oil injection. All this was done in the desperate situation. As was mentioned by one of my previous speakers, that in fungal endoff, a person needs to be very aggressive. And I think the IOL has to be sacrificed at the first go. So this patient maintains a good vision of about 6/18. And Pseudosporium again is isolated from rural soils. It can manifest very commonly it manifests as keratitis and sclerokeratitis, but getting an endophthalmitis is extremely rare. And whatever cases have been reported are mainly of endogenous endophthalmitis in immunocompromised patients. So this was our first experience of having this particular organism in a post-op endoff cases. And if you review the literature, 93% of the reported cases are fatal, and most often, again, the eyes are lost. So post-op endoff cases following cataract surgeries are usually bacterial, and Aspergillus is the most common isolate. Fungal endoff, as is the classical teaching, usually presents in 1 to 2 months after surgery. But in tropical countries like ours, it can present early within 4 weeks of the surgery also. And these eyes are generally very difficult to treat. I'll just present my last case, which is again a very interesting case of a 70-year-old female patient with a pulmonary TB history 15 years back and a cataract surgery done 2 years back. She had a vision of hand movements in the right eye. The B scan showed extensive echoes. We treated her like a typical end-off case. We were a little confused because it didn't appear like a post-op end-off with the cataract surgery being done 2 years back. And the vitreous sample showed a Grams variable bacilli. There was no growth, but her ESR was very high, her Mantux was very high, and HRCT thorax, when he got repeated, it showed signs of reactivation of tuberculosis. So here this patient apparently presented with endogenous end-off, which was secondary to a reactivation of her chest TB. And this patient, we just treated her with ATT and oral steroids, and she recovered a good vision of 624 and 24. So we were really not aware of this. And when we reviewed the literature, apparently Dr. Vaidya from Mumbai, he has actually reported a case of post-op endophthalmitis and panophthalmitis secondary to Mycobacterium tuberculosis. So this is again one of the rare organisms which we can sometimes find in our post-op end-off cases also. So I would just conclude by saying that atypical organisms in endophthalmitis, though rare, but they can occur. And they're usually more difficult to treat as their antibiotic sensitivity to drugs is really not known. A very regular and a long-term follow-up is required as they can come back with a late recurrence, even after a complete recovery. So we have to be on the lookout and regularly follow up these patients. So thank you so much for your patient listening.
Wonderful talk, ma'am. Just a few questions, ma'am. Any signs when you are thinking of these atypical organisms regarding presentation and the signs which we observe as regards to the hypopyon, the membranes over and behind the IOL, or any special features on ultrasonography which suggests that we may be dealing with some atypical organism?
Yeah, thank you, Rajiv. I think that's an interesting question. I think on ultrasound, it's very difficult to really differentiate because the maximum that you see is just vitreous echoes. But what I've classically seen in these patients is that after you've done the first surgical intervention, the eye looks extremely quiet the next day. So you feel that you're done with the job and everything is over and out, the patient recovers a good vision. But very often in these atypical organisms, I've seen that they come back with a recurrence, and that recurrence is with a vengeance. And that is something which should ring a bell in your mind, that you're probably not dealing with a regular organism, which shows a typical kind of a response to the drugs that we use. So that is something I have learned with my experience, that when you have a very clean looking eye the next day, and you have a patient who seems to be responding very well to your treatment, I think those are the patients you have to be on the lookout for. And the other thing, of course, would be that, sometimes you have evidence more of uveitis in these patients rather than of endophthalmitis. And why I say that is, like, you'll have some evidence of vasculitis. You will have very atypical looking exudates which are plastered over the retina. So these are again a few signs which probably you have to be, like in this particular case, which I showed. The vitreous cavity was quite clear. The retina was very good, but you had this huge fungal ball sitting behind the iris.
Yes.
And that is something on a regular examination, you apparently might even miss because they are usually not a very good dilating pupils. So these are a few things you have to, look out for.
Dr. Manisha, how long are you giving the antifungals for your case, and which ones? Like for these cases, how long antifungals are given?
I don't think there is a very set time period for it. It will entirely depend on the response. But yes, if it's a vitrectomized eye, I often land up repeating the intravitreal injection of the antifungals within 24 hours because the washout period is very fast.
Are you giving systemic antifungals?
Yes, I'm giving that.
How long? That's what I'm saying. How long are you giving
systemic antifungal, I think even if after the complete response, I would not hesitate to continue them for at least 3 weeks to a month after there has been a clinical response.
1 or 2 months, some people are giving. But which one are you giving? Which one are you giving?
Voriconazole. So we are giving voriconazole or sometimes even fluconazole.
Okay. Voriconazole is right. Okay. Is voriconazole available oral?
Yes, as an IV infusion, it is there.
Yes.
Infusion, it is in oral. Is it available?
It is available in oral also.
Oral also, it's available.
Oral, right.
Oral also.
Okay. So what could have been the source for the fungus? What could have been the source?
These are the fungal infections, sir, was the post-op cases. They were post-cataract surgery.
Post-op, but where could have been what could have been the source?
I cannot say that because the cases had been operated elsewhere, so I didn't have any source of tracing what was the source of infection.
So what was why? And moreover, the first the steroids were started beforehand. Even the
because sir, it had presented as a very acute presentation after the cataract surgery, so we didn't suspect actually a fungal infection.
Okay.
We thought it to be like a typical bacterial post-op.
Okay.
But it was interesting when I was reviewing the literature, there has been a report of fusarium cluster end-off, and where all the patients had got infected because of the BSS solution. So that was something new which I got to learn, that you can actually have these fungal infections even residing in the irrigating solutions.
Okay.
That was very innovative, ma'am. Using cryo to destroy the fungal colony.
Yeah, I think now we are quite regularly. Yeah, Rajiv, we are quite regularly doing that, and they're responding very well to it.
Dr. Ashish was asking something.
I am today presenting on cluster fungal endophthalmitis and my experience on how I dealt with a cluster fungal. And as you said, we also had this in the BSS.
Okay.
And these patients.
Ashish, why don't you start a presentation now?
I think that will be better.
Yeah.
I just have one question. I just read a paper on, they were giving intravitreal betadine for patients who are not responding in endophthalmitis. Yes. Has anybody used that out of the panel?
Yeah, very low dose of betadine is being advocated, but I have not had the guts to do that.
So we have done it. Avinash did one case.
Okay.
And the patient did well, but the eye went into hypotony. The infection was cleared, but the eye went into hypotony.
And how much betadine did you use? What concentration of?
I don't remember the concentration, but we used 0.1 ml to inject in the vitreous cavity after vitrectomy.
I thought it was added in the solution.
Rajiv, can I start?
Yep.
Rajiv, can you hear my screen? Can you see my screen?
Yeah, it's visible.
Okay, can I start? Friends, today I'm going to talk about cluster endophthalmitis, how we won the battle. Now these are, cluster endoff. It is a nightmare. Everybody's sad, despair, so much of anxiety, and especially to the person who is referring to you. Now I call endophthalmitis as a war between the surgeon and the organism. The surgeon uses his antibiotics, vitrectomy, clinical intuition, culture, PCR to kill the organism, which is the enemy, which could be gram-positive, negative, or fungal. Now, this is a case series. A high-volume center did 9 surgeries on a day. The first 3 surgeries had anterior chamber reaction with fibrin on the first day. It was diagnosed as toxic reaction, and on increasing the dose of steroids, it subsided, and then the surgeon forgot about it. Now it's 1 month passes, and when they taper the steroids, then comes the trouble. So this is the first case. After 1 month of surgery, the surgeon sees that there is a small hypopyon. Vitreous was quite clear with few cells. Vision was 6/18. This was the first case done on that fateful day. This is the other photograph after dilating the pupil. This is the case number 2, where they could see AC cells and vitreous cells. Vision was 6/9. This presentation is after 1 month of the surgery. This you can see the cells, and this is case number 3. Now, as Dr. Manisha said, we had a high degree of suspicion because on that day we already had 2 cases, and if you see here, we can see that there is a small fungal kind of a colony that is there. So our mind said that there are 4 cases operated on the same day, case 1, 2, 3, and case number 7. The diagnosis was delayed endophthalmitis. What is it? Is it fungal? What is the management strategy? What surgery should you do, and which antifungal should you do? So first what we did was, the surgeon who referred was very skeptical. So we did just an AC wash, sent for microbiology, and injected vancomycin, tazobactam, and amphotericin B. Now, waiting eagerly for microbiology, we found that the microbiology showed fungal hyphae. And after 2 days again, this patient again had AC cells and AC inflammation. So now what we did was we cleared the AC, went ahead, also removed the IOL, then did the vitrectomy, did a complete vitrectomy. I did a PVD and tried to remove as much of vitreous as possible, and also removed the capsule with it. The entire capsule was removed, and finally we sent the whole thing, the capsule and the IOL for microbiology. Now, microbiology showed fungal endophthalmitis. We gave amphotericin B. Now, amphotericin B comes in 2 variants. It is either lipophilic or lipophobic. Half-life of amphotericin B is 48 to 72 hours. I feel amphotericin B works even better than voriconazole and has to be repeated every 3 days. While half-life of voriconazole is 6 hours. So it has to be ideally repeated every 6 hours, which is again a very difficult thing to do, especially in our setups. This was the second case. In this, what we did was that we went ahead and just did a small, anterior vitrectomy and AC wash, and gave amphotericin B, voriconazole, as well as vancomycin. Vitreous was clear except for few cells, so we did just a limited anterior vitrectomy. This had less load of fungus. We thought we have time because as it is, the inflammation had occurred after 1 month. So amphotericin B along with voriconazole were given 3 times at an interval of 3 days. In the case number 3, what we did was we just went ahead and cut the iris along with the fungal ball. The cotton-like mass was stuck to the iris, so we cut the iris. We gave both intracameral and intravitreal amphotericin B and voriconazole 3 times at an interval of 3 days. We were happy we could salvage all the 3 eyes. This was the case 1, this is the case 2, and this is the case 3. The question was that the take-home message was that fungal endophthalmitis behaves differently than bacterial. These are fungistatic drugs, so they need repeated injections. The half-life of injections is very important. Amphotericin B is 48 to 72 hours, while voriconazole, it is 6 hours. Amphotericin B, you can use either of these, liposomal or lyophilized. Now, when we are dealing with endophthalmitis, we need to realize that how aggressive we should be. If the organism is less aggressive, we can be less aggressive. If the organism is too aggressive, like a bacterial Pseudomonas, then we need to, removal may or may not be required, and you don't need a total vitrectomy initially in the first go. Now, the question was why this happened. This happened because that surgeon said that he had used a fluid from the BSS from a company which was not a very regular company, and probably that fluid was used to start the phaco, and then they had used another fluid. So we need to check the bottle for any particulate matter. And we realized that most probably it was the BSS that was the culprit in these cases. Thank you.
Ashish, what was the organism? Which fungus you grew in these cases?
The organism was Fusarium. In fact, what I found is that since the cases presented after 1 month, I feel that we can always, we should give it some time to think about how we are going to kill that organism. Now, in one case, there was a fulminant endophthalmitis. In the other case, there is eyeball. We were actually worried about the recurrence. And what we realized was that we gave amphotericin B every 72 hours just to prevent that recurrence. And we were lucky we did not have any recurrence later on.
And why did you want to use both the antifungals? Because actually why we've all drifted away from amphotericin B is because of the toxicity, not because that it's less efficacious.
In fact, I feel that it is more efficacious. It causes inflammation. in one of my cases, I realized, not in these 3 cases, the patient actually had a lot of AC
No,
reaction.
that's what I said, that we have not drifted away from amphoB because it is less efficacious. We know it is more efficacious, but it is because of the toxicity we have started using it less.
Ma'am, I felt that voriconazole have to repeat it every 6 hours to actually kill the fungus, which again is a difficult thing. And for me, I felt that probably amphotericin B we have to give after 72 hours. So one is that we can easily follow up the patient, and we have more time. The amphotericin B has more time to act on this. In my experience, I feel amphotericin B works better than voriconazole.
One point I want to add is that any eye which has been vitrectomized, any intravitreal drug given will have a reduced half-life. So once you have vitrectomized the eye, any eye, the half-life of the drug becomes less. Yeah.
Half-life is even less.
Yeah.
So the washout is fast.
Right.
So what I would suggest is that any fungal endophthalmitis, it can behave any way, either like these cases or like what Dr. Manisha has shown. So we need to be, the most important message that Dr. Manisha's case is that, it can stick to the ciliary body, and that is a place which is a problem.
Very nice note, Ashish. I just wanted to know, do you also add systemic antifungals for the treatment?
No, I did not add. I feel that probably if it has to work, it will work like this. In fact, I am not a good proponent even in my bacterial endos. I don't even give ciprofloxacin. I feel because imagining that the drug will enter the eye and kill the bacteria and will be okay. It is just a very.
Ashish, you can stop sharing your screen.
I think there's one last presentation left, and we have only 10 minutes. So Dr. Divya is there? Is he there?
Yes, sir. Yes, sir. I am there.
You can start your presentation, please.
Good afternoon, everyone. Today I will be presenting my talk on endogenous endophthalmitis. And before starting, I would like to thank all the panelists and all the speakers for providing me this opportunity. So before starting, I would like to share that fact that intravitreal povidone iodine, some authors have used in their management of endophthalmitis, but only one report recently published in BMC Ophthalmology, it has shown that the authors have used around 1.25% of povidone iodine in 0.1 ml of intravitreal injection. So that they have done in cases of endogenous endophthalmitis of gram-positive bacteria, Staphylococcus aureus, for whom the condition was worsening and the patient could not be taken up for OT. So in that case, they have shown that 1.25% povidone iodine is useful and effective. But the authors didn't mention about any side effect or change in perimetry or in ERG findings also. So with this, I will be starting my presentation. So good afternoon, everyone. Today I will be presenting on endogenous endophthalmitis, which is very important both for the physicians as well as for the ophthalmologists. So first of all, I would like to discuss a case. So here in our OPD, a 50-year-old male patient, healthy, fine, presented with sudden onset painless diminution of vision. Remember, painless in right eye for the last 7 days. And only thing which is significant was in history of intravenous IV drug therapy given for 5 days for suspected typhoid fever by some RMP or quack 2 weeks back at some local hospital outside. And there were no any other systemic findings. On examination, only the right eye was involved and vision was finger counting close to face. And there was significant anterior segment inflammation. And when we saw the fundus, the findings were startling. So we can see a massive subretinal abscess at the macula, which was associated with vitritis. And there is also some inflammation in the vessels, and there is a small inferotemporal bleed around the inferotemporal arcade. So we thought that we manage it as a case of endogenous endophthalmitis, as there was no other apparent cause, no history of trauma, no history of any intraocular surgery. But before we manage this as a case of metastatic endophthalmitis, we should always rule out some other Masquerade syndromes or mimickers. Most of them are Vogt-Koyanagi-Harada disease, posterior scleritis, sarcoidosis, tuberculosis, as ma'am has mentioned. Also, lymphomas can also present with uveal deposits. But interestingly, in our patient, there was a presence of anterior segment inflammation, and overlying vitritis was there, and there is no evidence of any sarcoidosis, and there is weak MON2 positivity. So we did quite some lab tests, and all of them were supposedly normal. So all the blood culture, urine culture, chest X-ray, USG abdomen were within normal limits. So then we proceed ahead with vitreous biopsy. And as in some of the cases, culture can also be sterile. But in cases of those where the culture is sterile, we can still send the sample for PCR. And in our case, we could not identify the species, but the broad overall bacterial PCR of ribosomal RNA was positive. So we took it as a case of bacterial endogenous endophthalmitis and started empirical IV therapy. And quite to our surprise, the patient started responding to initial IV therapy of vancomycin and ceftazidime. So this was 3 days post-op. The macular abscess started to resolve, vitritis started to improve. And on 1 week post-therapy, you can easily see that the entire fovea is clear. The abscess has reduced drastically and the vitritis is so much clear. And after 1 month post-therapy, the patient had a vision of 660, though there was some slight amount of foveal scarring. But you see the patient is very well managed if the initial therapy is timely instituted. So whatever it is metastatic endophthalmitis, as you all know, it is the hematogenous spread of infection from the distant foci. And it is very uncommon form. It only occurs in 2 to 8% of all cases of endophthalmitis. And most commonly, the fungal are more predominant than the bacterial. In our Asian countries, sometimes the bacterial are more predominant, but most commonly Candida aspergillus should be taken care of. And in bacterial, most commonly Klebsiella. Even if it is in most cases it can be associated with liver abscess also, so it is notorious, it should be taken care of. And then Pseudomonas, Streptococcus and Staphylococcus. So before approaching any case of endogenous endophthalmitis, we must always look for the risk factors and address them. So majority of the risk factors are the patient always is there will be some amount of immunosuppression, or the patient may be diabetic, or he can have some systemic evidences of sepsis, organ transplantation, any history of immunosuppression, prolonged steroid intake. And most importantly, around 10% of these patients may not have any identifiable risk factor. So this must be noted out that not every person will have some risk factors. Some of them can develop endophthalmitis without any risk factor. And whenever we do cultures like to rule out any systemic sepsis, 44% of those cases can have either previous infection or can still have no identifiable source of infection. So we have to manage them empirically even before the definitive diagnosis is made, because timely intervention saves the eye. So pathophysiology, apart from in contrast to post-traumatic endophthalmitis, these are basically hematogenous. So the septic embolus and toxins breach the blood ocular barrier due to inflammation and then proliferate in the subretinal space, in the choroid, and later on in the vitreous. So the symptoms are similar to that of a usual endoph patients, but the signs are characteristic. So in the anterior segment, you can find cells, flare, hyperpion, iris nodules, but in the posterior vitreous exudates and vitreous involvement, vitritis is the hallmark, and you can always identify the species based on specific involvement, such as in Candida, you can always have the string of pearls appearance, or in Aspergillus, they are very invasive, so they have more of a vascular involvement. And presence of subretinal abscess, choroidal abscess can always have this doubt of metastatic endophthalmitis. So I want to highlight that this is a Candida endophthalmitis eye. You see the vitritis is quite less, but there are evidences of subretinal and string of pearls appearance. And in this case, in Aspergillus endophthalmitis, you can see it is very angioinvasive, and there is inflammation with ischemia. So importantly, while approaching, RAPD is always a very important prognostic marker and indication for early surgery, because it signifies the amount of damage that has already occurred. And in patients who are being treated in main specialties with suspicion of sepsis can have also candidemia, and you can get sometimes referral for ruling out endogenous endophthalmitis, as most of them might be asymptomatic or due to their systemic condition cannot tell about any ocular involvement. So we have to always do repeated sequential screening in those, because there can be sometimes normal examination initially, and as the disease will worsen, they can have these retinal manifestations. So there are some very definitive signs such as uveal tissue abscesses, vitreous exudates, and you can always see some necrotizing retinitis. And in later cases, as Dr. Manisha has told, in cases we can have panophthalmitis also. So these should be managed very early. So basic thing in cases of endophthalmitis, you always have to rule out the pathogen. You have to isolate the microbe. So in this case, vitreous biopsy is much more advisable, because the vitreous is more, there are more exudates, it's more dry. So sometimes the tap is not giving you that much yield. And as in our case, even if the tap was sterile, we did vitreous biopsy, and even if the vitreous biopsy culture was sterile, we immediately send the patient for culture sample for PCR. So PCR is very important. At least it gives you a line whether you are thinking in terms of a bacterial management or a fungal cause as etiology. Otherwise, systemically, you always have to rule out sample sepsis. So you have to send blood cultures, and always all the foci of infections need to be ruled out, such as urine culture, chest X-ray, abdomen USG, to look for any pyelonephritis, liver abscess, or any echo, 2D echo, or any CSF evaluation if required. And we have to rule out any history of diabetes. So we can do HbA1c, and always rule out tridot markers like HIV, you have to rule out. And in those cases in which fungal is highly suspicious, but you cannot get any culture, you can always try beta-glucan assay. It's an enzyme-based assay, and its sensitivity is not that great, and there can be high amount of positives also.
Dr. Divya, cut it short, please.
Yes,
time is going to be over, please.
Sir, so in ophthalmic, USG should be done to look out for vitreous exudates. And treatment is basically, you have to get an infectious disease consult if there, and you have to start initially intravenous antibiotics, systemic antibiotics. And if the vitreous is involved, you have to give intravitreal antibiotics also. And suppose if there is sight-threatening involvement, and so the vision is very less, or presence of RAPD, or if the lesion is non-responding, then we have to do an early vitrectomy. So systemic antibiotics are very important. We can give broad spectrum vancomycin and ceftazidime for bacterial, and for fungal we can give intravenous amphotericin B, and it can be continued for 4 to 6 weeks. So amphotericin B is also very useful, and intravitreal can be most active against Candida. Otherwise, as ma'am has told, voriconazole is now the treatment of choice for Aspergillus and other fungus. And as I've told you, the time is less, so early vitrectomy gives always the better outcomes. And I also want to mention that in cases of like non-resolving subretinal abscess, we can always try a novel technique which we have described at our center using a 41 gauge subretinal needle. We can always try injection of subretinal antibiotics or antifungal agents, and these can also help in early resolution of that abscess. And because it's a 41 gauge, so there is no there are less chances of retinal detachment postoperatively. So here in this case, the abscess resolved very good. And role of corticosteroids is conflicting, as there can be in fungal endos, it should always be avoided. So at last, I want to say that the prognosis from the etiology, these have the best etiology, Aspergillus and molds have the worst. And MRSA and other drug resistance should always be taken care of. Thank you.
Okay, that was a nice presentation. So I think our time is over. It's already 1:30. So I think we'll wind up the session. I thank everyone again. Yeah.
Rajiv, we can have a photo. Yeah.
Please switch on all your videos. I'll click a photograph.
Yeah, I'll request everyone to please switch on their videos.
Okay.
Ashish has bought a fantastic camera. So
no. Just click on everybody. Please click on your photo. Yes. Dr. Sanjay.
Yeah, please.
Sir, aap nahi aa rahe.
No, you asked
the video is not on.
Switch off the video. I started.
Switch on the video.
Switch on. Okay.
Nice talk, Divya.
Thank you.
Okay. Thank you.
Thank you.
Thank you. Well done, Ashish.
Thank you.
I think we have finished on time.
Right.
And thank you, everyone.
Thank you. Enjoyed the session.
And it was nice to see Manisha, Rajiv, and Bhuvan, Upar, everybody. Thank you very much. We enjoyed it. And it's a different platform, but
I think this is a new thing. Really enjoyed seeing everyone.
Right. Okay then. See you.
Okay.
Bye.
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 Hi, Sahil. Hello, sir. Praveen, sir.
Yes, hi, Pooja. So,
Hi. Yeah, I think we can.
Hey, hi guys. Good afternoon. Fantastic. In the middle of the busiest ever late OPD. So I'm going to disappear very soon.
right. Sir. So Dr. Praveen, I think first speaker, Dr. Sushant Ray, I'm not able to see on screen. So maybe we can wait for a couple of minutes and then get started with your talk.
He sent a message on the group that he's not going to be attending today.
All right, sir. So then we'll directly start with your talk in a couple of minutes.
Yeah, whenever you're ready.
Right, sir. So I think the program has been going on time. There is no point waiting. I think we should directly start with yours. We'll have more time for discussion and questions with you.
Yeah, certainly.
So
tell me whenever I'll start and
let's get the session started. I would like to invite Dr. Praveen Krishna. I have the pleasure of inviting. He has been my mentor and one of my favorites. He is going to start his talk on diagnosis of corneal ectasia on corneal topography. Dr. Praveen, over to you.
So Sahil and everybody else. So I was looking at the session details and I saw 6 talks on diagnosing ectasia on corneal topography. So I said that there's going to be too much repetition in a session. So I asked Dr. Namrata if we could actually change the topic to something else. And she was asking what else. And I said, let's talk about something other than keratoconus. And I just said that I'll give some examples of peripheral corneal thinning that is not very common in clinical practice. But actually, there are a few things that I think from the topography point of view, as well as the management point of view, that we've learned along the last few years. So I thought I'll probably share that instead of duplicating some of the things we're going to say. So
right.
I hope that is okay. So
sounds good, sir. Let's start with your peripheral corneal thinning disorders.
All right. So thanks a lot, Sahil and Pooja as well. And hello to everyone who's able to listen to us. So sorry to disappoint you if you are looking forward to listening to about different colors on the cornea. I thought I'll make it a little different by talking about the peripheral corneal. Which are one of the most thinning disorders that you will typically see in the clinic. Could be because of several autoimmune conditions or inflammatory conditions where you get perforations in the cornea as well. Could be degenerative, several furrow degenerations and other degenerative conditions that lead to corneal thinning in the periphery, could lead to thinning and in some cases ectasia as well. But what we are really interested in today, because this is a session on ectasia, is degenerative changes with ectasia in the cornea. So when you talk about degeneration with ectasia, there are three major disorders that we will be dealing with today. One is obviously Tyrion's marginal degeneration, where you tend to have peripheral thinning along with ectasia of the area of the thinning. Then you have pellucid marginal degeneration, where you tend to have thinning in the periphery along with ectasia just above the area of thinning. And you tend to have keratoglobus, which is usually global corneal thinning. So three major disorders. And the way I'm going to take you through this session is not talk to you about numbers, but talk to you about case examples about what you typically see and what is typically possible with cases like this. To start off with Tyrion's marginal degeneration, typically described as a superior area of corneal thinning, along with deposition of lipid, along with some peripheral vascularization. You tend to see a lot of variations as this as well. You will see inferior corneal thinning with Tyrion's with the same kind of vascularity as well as lipid deposition. And you also will see some cases where you have a 360-degree annular thinning in cases of Tyrion's marginal degeneration as well. So what do you do when you see a patient of Tyrion's marginal degeneration? This is a 58-year-old lady who presented to us with the typical thinning in the superior part of the cornea, along with some vascularity and some lipid deposits. And you can see that the cornea is very eclectic, as you see in this picture. So the area of the superior part of the cornea, directed visual acuity in her case was 2400, best corrected
Dr. Praveen, I think your audio and video now is breaking a little. So can we have...
So what we did in this case is going to be to isolate the area of thinning and then did a diamond knife. You cannot use a regular... I've just stopped sharing my screen if you can hear me.
Yes, sir.
We can hear you.
If you can see the video, let me know. If not, I'll just start skipping on to the slides where there is no video.
So yeah. Yes, sir. Now the video, we can see the case. Yeah, can see the case one presentation, but sir, his audio is breaking.
All right, so I'll just, the audio is any better, so. Any better now or no?
Now it is better.
All right. So, hey, I'm just changing my location, so hang on. I'll be back.
So what I can gather, Dr. Praveen is trying to show a video of anterior lamellar keratoplasty, something sort of a banana graft for pellucid marginal degeneration. The video was not able to stream properly, so let's see if we are able to get back to him again. Meanwhile, till Dr. Praveen comes back, we should have next Dr. Pooja, Dr. Ashu, Dr. Rajiv Mukherjee. Pooja, do you think it will be a good idea to start to go with topography sessions first and then come to Brilliant microscopy, or you would want to talk about Brilliant first?
Anything, I think, because mine is much advanced.
Right. So I think let's go about with the topography first and then come to Brilliant. So yeah, Dr. Praveen is back. We are going to resume with this talk first.
Hang on. All right, I'm back with hopefully better reception now. I hope you can hear me. Sorry to be so much of a
audio certainly better.
All right, so I'm back in my office now. So can I resume, Sahil, do you think?
Absolutely, sir. Go ahead.
So I'll skip the first video at least and just talk about how this is the same patient that you see who you saw with the Tyrians earlier, where we resected a wedge of the cornea that was thin earlier, and her uncorrected visual acuity improved from 2400 to 2080. And if you compare the pre-op and the post-op picture or the curvature of the cornea, you'll see that there is a significant reduction in the contour of the cornea. Just to drive home the point that several of these disorders cannot be managed by the traditional way in which we know how we manage ectasia. And you need to use slight manual corrections as well as customized treatment algorithms using your hands to treat these cases. So this is another patient of Tyrians. Again, I will not go through the entire video with complete annular thinning. So what we had to do in this case is we had to actually do a tuck-in annular keratoplasty all around to reduce the area of thinning. And eventually this patient did very well as well. So that's the pre-op as well as the post-op picture of the patient where we retain the patient's cornea, but we replace the peripheral cornea of this patient as well. So what happens if you have a patient of pellucid marginal degeneration? This is a 55-year-old lady who had pellucid. You can see quite severe, quite a large area of thinning as well, as you can see on the Scheimpflug image at the bottom. And you will see that the pellucid also has a similar topography picture as I showed you in Tyrians, but this is the typical butterfly pattern that people talk about. Uncorrected vision was counting fingers at 1 meter. And again, I won't go through the surgery, but then what we did was we did a lamellar patch graft where we manually had to mark out the area of thinning and then excise the area of thinning. And this is the post-op of the same patient, where you will see that the area of thinning is completely removed. Our uncorrected vision improved to 2200 and best corrected at 20/80 as well. So this was how we managed that patient. This is the fourth case of a pellucid again, where we had thinning that was not as peripheral as you saw in the previous case. And you can see the thinning here is more uniform. It's broader, so it's difficult to do a lamellar resection. So what we did in this case is we did a peripheral DALC, and using a PM, very large Strifine, we actually did a partial air bubble and then did a manual dissection. Again, I'll skip the video because this is just a regular DALC surgery. And eventually you will see that the contour as well as the thickness of the cornea is normalized in the inferior part of the cornea as well. So that's the pre-op topography, 20/400 uncorrected, and post-op 20/100 uncorrected. And you can see the change in the contour as well. Last up is keratoglobus, not particularly pertinent to what we're talking about, but this is where you have global thinning. This is the right eye of the same patient that was lost to trivial trauma. And this is the left eye showing a uniformly thin cornea all across. And for this, again, I won't show you the video because this, we did an epikeratoplasty, a tuck-in epikeratoplasty. And first day post-op, she was 20/200. And eventually you can see the folds on the cornea because of the thinning that was present in the host cornea. And she went back to 20/100. But most importantly, we actually gave her a secure cornea with very less risk of traumatic dehiscence of the cornea. So this is how this patient ended. So to summarize what we just spoke about so far about peripheral corneal thinning, this is another patient of keratoglobus. Again, very extreme ectasia with 2400 best corrected vision. So we did a penetrating keratoplasty. That's the OCT showing you the amount of ectasia on the cornea. So we did a penetrating keratoplasty for him, but that failed. And eventually after that, we had to do a DSEC, and he had very good vision recovery as well. So each case had different approaches, as you saw. But then I think the approach that I would like to take is if the visual acuity of a patient who has peripheral corneal thinning and ectasia is relatively good, of course, by all means, use glasses or contact lenses. Make sure that the eye is protected because trivial trauma, especially in cases of keratoglobus, can lead to ruptures. If required, do a lamellar patch graft for a localized area of thinning. If the visual acuity is poor and the thinning is localized peripheral, then the best procedure is a lamellar patch graft. If it is a generalized peripheral thinning, like I showed you, then the best procedure is going to be a DALC. But if the central thinning is also present, like in associated keratoconus or keratoglobus, you can either do a DALC, or in cases of large keratoconus, you can do a large PK, or in case of keratoglobus, you can do a epikeratoplasty. So thank you very much. And again, really apologize for all those difficulties with the connectivity. And I hope something that was useful that you saw in this short presentation. Thank you.
Thank you very much, Dr. Praveen. Thanks for the wonderful presentations. Cases of extreme ectasias, surgical management, certainly, which are very challenging. I think you were right that we have a couple of people talking about topography. So from the panelists, if we have some questions about this or anything to be discussed before we move on to the topography session. All right, sir.
I guess it's fine. Thank you.
Okay, thank you very much. So we'll move on to Dr. Ashu Agarwal, who will be talking about elevation-based corneal topography.
Sahil, is Shashwat there? Because I think he was supposed to set the ball rolling with basics of corneal topography. Because
right. So Dr. Praveen just mentioned at the beginning of the session that probably he messaged in one of the WhatsApp groups or somewhere that he will not be there.
Okay, so I think I'll have to reorient everything.
Right, sir.
So just bear with me for a minute because I had designed it so that I just talk about elevation.
No problem, sir. So meanwhile,
Okay.
I think we'll set
No.
up
I'll start. It's all right. I'll start. Just I'll have to do it on the fly. So just bear with me.
Right.
I'll share my screen.
So I think after this elevation-based topography, we'll have the talks on corneal topography interpretation made easy by Dr. Ashish Kumar and Pentacam by Dr. Rajiv Mukherjee.
Okay.
Dr.
So
please comfortable.
Should I start?
Absolutely, Dr. Ashish. Please go ahead.
Okay. Sorry, because I'll have to restructure things over here. I've hidden some of the slides. So I'll just jump to straight types of topography. We all know what topography is. We are here for that reason. And without further ado, I'll just talk about types of topography. So basically, if you look at the various topographic systems, now over the last 2 decades, there's been a dramatic change in topography. And it's now more of topography with tomography and these devices are combining a lot of things. So if we look at it, there are various systems. They work on the Placido ring system, which is the earliest one, and it still has a lot of relevance, especially in keratoconus and ectatic disorders. It is a reflective system. Then came the elevation-based system, which started with the scanning slit system or the OBSCAN, and then came in the Scheimpflug camera-based systems, the most prominent example of which is the Pentacam. And these were now followed. Now we have the OCT-based systems also, and the newer hybrid systems, which combine the benefits of all, like Placido plus Scheimpflug, like the Sirius, which one of our colleagues would be talking about, and the Placido plus the OCT, the MS39. However, the game changer, I believe, in all this was the elevation-based topography, because it really changed our outlook and made refractive surgery much safer and also diagnosing earlier ectatic disorders. Placido is always good for established ones and monitoring progression, but elevation was the real game changer, I feel, and this is what I would be confining my talk to. My colleagues will be talking about others.
Sir, sorry to interrupt you. We can't see your screen. I don't know if you've started.
You can't? Yeah, I'm sharing it.
It says
okay.
Screen sharing, but the slides are not visible.
Your screen sharing is paused. I don't know, but why is it paused now? Resume share. Okay. Is it? Has it started? Okay, I'll restart. Okay. Some problem, yeah. Let me restart. Okay. Can you see now? Hello?
No, not yet. The slides are not yet visible. It says screen sharing from your end is on, but the slides are not yet visible.
Is it? Now?
No, sir.
Is your presentation PowerPoint?
PowerPoint, it's PowerPoint.
Is it a full screen? And try keeping into slideshow. Maybe with slideshow.
It's in slideshow now.
Okay. Sorry, the slides are not yet visible.
Just a second. Yeah, can you hear? Can you see this now? Is it visible now?
Yes.
Yes, it is visible.
Okay, fine. So anyway, I'm sorry about this glitch. So as I mentioned, types of topography systems, we start with the Placido, the reflective, then came the elevation-based. Earliest example was the scanning slit system or the OBSCAN, followed by Scheimpflug camera-based, Pentacam being the most prominent example. Then the OCT systems, and now we have the hybrid systems like the Placido-based Scheimpflug and the Placido plus OCT-based system. Our colleagues would be talking about them. Hello. Sahil?
Admin, please moderate. Please mute the other people.
Panelists to mute themselves. Dr. J.S. Bhala. Yes, now it is on mute. Please, sir, go ahead.
Yeah, so what I believe that the elevation-based topography was the real game changer in our understanding of topography and making refractive surgery safer and diagnosing early ectatic disorders. So let's look at color coding. So now, because you'll see a bit of a mix-up here because this presentation I had to uncover some of the slides. So in Placido-based systems, basically placebo-based systems were the commonest, is still the commonest one, and it utilizes the reflective property of the cornea. It measures the curvature, and if the basic objective here is the various rings which are reflected onto the cornea, and the size and distortion of the ring patterns are the basis for calculation. Ring location relative to the center of pattern determines the radial distance, and the size of the rings and the spacing between the rings determines the radius of curvature. Closely spaced rings, that is over here, show higher corneal powers like here, and widely spaced rings have lower corneal powers. And it has certain advantages, like they are affordable, inexpensive systems, and they're reasonably repeatable for curvature and astigmatism, and been around for a long time. So people are familiar with it, especially the colored maps. And in short, it's a good tool, but it has quite a few disadvantages, that it does not image the posterior surface, which has become imperative in refractive surgery now. And let's look at the maps, the way they're presented. So what is the reason for presenting these maps? Now, if you look at this image, it does not tell you much except that there's some distortion. But when you do a color coding and the computer analyzes it, this is what it comes out as. It's something similar to what Praveen talked about a little earlier. So if you look at the color scale on surface curvature, for these placebo-based systems, the warm colors represent red and orange. Red and orange represent the relatively higher powers, and green and yellow represent the normal corneas, and the cooler colors like hues of blue denote the relatively lower powers. Right? So relative elevation, and in elevation maps, the surface there's a reference surface which is drawn. I'll talk about it a little later. And anything anterior to it is given the warmer colors, and posterior to it is the cooler colors. So I'll skip these because otherwise it's become a too big a presentation. So various topography patterns have been seen. I think one of our colleagues will be talking about it. And so coming to elevation systems, they provide much more information than topography. And there are two types, I said, essentially they start with the OpScan, which is the scanning slit system, and the Scheimpfler camera basis, or the Pentacam. So why is elevation important? So let's look at elevation versus curvature. Now, if this is a sphere and a part of it, this segment would also have fitted in here, but suppose you depress it, you remove it and put it a little behind this. The spherical curvature of A and B is the same as that of C and D. The curvature remains the same, but the elevation of A and B is different from C and D, and therefore elevation gives us a little more information. And this is again elevation data. So elevation, if you look at it, this is a Google Earth image of the Himalayas. Now we know that Himalayas are almost 8.5 kilometers high, but if you look at it from outer space or from a satellite, this imagery, the elevation does not mean anything. So which brings us to the next point, that elevation is a relative concept. It is relative to a certain surface, which brings us to the concept of reference surfaces. So for elevation maps to make sense, a close fitting reference surface is required, which could be any surface, which could be a sphere, a cylinder, a cuboid. So, but the best that we have seen, or the easiest to comprehend, and mathematically also it makes a lot of sense, is for the cornea, a reference surface, typically a sphere, is chosen and is constructed such that it fits the surface as close to the surface data as possible. For instance, this is yellow line is the surface. So you make a reference surface is generated, which is sort of averaging out everything over here, the surface. And relative to this, any point, as I mentioned earlier, anterior to it would be given a warmer color, anything posterior to it would be given a cooler color, and the best fit sphere would have a green color. So this is the so as I would just want to reiterate the point that for elevation maps to make sense, there has to be a reference surface. And the change in the diameter, when you look at the Pentacam or any other printout of elevation maps, a change in the diameter of the reference surface changes the values. So again, I said anything anterior to the reference surface is a warmer color, anything posterior is a cooler color. So now typically we are used to seeing curvature maps where anything which is a warmer color would indicate a higher curvature. However, in elevation maps, this gets reversed, because what happens is this curvature, this is the reference surface, and the green line here is a higher curvature, but part of it is going behind, so it will be given a cooler color. So this is actually the steeper meridian. The cooler colors are actually shown as steeper, and the warmer colors are refer to the flatter surfaces. A little difficult to understand in the first go for the audience, but by and by, if you look at it, you'll learn. So I think that's about elevation maps, and I think I'd like to end here. And because I think Pentacam would be taken by Rajiv, and others will be taking up the rest. Thank you for a patient hearing. Hello.
Hello. Yes. Thank you.
Can you hear me?
Yes, Dr. Ashu. Thank you very
much.
much.
I just wanted to highlight the concept of elevation maps, and I think our colleagues will be taking over from here for Sirius and the Pentacam.
Right, Dr. Ashu. Thank you very much for highlighting and delineating the difference between elevation and curvature-based maps. And I think initially when elevation-based maps came in, a lot of people shifted to thinking that elevation maps are much better than curvature-based maps. But both have their individual importance, and both have to be taken into consideration while interpreting tomography map for any evidence of ectasia.
Absolutely, Sahil. I couldn't agree more, because we all jump to elevation maps, and they're great, no doubt about it. But I have always believed that Placido has its own place, and which is becoming manifest now. If you see the newer hybrid devices like the CS and they're all employing Placido maps also. So I think it'll be a combination in going forward. It has to be a combination of technologies, and that's what will make the real difference. So we cannot just be elevation or this. You cannot have cams over here in the interest. So I think future is going to be interesting, and already these devices are making a lot of significance. Thank you.
Thank you very much. So next we'll have a talk on Pentacam by Dr. Rajiv Mukherjee. If Dr. Rajiv is here.
No, I think we'll move ahead with Dr. Monica if she's ready.
Sahil, if Rajiv doesn't come in, I could take up, because I mean, I'm all ready with the Pentacam thing. This essentially was a Pentacam presentation, but let's go forward. If maybe Rajiv will join us.
We'll go ahead with Dr. Monica first. She'll be giving us a brief on Cirrus Topographer, how to use it and how to interpret. And followed by that, we can have Sir again or Dr. Rohit Shetty for the MS-39, because that's a different type of a topographer. So.
Thank you, Pooja. I hope the screen is visible.
Yeah, definitely. You can go ahead, ma'am.
Okay, thank you. So I'm really thankful to Namrata ma'am for this wonderful opportunity. And I'm also thankful to Ashu sir for making my job very, very simple and easy. So I think he has already given us a brief about how to interpret a map. So I will, in these 7 minutes, I'll just be letting you know that this is kind of a Pandora's box. I would like to tell Cirrus like a Pandora box, because it has so much that it's extremely impossible to cover it within 7 minutes. But as you know, you get into the machine, you come to know that how much can you do with this. So starting with the features of Cirrus, it's actually a combination of P-Flug and Placido, which is the best combination, as also highlighted by Dr. Ashu Agarwal. And it also has anterior and posterior corneal topography, which gives us sagittal, tangential, curvature, and elevation maps. It also gives us corneal pachymetry at different levels of cornea. It is very helpful in keratoconus screening. There are a lot of criteria which we need to take into consideration while reading the map for keratoconus screening. But to make it simpler, the machine has already gives you that it is whether it's a normal report, whether it's a keratoconus suspect, or it's a full-blown keratoconus. So even if somebody who is not much into topography can easily just look into the interpretation from the company, and you can go ahead on that basis until and unless the report is quite confusing. It also has a very beautiful feature of pupillometry. So it gives us pupil measurements in all the different conditions of light. So that is very helpful in deciding the optical treatment zone for laser firing, so that the patient does not have complaints of glare and halos during the night time. And it also gives us anterior chamber analysis. There is an IUL module which is optional in this machine. It is also helpful in analyzing the tear film, which helps us in treating our dry eye patients, even for pre-LASIK evaluation. It also has meibomian gland analysis, though it is a little tedious one, because you have to trace it. Nowadays there are newer machines which make your job much simpler, but still if you have Cirrus, it's very easy to do the meibomian gland analysis, and you don't need any other machine for the same. It also helps us in contact lens fitting. It has corneal aberrometry. It helps us in intrastromal ring planning, even a little bit in glaucoma screening, and we can compare different maps. So it mainly is Scheimpflug's based principle plus Placido disc. So there are around 22 Placido rings, and acquisition of 25 Scheimpflug's frame and 1 keratoscopy in less than 1 second. We can imagine how quick it is. It also has integrated pupillography, as I told you. And each Scheimpflug's picture is 640 points. So when we acquire 25 images, it's close to 16,000 points, right? And these are available both from anterior and posterior surfaces. So it becomes doubles, that is 32,000 points. And we also acquire some points from Placido. So in total, it covers 37,632 points. So this is how the quad map appears. It gives us corneal thickness. It gives us tangential anterior elevation, posterior elevation. And so it's guided tridimensional manual acquisition. And because it has 2 cameras inbuilt in it, that is one of the most important feature of Sirius. So it has got 2 cameras. So it also gives us a 3D view. So in maps, we have Scheimpflug's pictures, anterior and posterior sagittal curvature, anterior and posterior tangential curvature, which is also known as instantaneous curvature. And we have anterior and posterior elevation maps. We have corneal thickness map, anterior and posterior refractive power, equivalent refractive power, and it also gives us anterior chamber depth, which is extremely useful in planning our phakic IULs. So as I was telling you about pupillometry, this gives us a pupil size in all the 3 different light conditions, that is scotopic, mesopic, and photopic. And it also gives you a graph. It's like a dynamic kind of a thing, that how much is the variation in your pupil size. So there is keratoconus screening also, as we have already discussed. It is very difficult to go into the depth of the whole parameters which are there, but it actually considers curvature, asymmetry of front and back, BCV factor of front, back, and total, thinnest pachymetry, vector analysis, and elevation of anterior and posterior with normality and all local points. So it, as I told you already, it gives us normal, suspect keratoconus and keratoconus reports. So which makes our job much, much simpler. It's not much needed to remember all the values, because it's little difficult. It's in point, like, you can see curvature, asymmetry, front is like 0.757. So you need not remember all this. Just take a printout of it and keep it close to your Sirius machine, so that you can easily go through it. It also gives us corneal aberrometry. So if you want to plan your customized treatments, you can do that. It also gives us the quality of vision in patients, who are unhappy patients post-surgery or even pre-surgery, if we want to know what is their, visual quality. And even in post-cataract patients, we can use this modality. It also helps us in contact lens fitting, though I don't use it much, but then it has got that feature also, that if you want to do some auto fit contact lenses, Cirrus will be helpful in that also. This is one good feature of Cirrus, which gives you TBIT, which is tear film breakup time. And it also gives you a graph, and no doubt we can do it on a slit lamp, but because this gives you a printed report, it becomes very easy for you to explain the patient. And if you're treating the patient, when you do a follow-up report, you can explain and show them the difference. So that is how it becomes helpful. As I already discussed, that this also offers meibomian gland analysis. So it's little tedious, but then still it's a good feature that Cirrus has to offer us. We also can see the angles. So this angle evaluation is useful in glaucoma or to rule out any iris cyst, or even in phakic IOL patients if you want to see so in them also you can use this modality. And this IOL module is there, though it does not give you the axial length, but if you enter the axial length, you can get the IOL power through Cirrus, as it uses the ray tracing technology. So thank you very much for the patient listening.
All right. Thank you very much, Dr. Monica. So we are going to talk about 3 tomographers. Dr. Monica just finished with Sirius. Next, if Dr. Ashish can talk about Pentacam, and then we'll have Dr. Rohit talking about MS39. All of them basically ultimately end up giving a mainstay is a quad map, which ends up giving corneal tomography, anterior posterior corneal surface, curvature based and elevation based. They have slight differences in the technology. So let's see if Dr. Ashish, would you like to go ahead with
Sahil?
Who is taking care of this?
No. Can we wait? Should we wait for Rajiv, and maybe we can find out? I could call him because it would be only fair to, maybe he's joining in late.
Right.
So I think let Rohit continue. In the meantime, I'll try to find out from Rajiv if he's coming in.
Okay, so can I share my screen?
Absolutely, sir.
But it says that I can't share when somebody else is participating.
I think Monica is already sharing her screen here.
Done, sir.
Okay, I'll just. Is my screen visible?
Yes, sir. Your slides are visible now.
Perfect. So would like to thank the entire DOS team and Namrata ma'am for this opportunity. I'm going to speak about a new hybrid tomographer, MS39, a new insight. These are my research grants. Basically, my talk is divided into the whole concept of indices, and that's what we're going to discuss today. The cylinder, the mystery of progression, and all that play a very important role in for a topographer. This is something which we published in this current issue of IGO about different indices, which helps to look at keratoconus screening. And the question still comes to mind is, are they adequate in today's refractive surgery? Because we have a huge amount of masquerades. And one of the masquerades is the epithelium. What we all require is we need to understand what is happening at the stroma. But what we are actually seeing is that the epithelium, and epithelium has a huge variabilities. So there are different machines which actually give you topography indices, some give you epithelial indices, but we need to look at something which can mix both, There is not a single topography which gives you both of them together. And that's what MS39 has. it has stromal thickness, epithelial thickness, maps, all your maps. And what is important here is the stromal elevation. So what does stromal elevation do is actually it subtracts the epithelium and it gives you elevation out here. This is the stromal elevation. And that means that this map here is without the impact of the epithelium. That means this is coming from your Bowman's surface. And that is the most important thing in this form of tools. So when we look at maps like this, and when we are worried about these kind of small elevations, see, anything which is classic, we are not worried about it, but we are always worried about the small bumpy changes when you don't see much on your posterior surface. And then what you see here is this huge lump of epithelium, which is showing a change. And when you see the elevation, this is actually matching with this. This is with the epithelium. You see that there is some amount of elevation, but when you see the stroma, it's absolutely normal. And your post elevation is absolutely normal. So this patient actually looks like he has some change, but it's all the epithelium, and this stroma actually picks it up. And you can see that the biomechanics also is normal, which means that the biomechanical measurement is also dependent on the epithelium. This is a male, 22-year-old male with a refractive error of plus 1.5, both eyes. And you can see that there is a huge amount of elevation out here. The biomechanics is normal, the body looks abnormal. And you can see that that elevation is actually with the epithelium, but when you see the stroma, it's normal. So again, it matches to what you're trying to see. Otherwise, you would have labeled this as a superior keratoconus. The second part is the mystery of progression. Progression heavily depends on the type of epithelium you have, and the thickness profile has been described by Ryan Reinstein. We also have trying to find an AI-based profiling for the epithelial in progression. You can see that this is a baseline follow-ups, and you can see that this whole area shows that it's progressed. The question is it a true progression or a pseudo progression? And you can see that in this case, the epithelium here has actually become a donut shaped, and this elevation at the stroma has become 47, which is it's a true elevation. That means a true progression. But also, this is a paper which we published. What we see here is that patient actually showed an epithelial thickness change, and this thickness change actually was responsible for showing a masquerade. That means stroma was actually normal. There was no progression. The elevation was actually normal, no elevation. It's only the epithelium was actually trying to create a masquerade. So this is a very interesting thing which can only be picked up by this. And this is what the progression is, and this is what I just mentioned here. At when you have an epithelial change, and you can see that this is the epithelial change after say 4 to 5 months, and you can see that what was 47 has become 63, and that itself is showing as an epithelial thickness changes. But when you actually see the stroma is perfectly normal. That means the cornea has not progressed at all. This patient, even though the curvature map showed 2 diopters of progression, but the stroma showed absolutely nothing. So it was completely normal. So this is not a progression. So if you are dealing with the keratoconus or even progressive myopias of post-LASIK, understanding epithelium is very, very important. There's a lot of work on epithelial cylinders, and epithelium also have a huge impact in the type of cylinders. This is a keratoconus and normals, and this also gives you an epithelial Zernicke, which is very important because it tells you how much of cylinders is compensated. In this, it's 0. It is normal, but here it's in keratoconus, it's 2.5 diopters of cylinder is coming from KC. And this is very, very useful for us because it tells you the amount of effect of KC on epithelium on the KC. And this again tells you that there is this is 0.95 diopters of cylinder. And here it's in normal, it's normal. So it is very important, especially if you're planning your contour on one of your treatment, because imagine 1 diopter of cylinder is only from your epithelium, and this is going to have a huge impact in the outcome of surgery. And this just shows the impact of what happens when you do a surgery. The future is we're trying to build an AI on the same platform. And this is something which we have already done on a Pentacam, but we have also done something very interesting on MS39, and we have built our own model, which the company will incorporate hopefully over time. And this is what we have submitted for in review in AJO. And finally, what I'd like to say is it helps to look at multiple epithelial masquerades. I'm very excited about epithelial Zernike profile and the cylinder and its impact on treatment. There are a lot of new things. I think Pooja has discussed about polarization sensitivity, which can be combined with this. AI is a real future. Company itself has a lot of program on it, and we are also trying to build a lot on that aspect. It's extremely new and hybrid tool, and it really helped me many times in my refractive practice. Virtually, I don't do case, or I don't see a post-op for my patient or a follow-up of my patient without having a report of this, because it really makes me look at the disease in a different perspective. Thank you, and thanks DOS and the team for this opportunity.
Thank you, Dr. Rohit. Thank you for the wonderful talk. A few questions I would like to start with is, the stromal maps, are they only elevation maps, or does it also give a stromal based curvature map?
At this point of time, it's on an elevation map. It just gives you an elevation data. There's not much. They have them small normative beta database of their own, like Pentacam. They don't have a real robust one, which we are trying to build. But mathematically, we can calculate. We have our own software which can calculate the curvature maps also from the Bowman surface.
All right. And what about the repeatability of stromal curvature map, stromal elevation based map? And is there any cutoff suggested to say, like in progression, we say for curvature maps, it's more than one diopter. So for the stromal elevation based map, is there any cutoff you suggest that this much is progression and repeatability of machine?
Yeah, we did. I think that's one of the papers which is in review now. I think the repeatability, because it's an OCT base, the repeatability is pretty strong. I think we are looking at in the factor of around 4 to 5 is the value and the repeatability. So I would consider this as a significant elevation if I see more than 8 to 10 value change. If it's 37, that doesn't have a real number. It's not a millimeter, microns and all that. It's just that number. So if it has around 8 to 10, I would consider this as a change. Anything less than 5, I would still keep it as under repeatability factor.
All right. All right. Thank you very much.
Thank you.
So from the panelists, if we have other questions or other things to discuss. Meanwhile, I think next talk we wanted was on Pentacam. If we do not have Dr. Pooja, can you please meanwhile get ready with your Brillion microscopy? We kept Brillion intentionally at the end of the session because after finishing all the tomographers, Brillion is the...
sorry to interrupt. I just talked to Rajiv. He has some internet problem, but he's trying to get into the system. So maybe he just wanted us to, defer his talk if he comes in, fine. Otherwise, I'll take it up. That's his request.
All right. All right.
So I know this will upset the order, but let's go ahead with Pooja, I think.
All right, Pooja.
No problem. Thank you, Sahil, and thank you, Namrata ma'am, and the entire DOS team for giving me an opportunity to talk here. So I'm going to be talking about Brillion microscopy. I have no financial interests here. What a lot of it is going to be in literature, because this is relatively a newer tool which many of refractive surgeons are trying to understand. So I'll make it quite simple for us to understand, and a little bit I'll be touching about what we are doing in practice today and how we can take a few tips back home. So we have a lot of indices at this point of time. Topography has been covered quite nicely by my colleagues. So what I'm going to do is we have Corvus. Like when you have topography, the second tool which came was the biomechanics, which said that it was quite additional. It gave quite a nice additional information of whether your corneas are healthy or not. And it helped us in detecting whether like the suspicious corneas, like it helped us in detecting normals from the suspicious cornea. So when Corvus, one one of the best nice tools is Corvus. It gives us various parameters like CBI and TBI, and it is said that it has an excellent sensitivity and specificity of around 90% to differentiate the normals from the suspect. So it helps us in telling that, you should operate this eye or you should not operate this eye. However, there were few challenges here, and the next thing which was introduced was the stress strain index. Stress strain index is nothing but it is based on the Young's modulus, which is the foundation of your biomechanics. And stress strain index, it was said that anything lesser than 1 is said to be a softer cornea, and anything more than 1 is known to be a strong cornea. However, here also there was a small challenge that the normative range, which is given of 1, lesser than 1 or more than 1, was based on the population. The studies were done on the elderly populations, which was around 50 years. So we still need to come out with a normative range for younger population, and we still need to know the role of it. Also, if you see that biomechanics, there is a major challenge that whenever you need to know the strength of the cornea, the biomechanical property of the cornea, we have to measure the modulus. But whenever you do ORA or a Corvus, it deforms your cornea. And whenever there is a deformation of the cornea, some amount of the material properties, like the viscoelastic properties of the cornea, would not be understood. So very minor changes which are there between the normal and the suspect eyes would be missed because there is a deformation. And that is why a lot of times, even though your biomechanics along with your topography is within normal limits, your patients land up into ectasia because of the deformation, the material, like this minute material properties are not studied. So that is one challenge with biomechanics. So a lot of groups started working on this newer technologies, which is the Brillion microscopy. What is Brillion microscopy? It is nothing but it is a non-destructive. It is first of all, it is contact-free, and it is a non-destructive method which can help us studying the viscoelastic properties of the biological tissue, and it can also help us in studying from a 3-dimensional aspect. It has been started, and various other branches. Our colleagues have. Yes, ma'am. Oh, sorry. So in cancer, to study the cancer tissues, they also study the zebrafish structures, and off lately, since past few years, its role has also come in various eye diseases. What are the advantages is that as I said, it helps to even as it doesn't deform your cornea, the subtle differences also of these biomechanical properties are detected. And the second advantage is that it gives you idea of at different depths, from depth of 0 to from your surface to your endothelium. It gives an idea of how your biomechanical strength of each of the layer of the cornea is, and it also gives from a 3-dimensional aspect. So that is how you will come to know the entire information with this Brillion microscopy. Now the principle here is it uses a low power, narrow bandwidth laser light which focuses on the corneal tissue, and it catches the acoustic waves. Now how does it catch the acoustic waves? The acoustic waves are naturally present in the cornea, which when this laser light is thrown on the cornea, it just picks up and gives us this information about how the biomechanical strength and the modulus of the tissue is. It gives us in various dimensions from the center to the periphery. So this is how your Brillion map of your cornea looks like. It tells you, depending on your thickness and posterior elevation, of what actually the strength of the cornea is. So basically they say that it is little bit more sensitive than your biomechanical properties. Our group is also supposed to start work on the same, but because of COVID, our machine has been stuck still with the manufacturers. So hopefully we'll have our data as well soon. So how is it useful in clinical practice? Again, as said, it helps us in picking up the minute discrepancies between your normal and your suspect corneas. This is how your normal eyes look like from a 3-dimensional aspect. Your flat cornea, your relatively a steeper cornea, what are the differences it shows? If you can see here, the normal has more of a, I'm just trying to make it simple, more of a blue color. It gives you values in the gigahertz. And as the cornea becomes steeper or as the cornea becomes weaker, you can see the less of the dense blue color. this is how your keratoconic grade eyes look like. You can see here in a higher grade of keratoconus, you can see more of greens. The blue is becoming lesser. And again, in grade 3 and 4, you can see more of red and the yellow areas. Like that is more weakness. So basically, it gives you an idea about at which layer, at which thickness, how much weakness is present in the tissue and at which zone. So it will be like giving us a detailed information on the same. It also helps us in Scarcelli et al. And group has studied that this technique has been extremely sensitive to detect the differences between the stiffening from anterior to the posterior cornea, and it was also successful in detecting what are the differences between cross-linking protocols and the laser-based cross-linking therapies. So the ideal and the most ideal advantage of this tool would be to have a better characterization of the biomechanical changes before and after refractive surgery. It will help us in decoding healing of each refractive surgery and also help us in predicting outcomes. And you can also know that whether your patient will land up in ectasia or not before surgery. So it's going to be having a much more detail, and the dilemma of which procedure is stronger or not will also be solved when this tool comes into practice widely. But however, whenever there's a new technology, there are always limitations. So what is the limitation of this Brillion microscopy? At this point of time, if you all remember, when the first computer came into market, it used the entire room. So same thing is with the Brillion microscopy. It takes like your 2 to 3 OPDs of a space at this point of time. So it needs to be made smaller for us to bring into practice. It is lot sensitive to the temperature, and a little bit of alignment issue or vibration when the patient is breathing also will land up into a lot, it will not give you the correct information. And of course, this is a newer technology, so it will take a little bit of time, and it's a robust tool to come into practice and make it as simple as our topographers are. So do we have any similar technology? Yes, we do have a similar technology, and our group has been working on it for like 2 years. How? Which is the technology? It's called imaging the collagen with the polarization sensitive OCT. Now, polarization sensitive OCT is like nothing, but it's an OCT where a polarized light is subjected on a surface, here the cornea, and all your structures take up this polarized light, but the stroma doesn't take up the polarized light. And the main defects you would like to understand is on the stroma. So what happens is when the stroma doesn't take up the light, it shows how the collagen orientation, it gives a lot of information about your collagen in your cornea. It tells you how the orientation is in your cornea, whether it's dense, whether it's less, and how, whether they are tightly attached to each other, whether they're not tightly attached to each other, and multiple information. If you see this diagram, this is a theoretical representation of how an ideal collagen bundle in your stroma should be. And if you can see the similar representative image here, this is wonderfully shown about how this collagen orientation in a normal and healthy eye looks like when your topography and biomechanics is both within normal limits. So this is just an example of how a normal cornea, if you saw the maps I showed with the Brillion microscopy, we have done a similar thing with the polarization sensitive OCT, where we are trying to understand, where we have developed color-coded maps of how the orientation of collagen is in your stroma. So denser and more denser the blue is, the better orientation of collagen is, and the more of red means that it's loosely attached or there are absent collagen fibers there. So this is how your normal looks like. This is keratoconic expected, then they're going to have lesser collagen. But the interesting part is to study the thin corneas. Now, this both are almost like, yes, one is a steep cornea, but both are almost normal looking symmetric bow tie pattern. But however, the corneas are thin, so you would not go ahead and do a surgery for this patient, expected, but, and probably would do, if it's a low power, you would do a PRK, an extra procedure, or if it's a higher power, you will do a ICL surgery. But just for our interest, we wanted to know that what is the difference in this collagen orientation of both these patients. So we did a polarization sensitive OCT. If you can see that similar thickness, almost a steep cornea, but the collagen orientation is different in both your eyes. Here it's dense collagen, here it's like a little, it's not as dense, and it matches your keratoconic eye, and this matches your normal eye. So we're just trying to say here that this polarization sensitive OCT is going to help us depict that which is a healthy cornea where you can go ahead and do a surgery, and which is an unhealthy cornea where you would probably not do a surgery and keep the patient on observation or do a different procedure like a phakic IOL or something. So it gives like, it just matches your Brilliant microscopy, and it gives you all the information required, which probably at this point of time our normal topographers are not able to give us. This is just to show that these are the keratoconic and thin corneas and how nicely it matches with the Brilliant maps, which is still to come in our practices. Another thing which we are working on, it said that whenever you're working on a biomechanical tool, you need the real future would be to predict the outcomes of your any refractive procedure, or you would to predict how your keratoconus progression is going to happen. So our team has developed this software, which is known as AccuSim software. This work is based on one of my colleagues and both our PhD works, Matthew Francis and mine, where we have done this work with finite element modeling, which is a very useful tool in biomechanics when it comes to biomechanics. And here we have actually shown that how we can predict the biomechanics prior to the surgery of like each of the procedures, SMILE, LASIK, and PRK. So before surgery only, if you have your Pentacam and Corvus at this point of time, we are working on other machines, you can predict how much weakening will happen post-surgery, and whether if we do a surgery, patient would be safer post-refractive surgery or not, what the outcomes will be. We can actually predict it before surgery only. And the in vivo, we have done this study already, that the in vivo and the simulation result, like the simulation and the actual outcomes are actually matching in all the three procedures. The dotted lines are the simulations and the straight lines are the in vivo results, and they quite match. So we know that this software is giving us the right information of the post-operative outcomes. So this is just a small video on how this software works. At this point of time, as I said, you need both Pentacam and Corvus, but we are also, and we have integrated MS39 also in this software, and we will be working on different other topographers to inbuilt in this again. So you just, it's very simple. You need to do, if you have the scans, you just need to take the CSV files of both Pentacam and Corvus. When you have the CSV files of both Pentacam and Corvus, you just upload it in the software. You enter your flap thickness, the flap diameter, or the cap diameter if you're doing, you can here choose which procedure you want to simulate the outcomes for, the optical zone, the refractive error, and you can choose the corneal thickness if you want just to put manually, or if you want to again export the CSV files and do it. And you just click here to run the files. And at the end of, at this point of time, yes, it is taking an hour, but we are working on it to make it faster like our topographers. And at the end of 1 hour, it just shows you what the results are. So I'm just going to this is how your report looks like. This is like how much change in the post-operative thickness would be, and here it's showing the change of 31 nanomiles. So whether it is ideal to go ahead and do a procedure or not. So this is just a case examples, again similar looking topographies, but one patient has a normal bad D, suspicious biomechanics. The second patient has a suspicious bad D, but a normal biomechanics. Similar curvature, similar thickness, similar refraction. So we were just curious on what would happen if we go ahead and do a procedure for this patient. We ran them on our AccuSim software. And if you can see here that the predicted change in corneal thickness in both the patients, it's quite different. So the patient who has like a normal bad D, it's showing a lesser predictive change compared to the patient who has a suspicious bad D. And this would actually help us in showing that, whether it's safe to go ahead with a surgery, or if you do a refractive surgery, you'll land up in a problem. So before taking up a patient, it's not for all the patients, but yes, wherever you have a doubt, you can run them on this software, and it will actually give us a lot of information about whether it's safe to, whether you are going to burn your hands or not. So just to summarize, yes, Brilliant microscopy is relatively a newer tool, which will help us, give us a lot of information for our refractive surgeries, for our keratoconus, and also help us know the cross-linking outcomes. But yes, at this point of time, we do have a polarization sensitive OCT to differentiate the healthy from the unhealthy corneas. And the real future would be to integrate topography, tomography, and biomechanics in one AI-based software to know which patient is going to be happy after your surgery, and or which patient you are going to burn your hands with. Thank you.
Thank you, Dr. Pooja. That was an excellent talk on Brillion microscopy and what the future holds for us. And I think you guys have been doing, have been at the forefront and doing tremendous work on it. Before we go to the future, I would like experts and panelists' view on which they think would be the best value for money tomographer. So what we have talked about, and probably we'll be talking about Pentacam at the last, but can everyone chip in their views and comments that if a newcomer, a new cornea specialist has to buy and invest in one of the tomographers, what would they put their money on? Would it be Pentacam? Would it be Galilei? Would it be Sirius?
Okay. Who wants to go here?
We'll start with Dr. Ashu.
Okay, so as I mentioned in my presentation earlier, if you were just talking about established ectasia, a Placido-based system does very well, but it would not be a sufficient tool. So you need something which does analyze the posterior surface. And if you can afford it, like you said, someone starting out, so I presume that affordability would be a major issue. Ideally, we would all like to have what Pooja is talking about, and what Rohit has talked about. But yeah, so if expenses are a limitation, finances are a limitation, you could go with the Placido, start your practice. But whenever you have the opportunity, or if you can do it at the outset, go for an elevation-based system, for which I would say Pentacam, Sirius, they are good options, all of them. The thing I like about Pentacam is that they've, it's sort of become a gold standard for, even if you're understanding topography, you're learning it, because we're still all trying to learn. None of us can claim to be an expert in it. I think Pentacam does a good job of, helping a person learn topography, also tomography, and, so it has standardized things. A lot of work is continuously being done. But yes, if you can afford more, then there are other tools also. But I think the basic that you should aim for is a Pentacam, if not a Placido, if you can't afford that. That's my view.
All right. Thank you, Dr. Ashu. What about others? We have other experts as panelists. If anyone is online, Dr. Vikas, Dr. Uma, Dr. Yogita, Pooja, what would be your preference? So what you would be talking about Brillion, I think it's the future, yes, and we would love to get our hands on it. But for those in real world who can get access to the tomographers, I think one of the reasons, Dr. Ashu, you said Pentacam is it also has maximum data available on it, and most of us are very, very comfortable with it. Sirius and Galilei, technologically, they are more advanced. They are a hybrid system, unlike Pentacam, which is just Scheimpflug based. But because of lack of information and data, they have not taken off as well. But
yeah, that's right.
If asked about value for money, what would others believe would be the best choice, best tomographer to invest into?
I would say that I agree with Dr. Ashu. A lot of us are comfortable with Pentacam because it's been used since a long time, and it gives you a lot of information. We here use almost every tool which we discussed today: Pentacam, Galilei, Sirius, MS39, everything. I would say comparison, which my mentor would keep on saying, comparison is the thief of joy. You have to be, all topographers are almost similar. If you say value for money, I would say you have to be comfortable with your machine. So if you know your machine right, that what information your machine is giving and how to interpret it for your practice, I think all the topographers are same. And whatever you're comfortable with, you can go ahead. But my two favorite machines will be Pentacam and MS39.
All right. So any other panelists and experts would like to chip in? Okay. So Dr. Ashu, for Pentacam, do we have someone coming in?
Is Rohit, sorry, Rajiv here?
Can't see on the screen.
Okay, so maybe I could go ahead.
Yeah.
You decide. You're the boss here.
Yeah. Please go ahead. We have another 10 minutes in the session, and
there's another talk, I think. No.
Now, basically, it's a domain of the.
Ashish, oh, he's not here.
Yes, sir. So
yeah.
Okay, so I think there's no choice, but we'll go ahead with it. Okay, so I'll just share my screen.
Like we have to, get targets. Absolutely. And the point is that this is a common complication and everybody do encounter it. But the whole idea is not to
there's some disturbance from some other session, some FACO session. Yeah. Sahil, can you see?
Sir, we can see, sir. We can
Okay. So I'll be talking about Pentacam now. And I think, as we all know, it's a rotating Scheimpflug camera-based system and provides crisp images of the anterior segment. And it was the first of its type, and of course has had the first mover advantage. And it essentially is a tomographer and captures right from the anterior corneal surface to the posterior capsule of the lens. And it's based on the Scheimpflug rule, which describes the optical principle. And basically in conventional cameras, the object plane, that is the film plane, the lens plane and the subject plane are parallel to each other. However, in contrast, in Scheimpflug cameras, these planes are oriented at an angle to each other, and they intersect at a point called the Scheimpflug line or intersection. So this is to illustrate, these are the cameras that you see. Normally the subject plane would be here, but here they are, the film plane is here, the lens plane can be tilted and the subject plane can be a little away. So it measures various things like, and these are the functions that it performs. I won't go into these because for this session, we are talking only about ectasia. And this is the most commonest 4-map refractive display of Pentacam, which everyone's familiar with. It measures corneal thickness, the curvature map, and it gives the front and the posterior elevation. This is the keratoconus indices map. And again, a lot of us would be familiar with. And this, these maps can be presented in, the data can be presented in various formats. And this is the pachymetric display. So let's talk of screening parameters for ectasia. So as I mentioned in my talk earlier, the best fit sphere is the concept that is very important here because it's the elevation is relative to a surface, and this is the best fit sphere. Check the size of the best fit sphere because these influences the borderline numbers. And in anterior elevation maps, if you're going with anterior elevation maps, I'll just go back to show you what the best fit sphere, where is it mentioned? In the 4 map, if you see the diameter, this is the diameter of the best fit sphere, 8 millimeters. It's customizable also, but typically 8 and 9 are kept, 8 or 9. So if it's a 9 millimeter zone of best fit sphere, on the anterior elevation, any point less than 12 microns is normal. Anything more than 15 is indicative of keratoconus. And between 12 to 15 is suspicious. And numbers on the posterior map, there's 5 microns or higher. And in the 8 millimeter zone of best fit sphere, the anterior elevation maps, anything less than 8 is normal and more than 8 is indicative of keratoconus. Posterior surface, anything more than 16 is indicative of keratoconus. So if you look at here, the map here, this is the elevation back surface, which is what we're going to take here. The highest point here, or at least around, this is the pachymetric, the thinnest point. This is +3 over here. So anything more than, and the diameter is 8 millimeters. So anything more than 8 would have been suspicious, but here it's absolutely normal. Here, if you see, the diameter is 8. Anything more than 8 would be suspicious, but it's a patient of keratoconus. And we have readings from 59 to 74 over here. So this would be, again, suspicious, although this is a very apparent case I've taken just to highlight the case. And here, of course, the indices are all seen, which are in red, which indicate that is a case of keratoconus. Coming to a very important parameter that we study in this Pentacam is the Bellin-Ambrosio enhanced ectasia maps. This new display combines elevation and pachymetry data. It contains no curvature information, please note, and it's a combination of elevation and pachymetry data. And the elevation maps using the best fit sphere are displayed. And as usual, the whole cornea is fit to the sphere. I'll just explain this. There's a little difficult concept to understand in the first go. And then the map is enhanced using the whole cornea except the 4 millimeter zone around the thinnest spot to fit the sphere. The thinnest area, 4 millimeter around that, is excluded. And then a difference of both is displayed. And the advantage is that it gives a pronounced cone, that is highlights, it enhances the ectasia artificially. So it's easy for us to understand. And it has a traffic light evaluation, as we'll see. So this is let's assume this is the keratoconus, the bulge in the center, and this is a normal cornea. If you do a best fit sphere here, this is the average value that would come of the sphere. Suppose you were to remove this is the thinnest point, 4 millimeter around it is removed. You ignore this part, you end up with this sphere over here, and the best fit sphere would be this red line red circle semicircle indicating. So this is the enhanced ectasia. This is the enhanced ectasia. This is the difference. The difference between these two best fit spheres would be very highlighted. Contrasted with a normal cornea, this is the best fit sphere. If you remove the 4 millimeters around the thinnest area, it would still be more or less the same. And therefore, in this, there would be no significant difference in the best fit sphere new reference surface that we have here. So this is what we see here. A normal cornea would look pretty much the same when the central 4 millimeter area is removed, whereas in the case of keratoconus, it would be very different. And this is what is happening here. This is the right eye. This is called the Berlin-Ambrosia enhanced display. This is one. Then there were some others that had come in. We'll just focus on this one. This is the right eye, and this is the front surface, the back surface. The way it is, the standard best fit sphere, the enhanced sphere, and the difference between the two, and this gets highlighted. So anything in this which is red, this is called the traffic light evaluation. Green is okay to go for surgery. Yellow is suspicious, and red is abnormal. Then, of course, you have the Berlin-Ambrosia display 2, which is a statistically weighed indices. But another thing that I'd like to highlight here is the ART max, or the Ambrosio relational thickness, ART. It is the relational thickness to the thinnest point. It is the ratio of the thinnest point to the pachymetric progression index, the way the cornea thins out over the surface of the cornea, while moving from the periphery to the center. And the maximal progression index, or the ART max, is a very good tool, and it's the value. We have to go with the values here for diagnosis of keratoconus. The thinner, the lesser the value, the more indicative it is of keratoconus. Anything less than 339 is okay for diagnosis of keratoconus. Anything less than 391 is for ectasia susceptibility. This is a normal cornea, and you see the value is 456, so it's normal. And similarly, another cornea which is value is 410. So anything less than 391 would be suspicious, and 339 would be doubtful. So in conclusion, corneal topography is an important tool today. It requires some effort to understand initially, and is important for refractive surgery screening and detecting atrophic corneal disorders. Newer systems, as colleagues Pooja and Rohit have talked about, will perform many functions and may provide more value for money. And however, please note there is no ideal and perfect system available yet. Thank you for a patient hearing. Okay, Sahil?
Yes, Dr. Ashu.
There are certain scenarios we can go ahead with, or maybe if you think...
I think we have 5 minutes, so I do not see any questions from on the question answer session.
Okay.
So I think you can go ahead with the session this year.
So basically, this is a combination of various systems. This is the Placido-based system, the ISIS. So no, it's not the ISIS. This is the OPD scan from NIDEC. And this shows an astigmatism. Let me go to the elevation-based ones. So this is again a normal cornea. I'll just show you some normal corneas right now. Normal cornea on the OP scan. This is a normal cornea on the Pentacam. You see nice green surfaces, because I think there was a talk on Pentacam on diagnosing. The elevation front surface, the posterior surface, the pachymetry, and thus the sagittal curvature. The indices, you see the cornea, you see these indices, the front surface, the keratometry values, the astigmatism. Here you have the pachymetry, the center, in the center, at the apex and the thinnest location, which is important. And of course, various other parameters, corneal volume. You also have in this particular image there, it isn't there, but you can get the white to white diameter also, which has proven to be fairly accurate for ICL calculations. And you have a nice green surface here. The readings, if you see, are +5 and +5 with a diameter of 9. Anything more than 15 on the front surface and anything more than 20 on the posterior surface would have been significant. You see the Berlin-Ambrosia display, it's all green, it's okay. And this is the Berlin-Ambrosia display 2, where various parameters are taken. And the net value here is 0.34, which is again normal. And this is the ART max, which is, sorry, ART max is not, this is an older one. So again, a normal cornea. So now coming to a few pathologies. This is obviously a keratoconus on a elevation, on a Placido-based system. Again, a keratoconus. Then this is a pentacam showing a patient of keratoconus. You see the value here is 55, which with a diameter of 9 should be not more than 20. And you see although in this case the astigmatism is just 1.2, but the cornea is fairly okay, 479. But this is the importance of the hotspot that we see on the posterior surface, why elevation topography has become important. However, now the same patient, how it gets magnified in the Bellin-Embruzzo display. Here, if you just had seen the anterior surface, it may have been a little suspicious. But here, this is these are red zones, which shows definite keratoconus. Had it been yellow, you should have exercised caution. Green is good to go for refractive surgery. Here again, Bellin-Embruzzo display too. Here also these boxes, they get colored. If it's white, it's normal. But there is a statistical value also over there. And here again, a patient of extreme keratoconus, and the astigmatism is 6.4. The steepest cornea meridian is 60.9, and you have a very hot spot over here. And all the parameters are showing keratoconus. Again, keratoconus over here.
Interrupt for a second.
Yeah.
The Kmax is also 82, which is the earlier one you showed. The Kmax was 56. Here it is 80.4.
Which one? This one, no?
This is a huge red flag, right?
Which one? Sorry.
The previous one you showed, the Kmax was 80.4. So when the Kmax is so high, this is not given in the Placido, and it's also not there in the OpScan. So Kmax is something which the pentacam shows us, and
yeah,
that itself is a huge red flag, right?
Yeah, and these are some older ones, Uma, I presume, right? So the ARTMAX value I've realized is very good for diagnosing keratoconus. The ARTMAX I talked about a little earlier in my presentation. Unfortunately, these ones don't have it here.
Yeah, but
so
then I always look at the Kmax and the
yeah, Kmax has always been there, right, Uma? Kmax has always been a very good parameter. But if you include ARTMAX, which you have in your pentacam, I know that ARTMAX value really enhances your ability, and anything less than 391, you should be suspicious. Anything less than 336 is obviously, by that time, a lot of other parameters become positive.
Right.
Okay, so now here, this is the other eye of the previous patient. Again, shows keratoconus. This eye he underwent CXL. This is the left eye. For the right eye, the previous eye, we couldn't do anything. The cornea is too thin. If you notice here, it's about 295. Just left him with some RGP lenses. Here, in fact, the left eye, he underwent ICL after CXL and is doing well. This is a patient of pellucid marginal degeneration. Sorry, not pellucid, PMCD. Yeah, pellucid marginal. And again, this patient had undergone CXL and benefited from it. This is a patient, sorry, now I'll come to a few others. This is now, can anyone tell me what is this patient? A typical mid-peripheral steepening. Exact RK, radial keratotomy. Typically, RK, what happens is there's after maybe 15 to 20 years, when the incision that were given, they start loosening, the mid-peripheral steepening occurs. A very typical feature I've seen. Some of the better done RKs would be a more annular one, but here you can see there's some decentering also. So again, similar patient. And now, what is this? Normal cornea. So one would assume one would believe it's a normal cornea and go ahead with the surgery. Everything seems to be normal. There's some, but then if you see here, so this is the advantage of these some of these parameters also. Now everything looks normal. +7, +5 over here, 9mm zone. Anything more than 20 would have been suspicious here. Anything more than 15 would have been suspicious here. 43, 44.5, 0.8 astigmatism. 476 cornea. So one would say, okay, we can do a PRK. But if you come here, Bellin-Embruzzo display 1 also fine, all greens over here. And you see over here, there's a red flag coming in here. So this, you would need to be cautious. This is the other eye of the same patient. definite keratoconus. So that's why, sometimes had it not progressed so much, one would have probably gone ahead with some refractive procedure. But it's very important to see both eyes. Sometimes also the history of keratoconus in siblings is also very important. We end up doing surgery and realize that there was a sibling who has keratoconus. And so this is again a patient with astigmatism of 0.6, nice greens over here, +8 on a 9 diameter, which is fine. Anything above 15 would be suspicious here, and anything above 20 would be suspicious here. Looking good. 486 borderline cornea, we could consider a PRK, surface ablation procedure. Again, this looks nice. And here, in fact, even the Bellin-Muzzer display 2, only one of the boxes here gets colored. The net value is fine. The y-axis is okay. The pachymetric progression is fine. The CTSP profiles, the graphs look normal. So one would consider refractive surgery. But you see the other eye, and this is a fairly advanced keratoconus, 63 and 63.8, although not much of astigmatism, but it was a very ectatic cone. So I think I'll end here. Thank you for a patient hearing.
All right. Thank you very much. I think we are time past our session. Thank you, Dr. Ashu. And Dr. Uma, if you have some comments to make.
I think, Sahil, they're waiting for the next session.
We'll officially end the session here. Thank you, everyone. Thank you very much.
Thank you, Sahil. Thank you, everyone.
Thank you.
Dr. Ashu, Dr. Ritu, Dr. Fogla, Dr. Praveen and Jaya are not here?
Ma'am, I'm here. Yes, ma'am, I'm here. But I don't see Dr. Ritu. I don't see Dr. Fogla.
I'm here. Dr. Ritu is not here. Rajesh is not here. Praveen is here. Praveen Krishna.
No, I don't see him either.
So Jay, I think let's start then. Let's start the session. Praveen. The first talk is by Praveen Krishna, but Praveen is here.
Don't see him, sir.
Okay, let's just take a quick roll call of the speakers. Praveen is not here. Vijay Sharma.
Yeah, I am here.
Okay, Vijay is here. And RK Bansal.
Yeah.
Vikas Mittal. Rishi Swaroop. Rajesh Fogla. Uma is here. Uma, are you there? She was here just a couple of minutes ago.
Ashu, hi.
You're here. And Susan is here? Okay, fine. So we'll wait for the others to come in, but I think we can start the session on management of corneal ectasias. And we'll set the ball rolling with Vijay starting his talk on Vokes Trier, new classification.
Okay.
Over to you, Vijay.
Yeah, thank you, sir. Yes, sir. So, good afternoon, everyone. A lot of advancements have taken place in diagnosis as well as management of keratoconus over last decade. And clinical diagnostics should not take a backstage. So what we have done is we evaluated 387 keratoconic eyes. And out of that, we found 52 patients had Vokes Trier. I'm sorry, I think this is the other presentation. Can I just change the presentation?
Yeah,
just
sure.
Give me 2 minutes. Yeah, this was the other one because I was logged in the other session.
It's all right.
Yeah. Now yeah. So what we have done is we analyzed 387 keratoconic eyes of 207 patients, and out of that we found 52 patients had Vogt striae. And then we evaluated these morphology and various other parameters of these Vogt striae in detail, and that is where we have come out with the sort of new classification system which we have started developing. So I'll start. This entire talk is based on these 52 eyes with the keratoconic eyes with the Vogt striae. So are the Vogt striae always vertical? As we know that Vogt striae are the vertical stress lines as it is classically defined as vertical stress lines located at the level of posterior stroma and descemet, which disappear on gentle digital pressure or even raised intraocular pressure. So are they always vertical? No. Then there are some case reports, about 3 to 4 case reports, and in our study, out of 52, we had 3 patients who had horizontal orientation of Vogt striae, like as shown in this photograph. So then question comes: are the Vogt striae always horizontal and vertical? So then we found the orientation, another orientation. Now this we can't call horizontal or vertical, as you can see that there is an angle of say 40 to 60 degree with the horizontal and vertical. So it's very difficult and dubious to call them exactly horizontal and vertical. So this we have called as oblique, and we have evaluated this orientation with the tomograph. We had op scan at that time, so we evaluated and we found that whichever side is the skewing of the axis, the orientation of Vogt striae in most of patients was also in the same direction. So then are the Vogt striae only vertical, horizontal, and oblique? And then we found something more. Now, if you see these cases, now you can see that there are mixed stria. There are vertical as well as horizontal, or there are vertical as well as oblique, as in the second case. In this also the same picture. And then there are some Vogt striae which are horizontal, vertical, oblique, all orientations in a single eye. So based on orientation, so this is what we found, that Vogt striae could be vertical, they could be horizontal, oblique, as well as mixed. So this is out of 52 corneas, 52 corneas with Vogt striae, 7 had mixed, around 15 had oblique, and vertical was the most common, that was 31, and horizontal were 3. So then based on number, now number again may vary, say from 2 to 3 to up to 52 Vogt striae that we counted. We did this under a Haag-Street IM600 at 40x magnification. So second parameter was number, and the third parameter was scarring. In some patients, there was associated scarring. So based on these 3 parameters, that is orientation, on which we divided them into vertical, oblique, horizontal, and mixed, and based on number, less than 15, 16 to 30, 31 to 45, and more than 45, and based on scarring, then we suggested this classification of Vogt striae. So here you can see all the 3 parameters. So vertical we marked as V, horizontal as H, and oblique as O. And if there are say mixed stria, then either it could be, if it is a combination of vertical and horizontal, it was named as V and H or V and O, depending upon type of Vogt stria that the particular patient has. How we classify them on orientation? The vertical we took 10 degrees on both sides of vertical axis, and horizontal we take within the 10 degree. Whatever Vogt stria which are lying within the 10 degree, they were classified as horizontal, and anything else in between these were classified as oblique Vogt stria. Now just giving some examples of this. Now this case, now the orientation is vertical, the number is between 15 to 30, so it was a V2 and there was no scarring, so we this was classified as V2N. Now this one, the oblique stria, the number is between 15 to 30, there is a scarring present, so as O2S. Now this one, again a mixed stria, there are vertical, there are horizontal, and no scarring, so V2H2N. Similarly this one, now it has got vertical, horizontal, as well as V2. That means the vertical stria, which are between 15 to 13 number, oblique stria, which are less than 15 in number, and horizontal stria, which are less than 15 in number, and there is a scarring. So there is a scarring associated. So we classify this as V2, O1, and H1. So why we felt, what was the need?
Vijay?
So lecture, every type of works more study association with the corneal thickness or any association. Any comments on this?
Vijay? Hi, Vijay. Yes. Your last part was not very audible. Your voice was breaking.
Okay. Could you see the presentation, sir? My presentation is done.
Presentation is just summarize the last part.
Okay. The purpose of giving this classification of this Vogt stria was to give a particular type, the number, and so that we can classify every type of Vogt stria. Otherwise, normally what we say is Vogt stria are present or absent. Yeah. So that doesn't convey how much the Vogt stria, what is the number, any scarring associated. And also then we have studied the various parameters, other parameters which of keratoconus, corneal thinning, and skewing of axis, what is the axis, and then correlated with these classification. Soon we'll come up with the results. We have not finalized them yet, but there are significant changes in those and correlation between this classification and those results. So any comments on this? This is just an initial presentation.
Excellent work, Vijay. And I think all of us have noticed that they're not always vertical. Quite a few are oblique, in fact. Horizontal, I would say, is very, very rare. And I'm not sure what it would be. But yeah, oblique is very common, and very good work to document it and, kind of classify it and have a classification system. Only question, how do you count? Do you take photographs and count? Because counting is a very tedious job if you try to do it on the slit lamp.
It's very difficult, especially if there is a scarring associated. It's very difficult. Initially, we took photographs. We used the Harkstreet IM600, that photography system. We took photographs, magnified, and then did the counting.
Yeah, because it's very difficult on the slit lamp to do it.
Yes, it's very difficult. That is one part. So the classification is broad, say 1 to 15 is 1 and 2. So even there are plus minus 1, 2, 3. So it won't make much difference, but we can have a good idea how many are there.
I think Dr. Ritu is here. So
yeah. Hi, Ashu. I had some connectivity problem.
Yeah, that's right.
Yeah.
So we had a very nice presentation from Vijay. He's talked about Vogt stria and he's trying to a new classification system. We'll be coming out with results. If there are any questions for him, we can have those, or we can move ahead with the session. Praveen, are you? Praveen is there. Praveen's there. Praveen, would you like to?
Yeah, I think I saw him. Yeah.
Yeah.
Yep, I'm here, Ashu. No, I think very detailed and very meticulous work done by Dr. Vijay Sharma. Just one question about what do you think is the potential clinical application of the finding of having the vertical, oblique, and horizontal striae from a patient perspective?
Yeah, I think I also have some instability. But what I could make out is what are the clinical implications. So what we have found out that the mixed stria, especially who have the scarring, the corneal thickness is quite less. That is around 300, 315. And the vertical and the oblique ones, the thickness is around say 450 to 500. And another thing that we found, the orientation, the skewing of axis in the horizontal Vogt stria, that doesn't correlate with the axis of the Vogt stria. So there may be some other mechanism which is causing them being horizontal rather than the skewing of the astigmatic axis. Out of 3 patients, 2 patients had around 90-degree difference between the axis of Vogt striae and the skewing which was visible on a tomographer. In oblique and vertical, the skewing as well as the axis of Vogt striae, they were almost in the same line. There was a difference of hardly 10 to 15 in all of them, 10 to 15 degrees. But in horizontal, there was a marked difference. Then another thing that I found is the number in the horizontal Vogt striae was very high. It was on an average of 38 Vogt striae compared to vertical and oblique, which were where the average number was say 10 to 15. So that was another difference that we found. I think maybe the ones which are mixed ones, or there is a combination of horizontal and vertical, even without scarring, we may have to go for an early CXL in those patients, because for around 3 to 4 months, we have seen that they progress very fast. The thinning occurs very fast in those which have got mixed stria. Maybe that is because of various stress forces and stretch forces in the cornea, and it's some activity which is going on. So that might be causing that thing. So this correlation, we are still in the process. So I think maybe another 2-3 months, we should be able to get a good results on those things also.
Thank you.
Dr. Praveen, sir, I think the next
connectivity issue. I have a shift my okay.
Yes, Jaya, can I go next? Is it okay?
Yes, sir, please.
All right, thank you. So, though the title of my presentation is going to be about diagnosing ectasia, I think what I thought I would do is talk a little bit of a different angle from the perspective of ectasia and keratoconus. So very recently, we completed looking at the data of keratoconus that we've accumulated over the last 30 plus years. And there are some very interesting findings in here from the perspective of management of keratoconus, because this is a session that is more focused on management. So I thought I'll share with you some of these interesting data rather than keep talking about the techniques that we perform in patients of keratoconus, because I think there is a lot of learning when you look at data that is of significant numbers and is also over 3 decades as well. So what I will try to glean from this presentation is how things have changed in patients who have come to us with keratoconus over the last 3 decades, how the future might be a little different when we approach somebody with keratoconus, what skills and what we need to probably invest in, and where to look for to be able to diagnose keratoconus early. So overall, I think at the start, when you look at literature, it seems as if the prevalence...
अच्छा मैं गाय का घी डाल लेता हूँ कभी कभार अरे और मैं सही बताऊँ मेरा चश्मा उतरने को है ऐसा लगता है चश्मे की जरूरत नहीं मुझे नहीं लगता वैसे थोड़ा सा हल्का काजल लगाता ना हल्का सा लगा
सर ऐसा काम ना करें तो अच्छा है
ये घर का निकाला हुआ घर के दूर से
Dr. Bansal, I think he needs to be muted.
The audio is not there.
Hey, I think you lost me. Where did you hear?
Yeah, we heard you till 30 plus.
Okay, sorry. Let me just change my hotspot. So
Plus
we'll...
data.
Yeah. Hello, can you hear me?
Yes, yes.
No?
Yes.
All right.
Yes, Praveen, we can.
All right. Sorry about that again. I was just saying that probably we'll try and share some data from the last 3 decades about what we've seen in keratoconus. And I was just summarizing what is available in literature right now, and also just saying that data from India is very limited. What we know is mainly from the Caucasian population in the West, and data from Indian studies are very limited to 2 studies, one from Central India, one from PGI. One from PGI is about 130 patients, one from Central India has about 400 patients. So what we did was we collected the information of all patients of keratoconus that we saw across the LVP network from 1987. And when we looked at the distribution of pathology among corneal disorders, we found that ectasia or keratoconus formed about 7% of all patients who came in with corneal disease. About 11% of these patients had allergy. And we also looked at the number of patients who underwent transplants during this time. We found about, of all the transplants we've done in the last 9 years, about 7% is because of keratoconus again. So over the last 30 years, we've seen about 20,000 patients of keratoconus in 30 years, of which about 2/3 actually are male and about 1/3 are female. So when we also looked at the time at which the keratoconus patients came to us, we found that there seems to be an increase in the number of keratoconus patients in the last 8-year period. So significant number whom we've seen in the last 8 years or so. You see about a doubling of the number of keratoconus patients. And if you include 2020, which is probably skewed because of COVID, that probably reflects why it's sort of plateauing slightly and not showing a lot of increase. So in addition to that, we also looked at what frequency we've been seeing these patients, and we've seen that about 70% of all the keratoconus patients we've ever seen, we've seen in the last 8 years or so. And the average age of the keratoconus patient in 1987 to 1991 was about 30 years. And this has come down to about 22 years in the last 4-year period, showing that there seems to be a trend for keratoconus patients to present younger and younger as well. So then when we started to look at what interventions we use for keratoconus patients, this is the total number of interventions, the blue line. The green line is the contact lenses. And then you have collagen cross-linking, which is the pink line, and then the transplants. We'll come to that a little more in detail. So we found that the commonest intervention in the last 2 years has been collagen cross-linking. So cross-linking has actually taken over several other interventions in the last several years. In 1987 to 1996, we only had penetrating keratoplasty to offer. And then we had 1997 onwards contact lenses to be a significant number of patients who use contact lenses. But then again, now we seem to have cross-linking as a predominant procedure that we do for keratoconus patients. Contact lenses, we started in 92, and every time we added a new contact lens type, RGP, rose case, scleral, we found that it has resulted in an increase in the number of patients, or percentage of keratoconus patients who were giving contact lenses over time. The age at which contact lens was prescribed to keratoconus patients has remained relatively similar, very small variation there. But then when we looked at the surgical intervention by type, when we eliminated contact lenses, again in the first 15 years of our existence, we see that it is mainly penetrating keratoplasty. DALK has become a little more common in the last, in the 1990s, in the early 2000s. But you also see that there is a very large proportion of patients who underwent C3F8 in 2 5-year periods. So this probably is ascribed to the fact that we had a publication from our group where we said that intracameral C3F8 is very useful in treating acute corneal hydrops. So there was a 3-fold increase in the percentage of C3F8 injections that we did in the next 5 years. And after that, I think people stopped reading the publication, so the numbers have come down again. Age has been about the same. When we looked at the DALK versus PK, we found that collagen cross-linking was introduced first in 2007, and it seems to have really taken off in the percentage of patients in whom you've done collagen cross-linking. And probably because of that, we've also found that we've started doing cross-linking in younger and younger patients in the last 10 years or so. When we also looked at the number of transplants that we've done, this is the total number of transplants that we've done in the entire eye bank. And you'll see that the total number of optical transplants has risen, endothelial keratoplasty has risen. But if you look at the therapeutic as well as the lamellar transplants actually have come down. And this probably is explained by the fact that in 2007, which is when we started collagen cross-linking, is when the lamellar surgeries actually absolute numbers started to come down. Proportion wise, we have about 50% of all patients that we do LK or DALK, about 50% we do PK. But you will see this gray line that shows that there is a stabilization in the number of LKs that we are doing for keratoconus. There is a reduction in the penetrating keratoplasties we are doing for keratoconus patients. This is very similar to what has been reported in several other groups, including from David Rootman's group, which show that there is a decreasing trend in doing PKP and DALK in patients who have keratoconus. And they also ascribe this to the advent of collagen cross-linking, which is a good thing as well. So to summarize what we found, that keratoconus in last 30 years accounts for about 7% of all corneal disorders that come to the clinic. The incidence seems to be rising. The age at presentation is getting lower and lower. Contact lenses and cross-linking seem to be reducing the need for corneal transplants. And acute corneal eye drops also, it seems as if the incidence of eye drops seems to be reducing with time. A couple of other interesting things that we saw was the majority of keratoconus patients, more than 80%, were between 11 and 30 years. And we also found that, interestingly, more keratoconus patients seem to be coming from urban demographies as compared to rural demographies. And when we looked at the clinical signs, the predominant clinical signs were ectasia, Fleischer's ring, and prominent nerves. Scarring and Vogt striae seem to be present in a smaller subgroup of patients. We also found that when we looked at the age, younger patients between 0 and 20 years tended to present with more severe disease, grade 4 keratoconus, as compared to patients who presented later on in their lives. We also found that females presented with more severe disease compared to males. And we also found that patients coming from rural areas and semi-urban areas had more severe disease as compared to those coming from cities. So it seems as if 80% of all keratoconus patients occurs between 10 and 30 years. 2/3 are more common in urban areas. Severe vision impairment was found in about 15% of patients. Females and patients coming from rural areas have more advanced disease as compared to those who are male or those who come from urban areas. So that sort of is a summary of what we found in looking at all our keratoconus patients over the last several years. So thank you very much.
Very interesting study, Praveen. I mean, real big data in real manner. And it just shows that how we have progressed all along and how the management presentation has changed. And maybe I think one of the reasons which you said that C3F8 is being less commonly used because maybe the disease is being picked up earlier. So we don't let it go to the high drop state. That's
absolutely.
Yeah.
Thank you, Dr.
Praveen, can I ask one question?
Yes, please.
Yeah, Praveen, it was amazing data, fantastic. So what I found that the people who are coming from rural background, they seems to have more severe disease. So there can be a bias also because it's possible that they are coming a bit late. Have you looked into which have progressed faster? So there must be patients who you were following for all these years. So was there any data suggestive, any significant thing that we need to look into, like if the practitioners around that you found, which are the cases where it has been progressed faster?
Yeah, that is the part of our next study actually. So what we've done is we've mined data so that we actually get demographic data first. And then the next set of data is the topography data. So we're still trying to enter all that. So once we do that, then we will know who is progressing, who is not progressing. And then we've already identified some of the risk factors. So that will come out in the next analysis. So that is not part of what for the initial study.
Can I also ask a question?
Yeah, Rishi.
So Farhad Hafezi had some data suggesting that thyroid might be a risk factor for keratoconus. Have you looked at that in your study as well, in your big data analysis?
Yeah, we've got risk factors, but I think when you look at the average number of patients, the age of the patients who are about 19-year-olds, I think anecdotally at least thyroids and systemic disease didn't seem to be a very major factor. The only major factor was allergic eye disease, about 11% of patients, and VKC in about 8% of patients.
And maybe
Atopy was very less, about 2 or 3%.
And you also mentioned that females were more than males, right? So, and this was quite...
No. Males were 2/3. Males were 2/3, females were 1/3. Okay. But females presented with worse disease than males.
Mm-hmm. Great, very interesting. Thank you.
Praveen, why did people stop reading that report? C3F8 report. It's our own paper.
Maybe like Dr. Ritu said, yes, I know, but like Dr. Ritu said, maybe we're also picking up keratoconus early. And I think collagen cross-linking also has a role in reducing the potential eye drops in patients too. So I think all of those really.
That was just an aside.
I know.
So can we go on to the next, ma'am?
Yes, Ashu. Yeah, please, we can go for the next speaker.
Shall I start?
Dr. Bansal, yeah, you'll be talking on topo-guided PRK with CXL for progressive keratoconus.
Okay.
My slide visible?
Yes.
So thank you very much. Good afternoon, everybody. So I'm going to talk about the topo-guided PRK with cross-linking for progressive keratoconus. Well, I think we already heard Dr. Praveen regarding the data on the keratoconus. So as we know, keratoconus is one of the most common ectatic disorder of the cornea if we compare with the other disorders. Usually the disease tends to be bilateral, but there is always an asymmetry. So one eye may progress a little more faster compared to the other eye. And most of the patients tend to have a progressive disease. The prevalence of this keratoconus has been estimated to be 50 to 250 cases per 1 lakh population. One of the main problem with the keratoconus is that the uncorrected visual acuity and even the best corrected visual acuity goes down over a period of time because these patients develop irregular astigmatism. Number of treatment options are available. We know we can start with glasses, then contact lenses, cross-linking. As we know, cross-linking has been there for many years, and this has really taken over the treatment of progressive keratoconus. So my topic is mainly to talk about when we can combine cross-linking with the PRK in the patients and what are the different indications and protocols which we can follow. As we know, the cross-linking first data came somewhere in 2003, where the patients of keratoconus were given ultraviolet light in the fluence of 3 milliwatts per centimeter square for 30 minutes. So that time it was only the cross-linking which was done for the patient of keratoconus. Over a period of time, we have started reducing this time by increasing the fluence of the ultraviolet light which is given. So the fluence levels can change from 3 to 30 milliwatt per centimeter square, and then the time of exposure can be reduced. But overall, the energy level is kept at 5.4 joules per centimeter square for all the patients. Now, over a period of time, it has been seen that purely doing the cross-linking doesn't help these patients. So now we started combining this with the PRK, especially if there are some indications. And we know that by combining PRK in patients with cross-linking, we are able to improve their functional vision. We are able to correct some of the refractive errors which exist in these patients. And we try to make more regular cornea so that patients are more comfortable even with the glasses or contact lenses, whatever the residual power may be left in these patients. The idea behind is that we try to correct about 70 to 80% of the power which is there in these patients. We never go for 100% because cross-linking is going to take care of some of the power of the cornea which may be reduced over a period of time. And another parameter which has been kept very important in this patient when we combine PRK is that we should not be exceeding 50 microns of the total ablation of the stroma. And at least we should see that whatever ablation we do, that we have a residual stroma of about 400 microns, which includes the thickness of the epithelium as well. I'll just give you two examples of patients which I did. This was a 28-year female. She was having progressive keratoconus in both the eyes. The uncorrected visual acuity was just counting finger in this patient. And she had a very significant slender 5.5 almost in both the eyes, and the left eye had more spherical power also. The Kmax was 47 and 49 respectively in right and the left eye. The corneal thickness in this patient was quite adequate, 466 and 452. So it was thought that we should go for PRK extra in this patient. We did one eye at a time, and then after 6 weeks, we did the another eye. And the overall ablation which we could do in this patient was 36 microns in the right eye and 45 microns in the left eye. And after about 4 to 6 weeks of the treatment, we had a very uncorrected visual acuity of about 6.9 in both the eyes. So this is the pentacam graph of this patient showing the amount of the astigmatism and the corneal thinning in these patients. We can see that the pupil center corneal thickness was 422 and overall corneal thickness somewhere in 435 microns. So this is a post-op graph, refractory graph, which again shows that some flattening has been achieved in this patient with the corneal thinning. And this is a OCT showing that demarcation line in the cornea, which indicates that the cross-linking, those mild haze is there in both the eyes, which disappeared over a period of time. And then we can see that the anterior segment OCT shows that there is a effect of the cross-linking in this patient. Just another patient, 19-year young patient, he had a very high astigmatism in one eye only. The other eye of this patient was normal, had a astigmatism of about 6 diopters. The keratometry values were 43 and 48 in the other axis. The corneal thickness in this patient was quite adequate, like 499. And we did combine this patient with topo-guided PRK and cross-linking. So the depth of the ablation which was done in this patient was 43 microns. So postoperatively, this patient was very happy, had a very small residual error of 0.5 diopter and 0.5 slender, and he could achieve a visual acuity of 6.9. So these are the pentagam pictures of this patient showing a mild keratoconus in this patient. And that's the Bayesian embryo scan of this patient showing well.
एक मिनट ये ना ये zoom में यहाँ पे कैसे करना है इसमें हो रहा है उसमें नहीं आ रहा. I want to see it on laptop.
Segment OCT showing thinning of the cornea and achieving almost flat.
Connect to you.
Then just to discuss some of the protocols which are being followed for cross-linking with the
What's that? Message में.
No, the first was about the Dresden protocol, which is called where we just do the cross-linking. So the first results of cross-linking were published in 2003, where the epithelium is degraded mechanically and cross-linking is done. So at the end of the follow-up of this patient, it was seen that there was a reduction in the keratometry value to almost 2 diopters, and even there was a reduction in the spherical equivalent of 1.14 diopters in this patient. So there was some benefit of cross-linking where the progression of the keratoconus stabilized in these patients. And then came time when people start thinking that we are not able to achieve the full results in this patient of keratoconus. So they started combining the PRK in these patients. So this is the first study which was published in 2009, which became very popular and came to know as the Athens protocol. So basically they combined the topo-guided PRK with customized cross-linking. They considered patients for this treatment if the age was 18 years and above, and the corneal thickness has to be 400 microns at least. And the target refraction correction was not full, but it was to the tune of 80% of the slender and 70% of the sphere. And another parameter which I again repeat, they kept constant was that the ablation of the stroma should not exceed 50 microns. And they did apply mitomycin C for 20 seconds in these patients to avoid post-operative haze in these patients. Then recently, last year, the same study published their results in 144 eyes, and they showed that these patients have a very significant improvement in uncorrected as well as best corrected visual acuity. And also there is a reduction in the steep K from 53 diopters to 44 diopters at least at a period of 10 years. And the corneal thickness, of course, it has to decrease. So it was from 468 to 395 in these patients. And the good part was that the ectasia got stabilized in about 95% of the cases, though about 3.5% of the cases had a small shift towards hyperopia. So the conclusion of from this study was that 10-year data which favors safety and long-term efficacy of combining the cross-linking with the PRK. Then once the TPRK became available, the combined transepithelial photorefractory keratectomy, then rather than doing the mechanical debridement, people started doing the TPRK, means the epithelium was debrided uniformly with the help of the laser itself, and then followed by cross-linking. So Creighton's protocol combines the TPRK with cross-linking. So the results published initially in 2014 and then later in 2017, where they had 43 patients and 55 eyes, and the mean age was 30.8 years. And they also showed that there is a significant improvement in the uncorrected as well as best corrected visual acuity. And the change in the keratometry Kmax value was from 50 to 46 microns to diopters. And spherical equivalent significantly got decreased from 4.67 to 2.2 diopters. So then another modification came, which came to be known as Tel Aviv protocols. Here again, it was by laser-assisted epithelial removal with PRK. However, the period of cross-linking was decreased from 30 minutes to 10 minutes by using high fluence of 9 milliwatts per centimeter square. So that was the idea, that you can combine cross-linking with the PRK, and you can use different protocols. You can use Athens protocol, you can use Tel Aviv or Creighton's protocol, depending upon whether we are doing mechanical debridement of the epithelium or we are doing with the TPRK in these patients. And over a period of time, it has been seen that these patients do stabilize and show a significant improvement in their keratometry values as well as improvement in their visual acuity. However, we should keep in mind that these procedures are not without some of the complications. There may be loss of best corrected visual acuity, maybe 1 to 2 lines, which has been reported in different studies after the PRK and cross-linking. And some of the patients, where those who have a high refractory error, sometimes they might develop some corneal haze, and which some time can be taken with the application of the mitomycin C. Some patients do complain about halos, recurrent corneal erosions, and sometimes the epithelium may take a long time and even it will be non-healing. And 1 or 2 cases have been reported who develop because of the epithelial defect, infective keratitis. So we should keep in mind that all these patients are not 100% safe. So we should explain the risk of some of the complications which can occur in these patients of PRK with cross-linking. The risk of ectasia again still persists in these patients because we are further making the cornea thin by doing the ablation. So that is how we should keep minimum corneal thickness available so that these patients are not at a risk to develop ectasia. So the take-home message from the studies and from few cases which we did, the simultaneously PRK can be combined with the cross-linking, and it is usually recommended for patients who have a grade 1 to 2 keratoconus, and we can see over a period of time that these patients are progressing. The important parameter we should keep in mind that the residual depth of the patient, the stromal should be kept minimum 350 microns, and if we include the epithelium, then we should have a minimum of 400 microns of the cornea should be left after the ablation. The stromal ablation which is recommended for this patient is somewhere between 40 to 50 microns. We should not exceed 50 microns because the risk of ectasia will be there in this patient if we go beyond 50 microns or beyond 350 microns, the depth, if it is not there. There were some studies which preferred a 2-stage over single stage, because this procedure mainly is a single stage where we do PRK and cross-linking. But 2-stage is not preferred, where people have been doing cross-linking first, followed by PRK. But here, the cross-linking will do some of the changes in the cornea, and then we are again removing the cornea which has been strengthened by cross-linking. So the 2-stage procedure usually is not recommended. So only 1-stage procedures can be done. And however, we should keep in mind that the refractory error in this patient is not fully corrected. So we have to keep these patients under-corrected because some effect will be achieved by the cross-linking itself. So thank you very much for your patient hearing. So if there are any questions, I can answer. Yeah.
Sir, very good presentation. Thank you so much, and very good, nicely you have concised everything. Regarding your case 2, who was 18 years, so, and I think -5 diopter surrender or something like that. So
Yeah.
did you see in follow-up any regression, or whatever the keratometry was? So do you feel that after 6 months, 1 year down the line, what did happen? And my second question is, how about doing just PRK and then followed by cross-linking? Do you feel that makes any sense?
Yeah, the first child, which I showed you, 18-year-old male, definitely I have a follow-up about 3 to 4 months in this patient. Since that patient was, when I did, I was in GMCH. So further, because of the lockdown, the further follow-up has not been complete. but whatever follow-up on that child I had, he had a small corneal haze in the center. But other than that, the visual acuity of that patient remained stable for about 2 months, which I had a follow-up on that patient, around 6-9. And your second question is about PRK. Yes, but thing is, if you're doing plain PRK in these patients, we are making the cornea thin by doing PRK. So at the same time, it is recommended that unless we make these corneas more thick or more stable, the PRK alone should not be done, because then the chances of progression in this patient will be very high. So collagen cross-linking has to be done in these patients, unless we don't have a patient or the indicators are not there for the keratoconus. But if it is a keratoconus, it has to be combined.
Yeah, somehow I'm quite conservative and we generally don't do it, but I think it is an interesting thing that is coming up.
Yeah, so Vikas, I was quite amused by the way you were asking questions, because I think you don't do it. Even I do, I don't know, even I haven't started as yet, and I have certain reservations which may be totally unfounded as time will tell. But if you consider the logic here about your question, because if at all it has to be done, yeah, you should combine it with CXL, because absolutely, at least some strengthening is happening simultaneously. As it is, if we do a PRK first, you've done a weakening procedure and then you're following up. So if one has to do it, I suppose it should be a combined procedure. But yeah, I have no experience with this procedure, so and Dr. Ritu.
I know a couple of surgeons who give IOP lowering agents also with these, and they believe.
So Vikas, that stems from a very early, I think maybe 2 decades now, when ectasia started coming, correct ectasia due to LASIK started coming in. People felt that lowering the IOP would prevent the bulge of the cornea. I'm not even sure how that works, but that stems from that fact. So, Dr. Ritu, do you have any experience with the?
I have not done this kind of procedure, again because I'm apprehensive.
Yeah.
Because I feel that it's a progressive disorder.
Yeah. So that's the thing. So there's a very sorry.
Because I have certain experience, in a sense, not from cross-linking, but earlier times, say in early 90s. When I was just getting into grafts, at that time we used to do smaller grafts, 7 or 7.5 mm in keratoconus cases. And those patients have now come with, progression of ectasia and bigger size of the cornea. Like there's ectasia in the graft coming up in those patients. So ever since I started seeing that, I've revised my policy, and if at all I don't do PKs, but if I have to do PK or even DALK, I never do less than 9 mm. Because my logic is it's a progressive disorder, and 18-year-old child, you do something, and since the disease is progressive, so for how long I'm going to maintain it, so I'm very apprehensive about it. So I have not done.
That's a very interesting point you brought forward.
Yeah.
Because nowadays, we are seeing that, we've always known that keratoconus is a global disease. The entire cornea is affected.
Yes.
Though nowadays we see studies coming in, people are focusing on small areas of treatment. I don't think.
I am not
convinced.
Convinced about, up to the extent that I've had patients whom I did corneal graft even larger, even 8.5 corneal graft nearly about now 18 years back, and they have come with high drops in the corneal graft.
Yes. So because again,
large grafts, they've come with high drops. So if it's a progressive disorder, so doing a smaller area involvement, I'm not sure how much we're helping the patient.
It's a progressive disorder, one, and it's a global disease. The entire cornea is affected. It's because it's there's something to do with the biomechanical strength, and it cannot be a focal treatment. So that's one aspect. The second thing that I'd like to observe is there's a very interesting divide I've observed here, that people like you, Vikas, me, who are trained cornea surgeons and are also refractive surgeons, but primarily cornea, who've also been trained as refractive surgeons, but have essential cornea training, are a little wary about doing, PRK plus CXL or any LASIK extra, these procedures. Vis-a-vis our colleagues who essentially started with refractive and, are progressing on. So there's a very interesting divide. I think time will tell where it is, although I think a good YMED would be, incorporating certain elements and carefully evaluating after some good studies come in. But till that time, I don't want to be adventurous personally.
I think 13-year results are already available, where the people.
Dr. Bansal, you also said that in one of your cases, for instance, in your summary, you said haze.
Haze, yeah.
Corneal haze. Now, if you're ablating just 50 microns of stroma, okay, let's say 50 microns of epithelium goes and 50 microns of epithelium comes out. 50 microns of ablation is not much of ablation.
Absolutely.
If haze were a function of the amount of ablation, larger refractive errors, like we used to see in surface ablation procedures, PRK procedures, where anything beyond 6 was likely to have more haze, 4 to 6 was a borderline thing, less than 4, less haze, usually, not always. Then where does that statement fit in,
Yeah, the haze is also because of the falling CXL.
No, there are multiple things.
For that, they say is because here we are doing cross-linking at the same time. So maybe
haze, I think, is cross-linking.
Yes,
cross-linking has a diffuse. It has a diffuse haze,
but combining the two procedures.
Yeah. Possible. Yeah. That's quite true. But so I don't know. The data is there, but what I'm saying, I'm not saying anyone's right or wrong over here. It's just that it's an interesting observation that core cornea surgeons trained also in refractive are somehow holding back vis-a-vis refractive surgeons when this as far as this procedure is concerned, where refractive surgery, ablative surgery is combined with CXL.
I saw Rohit Shetty's center once. I was visited that center.
Yeah.
I saw now they're shifting to more customized PRK where they locate the cone. So rather than simply doing in the center, so what they're doing is they are locating the cone area and then doing the cross-linking, particularly in the area of the cone.
So that's again a debate which we were discussing a little earlier prior to this, just when we're talking of keratoconus being a global disease rather than a localized disease. So again, interesting things happening. Time will tell, but each to his own.
Also, if you really see now that we've had so many cases when is there an entity of a unilateral keratoconus? I am going away from there. We see so many cases which present to us in their teens with unilateral keratoconus, other eye perfectly normal. But you follow them up and 10 years, 12 years down the line, the fellow eye starts showing early
Absolutely.
So that again brings me to the thing that it's a progressive disorder.
Exactly. I mean, in the previous session and a Pentacam session, I showed some slides where one eye is perfectly normal, absolutely normal. You would have gone ahead with surgery. The other is already manifested keratoconus. So, and these are about 28, 29 years of age. About 3 years earlier, where both eyes would have been absolutely normal.
Yeah.
So this is something. So
therefore, it's actually your whole approach will change the more you see those kind of patients.
Yeah, absolutely.
Yeah. Thank you.
Good,
I have a question for Dr. Bansal.
Yeah.
So Dr. Bansal,
yeah.
I have a question. You did a topo-guided PRK or was it a normal wavefront?
This was a normal wavefront.
Okay. Because what we do is usually a topo-guided treatment.
Yeah, if topo-guided probably would be
recommended is a topo-guide.
Recommended, yeah. Jaya, can you ask? I think
yes,
we can have the next speaker.
I think the next speaker is Dr. Vikas.
Yeah. So, Dr. Bansal, you might need to stop sharing your screen.
Yeah, Dr. Bansal, please.
Okay.
So my screen is visible?
Yes.
Yeah, okay. Absolutely. Thank you so much. And first of all, I'm glad that DOS 2020 is happening in 2020, and congratulations to the whole team.
That's nice.
It's a wonderful platform that we can, still learn even virtually. So I'm going to talk about, since we are discussing keratoconus, another option in keratoconus management. And I'll take you through a case that came to us. This was a 20-year-old male who had diagnosed progressive keratoconus, came for consultation in right eye. Left eye, he had undergone corneal transplant some 3-4 years back, but he was not happy with the high astigmatism. The tomography image showed typical keratoconus with K, even more than 60 diopters and pachymetry less than 300 microns. So we have this 20-year-old boy with progressive K-conus around 300, less than 300 microns cornea, who had good vision with contact lens and was comfortable with them. So what are the options? Of course, in case the patient is comfortable with contact lenses, we would like to stabilize the disease. Doing a cross-linking in less than 300 microns cornea is always challenging, although there are a few options. And as I said, patient was not interested in any kind of transplant. So is there anything else also that we can do? So there has been a few publications on Bowman layer transplantation for stabilization of progression of keratoconus. And the basis behind this is the Bowman layer appears to be fragmented in keratoconus. There are a few histopath studies as well. And this was the basis on which they tried to do a Bowman layer transplant. Most of the literature has come from Dr. Mellis group, and they have found stabilization of keratoconus over even 5 years. And even they have found some flattening of the cornea as well. As you can see, there's a Bowman layer over there. Although it's technically quite challenging, and as we see that even in 5-6 years, there has been only one center that has been reporting most of the data. So it was been technically challenging and could not be adopted surgeons while over. Another concept is stromal augmentation by putting collagen into the keratoconic cornea. So they have used SMILE lenticule, which we removed from the refractive surgery and placed it into the midstroma of the cornea. And the basis was because you are adding collagen, so maybe the biomechanical strength increases, and that's how they have found. There are, I think, 3 or 4 articles where they have found stabilization over 2 years or so. So with these taking into account this background, so we did surgery which we called Bowman layer, Bowman stromal inlay. So what we actually did was we took a donor tissue and created an anterior 200 microns anterior lamellar graft using femtosecond laser, and then created a 130 microns pocket into the patient's eye, and then transplanted this graft into the intrastromal pocket using a simple IOL injector. Since this graft has Bowman layer as well as anterior stroma and was placed in the intrastromal pocket, we called it Bowman stromal inlay. So I'll just take you through this video. So first patient was taken. So after docking, so we created the intrastromal pocket. We used normal routine LASIK software, just made some correction. This depth, this was 3 millimeter. And then after creating the pocket, donor cornea was mounted on artificial anterior chamber, and pressure was nicely tight. So first I'm using alcohol to ensure all the epithelium goes off. Once all the epithelium is goes off, we just mark it with the mark the limbus and then create anterior 200 microns inlay from here. So once this has been created, so this inlay was stored in BSS. Now the patient is shifted into main OR, and using any blunt instrument, the pocket which has already been created is opened. Once the pocket is opened, now the inlay is loaded on the IOL injector with Bowman layer side up, and then you just inject a few drops of BSS just to ensure that it is smooth. The tip is engaged with the tunnel, and then it is injected into the anterior stroma where your pocket is. The feel is almost, it is quite tight, but it can easily go, and then unfolding centration is same, can be done by using a cannula, and the feel is same the way we do a DSET. And you can center it well, and once centered, the surgery is over. You don't need to suture the tunnel part at all. So this was the patient. Post-operatively, the interface looks just like we see in LASIK. There was subtle edema on day 1, some patients even up till day 7, but it settles back in 3 to 4 weeks, and you can't even make out where that particular inlay is, and merges so well with the host stroma. You can see nicely lying, no folds, no cellular reaction, and no debris. So pentacam image of the same patient. Have a look at this pachymetry map. So post-operatively 1 month, so which was sub 300 microns, it has increased to close to 500 microns, according to, in collaboration with what was the thickness of inlay. And the sagittal map and posterior float map, it remains stable. And now this patient is close to 18 months follow-up, and both these maps are stable. So we recently compiled a data where we had 10 eyes of 9 patients who were followed for minimum 1 year. And all patients were keratoconic except one who was post-LASIK ectasia. Youngest patient was 10 years old. And these were moderate to severe keratoconus patients. And we followed up with mean follow-up of 15 months. As you can see, the mean PACI was also 385 microns, and all were moderate to severe keratoconus patients. There was surgical ease. There was, hardly any learning curve. The field of, because I already do a refractive surgery, so that helped. Otherwise, there was not much learning curves. No specific intraoperative complication. 2 patients, there was some tear at the tunnel, which we sutured. Otherwise, 8 cases, there was not even, no stitches was required. And there was no flap related, like any cellular reaction, folds, stria, nothing was seen. You can see this Pachy map, the Pachy map improved. And this was according to the depth that we had of the inlay that we had selected, the thickness of inlay that we had selected. The BCVA dropped in 1 patient by 1 line, but it was improved or same, but contact lens and uncorrected visual acuity was same in all the patients. So subjective astigmatism also got reduced a bit. Tomographic astigmatism also was slightly low. Mean K also got reduced by around 4 to 5 diopters. Posterior float remained stable all through. We didn't, whatever changes happened, that happened in first 3 months. After that, the whole thing, both sagittal map, anterior float, posterior float, they remained more or less stable. As I said, we didn't find any patient who had a progressive. Rather, 1 patient, the other eye, which we had planned for this surgery, but she couldn't follow up. The other eye had even hydrop. So which shows that this was a progressive in nature, but got stabilized nicely. So possibility, maybe this by transplant of Bowman layer and stroma, we may increase the biomechanics of the cornea. It is possible that, we can stabilize these keratoconic corneas. Since we have good thickness, we can even consider topo-guided PRK, because if you have anterior 130 microns, that can be ablated later. And in case, God forbid, this ectasia progresses still, then you can do a cross-linking, and now we'll have a much better pachymetry. So at the moment, I feel that this may be another treatment option in keratoconus, and looks like the early result looks like it's quite promising. Thank you so much.
Thank you, Vikas. Very, very novel idea and beautiful results.
Vikas, sorry, I got logged out, and so I missed a lot of your presentation. How many cases have you done till now?
10. So we have done, I think, close to 15, but 10 were the ones which we included in the study, which had
analyzed,
follow-up of at least 1 year, or average follow-up is now 15 months.
Okay. And is there any interface scarring?
No, that's what I specifically highlighted. I think the reason for that is we ensured that there is no epithelium in the graft, the inlay. And second, we are using IOL injector, so tip straight away goes in the intrastromal. So there are no conjunctival debris or anything that can get incorporated. So we didn't see any DLK, any interface haze, any stria. We didn't see anything. That was sometimes can't even make out.
It's cadaveric, right? I'm sorry, I missed.
It was cadaveric. Yes, it was cadaveric. That's right. And we chose variant. There was, most of the patient were 200 odd microns inlay. There were 2 or 3 patients where it was 170 microns. It depended on the least Pachy of patient was, I think, 280 microns, in which we had done that, and 280 that got increased to 470, 450 or so.
So your target is 450 plus.
My target was, around 500.
Okay.
But we didn't want to increase more than 200. So we played between 130 to 200. Most of them, we ended up with 180 or 200.
Excellent. I mean, we should follow it up. And
yeah, we are closely following it up.
Great.
I am Rajat here. Can I ask a question, please?
Yes.
Yeah. Hi, Dr. Vikas. Nice presentation. My question to you is, there was a case of post-LASIK ectasia in which you also did the same thing.
Correct.
So what was the thickness of the graft of the host you did an ablation on through the femtosecond laser? What was the flap thickness, and what thickness of the femto you did in the host in a post-LASIK ectasia?
So yeah, that's right. Actually, in that patient we had slight problem also that was minor. So this patient had undergone LASIK, I think some 5-6 years back. We couldn't, with the OCT, we couldn't locate what is the thickness of the flap. So what we did was, it was total, I think, 400 or so pachymetry. So we just thought that maybe, we took, I think, 140 microns. We made that tunnel at 150 micron. So on second post-operative day, I could see the flap separate and the graft separate. So we took the patient into OR and just saw how it is, and we made used one or two sutures also on one side. After that, it got stable. This was my concern. I was even wondering that whether that flap will stay or not, but we didn't have much of the issue.
So if you'd gone maybe 30 microns more, you would have probably been okay.
Yeah, that's right. That was a lesson that we learned. So we thought that maybe, you can go even less than that.
Yeah.
True.
And one more thing, can we use a sheet slide in this for insertion? Because
sheet
it can go.
Slide, we can use, so sheet slide is slightly broader. So in what we do is we generally use LASIK software only. We didn't have an intrastromal pocket, they charge extra. So what I did was the same software, the tunnel that we use for the removal of the LASIK, this air bubbles. So that was, I think, 1.7 mm. So we increased it to 3 mm. That is the maximum I think that can go. Or I think you can go slightly more also. And the side cuts, the energy was reduced to minimum. So in the side cuts, we had just an impression, but there was no side cut at all. And this 3 mm, why we chose? Because the IOL injector was 2.8, so it could snugly, fit inside, and you can do. In case you want to use a sheet slide, then I think you'll have to take a broader tunnel. And then, length is only 1.5. It's not much. So you may get tear also there.
Yeah, I think it would be a better.
How much was the loss of thickness? How much was the loss of thickness of the lenticule that you inserted because of, say, storage or something like that? Because normally
not much.
we get around 15 to 20 microns.
Yeah, that's right. So what we did was we did a whole statistical analysis that what was the expected PECI. So expected PECI was initial PECI plus thickness of the inlay. And what did the PECI that we came? So we found that the difference was not significant. So I think, and when we saw clinically also, it was hardly 10, 20 microns, because most of these tissue, they are stored in U-sole, right? Those MK tissues, they are generally tend to be thicker ones. These
MK
they
is
are
thicker,
not very, and we had removed the epithelium totally before we, harvested that graft.
In fact, also we get 10 to 15 micron loss of thickness. That's it.
Not much. Not much. Yeah. And it was not clinically, statistically, it was not insignificant. Yes, Rajat.
Did you prepare it at the same time when you were doing the surgery, or you prepared it a day
before? Yes, ma'am. Yes, absolutely. So first we took the patient so that we created, because maximum diameter that we can take, that depends on what is the wide diameter that you have. So most of them we had 9.2, 9.5, this was the maximum. So, and then we harvested the inlay, and then we went into main OR and immediately opened and, did the surgery.
There's a question by Dr. Uma. How about cross-linking the button before inserting? Dr. Vikas?
Yes. So yes, you can do that. See, why I didn't do that is there is a Bowman layer. There's a good Bowman layer, and all the tissues we used were more than 40 years, 60 years, 65 years, like that, which are already naturally cross-linked, right? So we thought that maybe because we are giving a good Bowman layer, and the anterior stroma that we have is again, is tough, so there is no need to cross-link, and we did it. And then another thought process was, in case it gets ectasia, we can always cross-link it later. So I didn't want to cross-link it. It might, cause haze. So I was not sure about that. So that's why I thought that maybe we'll do without cross-linking. But yes, that is also an option. We can do even cross-linking along with this. After doing this, we can cross-link it, because we have, 130, 140 microns odd. So even if you remove 60, 50, 60 microns, you can cross-link there also.
I thought, because this is the first step. This is the first step. So you see whether this works or not. And then you decide whether you do simultaneously cross-link it or subsequently cross-link it. That can be later. That can be a subsequent study, I suppose.
True. And in one of the child, we had done a cross-link in the other eye and BS inlay in this eye. And both we are following up. And both are pretty good. And BS inlay eye is, now started flattening also. This was a 10-year-old boy. So
but the primary indication would be for thinner corneas, where cross-linking also is not really safe or possible, and you will need to do it instead of using a contact lens or various other techniques that have come in. You just want to increase the thickness.
Correct.
Then
At the moment, but now we had a couple of patients where we have done even with the initial PECI of more than 450 microns, with an idea that if it works, maybe we can ablate it later.
Okay.
One last question.
Okay.
So
we
in
have 3 more
central
talks.
cones,
Rajat, yes, please, I couldn't hear you.
in central cones it would work nicely. What about the eccentric cones? So the thickness would,
True. That's a good question. So in case you have to take a larger graft, so the diameter of the inlay that we chose was maximum. So what we did was, so suppose I have a 9.5 millimeter intrastomal pocket. I'll try to use around 9 millimeter. So if it is 9 millimeter, that also it will, push there. So there has been 2 or 3 studies where what they did is they use only 6 millimeter. And they just place in the central cone. So if you place there on the, eccentric cone, it will edge come in the center and it will cause issues. So I don't know whether that will work, but as we all were discussing, the holistic thing, the keratoconus. So maybe even in eccentric cones, you place your new Bowman layer, maybe it works.
It should work for eccentric cones, but it may not work for pellucid because there the zone, it goes outside the zone of 9 millimeters.
True.
For eccentric keratoconus, it should work, but maybe not for pellucid. But anyway, you can observe that. So Jaya, can we have the next speaker? I think.
Yes, I think we have
we are
three
a
more
little short of
speakers.
time. Yeah.
Yes. So I invite Dr. Rishi Swaroop to give his talk on intraoperative problems and solutions in DALC. Dr. Rishi?
Hello. Hello, am I audible?
Yes.
Yes, sir. Absolutely.
Hi. Thank you. And I apologize for the way I'm looking. I'm in clinic. And I'm
you're looking good, Rishi. You're working.
I'm not in a very good internet, so I apologize in advance if the signal breaks. So I'll just start sharing my screen straight away. 1 second. Can you see my presentation?
Yes.
Okay, so the topic given to me was complications of deep lamellar keratoplasty. So I'm going to try and cover the scenario of what to do when things start going difficult in a DALC. So when we are talking about this, essentially it's intraoperative and post, the most common being and most important being the perforations, but we can have difficulties with bubble formation, problems with sizing and trephination and dissection related problems. Post-operatively, you can have things like a retained big bubble if you've not realized that you've not punctured it, interface problems like double anterior chamber, vascularization, opacifications, suture related issues. Rejection is a reality. With DALC, understand the kind of perforation you're dealing with so that you can manage it properly, whether it's a micro perforation or a macro perforation, whether it's central or peripheral, superior versus inferior. All of these factors will help in determining your approach to a perforation. Also the fact that whether you have a backup tissue or not. In general, most perforations can be salvaged. Only those which are very central and large are the ones which currently need conversion to a penetrating keratoplasty. So I'll just show you a few videos, some from my colleagues. This is one of Dr. Himanshu's cases in which basically he is trephining, and as he is trephining, he realizes that his trephine has gone full thickness. And when he looked carefully, he realized that basically about 200 degrees the trephine had gone full thickness. Now, in olden days, you would have just converted to a penetrating keratoplasty, but Dr. Himanshu is a fabulous surgeon. He sutured up the areas which had gone full thickness, and then he started doing a deep lamellar dissection from the opposite side. Of course, he could not do a descemetic DALC, but he did like a pre-descemetic dissection and came to the area of the perforation last. Rest of the dissection was done. He sutured the new graft in place, and then in the end, he took off the sutures which are anchoring the primary cornea, and that's probably the best thing he did. And you can see he got such a wonderful outcome in spite of a big complication. You can have problems with the big bubble if you're attempting that. So if you're using a needle, you can go full thickness. If you haven't taken too much air, you can end up with a partial bubble like you're seeing on the right. But these a partial bubble is really not a big problem. You can enlarge the bubble, or you could even leave it as it is and just have a central area of bearing. If you have a full thickness perforation also, it's not the end of the world. Maybe you can't do a descemetic DALC, but certainly a pre-descemetic dissection is possible. Now, we all know that big bubble, there are two types of bubbles. Ideal bubble is a type 1 bubble, which goes from center to periphery. But sometimes that air is between the pre-descemetic Duas layer and the stroma. But in certain situations, if the air goes between the Duas layer and the Descemet's membrane, that's called a type 2 bubble, which can go to the periphery. And essentially, if you bear this kind of a bubble, underneath that, you just have Descemet's membrane, which is very thin and fragile and ruptures easily on touch. As you will see in this particular video, you can see as I was dissecting, just a touch of my scissors, not even the blunt part of it, just touch, and you ended up with a macro perforation, like you will just see in a moment. And that's the end of the story here. So type 2 bubbles are not desirable, and that's one of the reasons big bubble technique is slightly unpredictable sometimes. So this is another case by Dr. Himanshu in which he was doing a dissection for a pellucid, and he was trying to get a big bubble by introducing a cannula. And what happened was, as he started injecting air, he started getting some stromal emphysema, and then suddenly he heard a pop. And anybody who's done DALC knows when you hear a pop, you know what it means. You're basically ruptured into the anterior chamber and you start getting an air bubble into the anterior chamber, as he's seeing here. That's a burst big bubble. And in most cases, if it's a big perforation, you'll probably need to convert into a penetrating keratoplasty. But here he dissected the stroma off and he realized it's a slit-like tear. So he left that as it is and put in a graft and put a large bubble of C3F8, and the patient did well. So the idea of showing you that is that even with a big perforation like that, you can salvage the situation most of the time. Central perforations can affect your vision and the cornea more, and may be more difficult to manage. Peripheral perforations, on the other hand, are much easier to manage. But even central perforations, if they are small, like in this particular case, you will see, you're seeing a big central perforation, but this patient was just managed with injection of an air bubble, and the graft was put on top, and you can see the patient did really well. He, in fact, has 6x6 vision at this point. If you're not careful while puncturing the big bubble, while doing the brave slash, if you didn't pay attention, you can end up doing a second slash and puncture the Descemet's, which is what I did in this particular case. So what I did for this scenario was try to seal the perforation with fibrin glue. People have also used cyanoacrylate glue to temporarily seal the perforation. And then you kind of do a peripheral dissection, as is being shown in the second video. So the central area being sealed with fibrin glue, you can do a peripheral dissection and then come to the central area last. And once you've kind of taken off the entire stroma, you will have a central slit-like perforation, which you can put a small patch of stroma like this, and then put air, which will then stay in place because of that patch of stroma. You can then put the graft on top and suture, and later you can remove the patch like is being shown in this particular video. So this was a central perforation that ended up doing well. But again, as soon as the air went away, we ended up with this situation where you have a double anterior chamber and entirely edematous cornea, and an OCT, you can see a perforation like this. But all you need to do is inject some air or a C3F8 kind of a bubble, and the Descemet's membrane attaches. You can see the perforation there, but the patient did very well. You can see 3 months later, clear graft. You can see the perforation. This patient did end up with a rejection after 5 months, but which was managed with steroids, and eventually the patient again got back a clear cornea. This patient finally had, after removing all sutures, had a lot of astigmatism, so was not happy with the vision. Then we did a topography guided PRK, and the patient now enjoys a very good spectacle corrected vision of 20/20 and is extremely happy. We did the other eye, and that also is now 20/20 parts. So patient, basically most complications, this patient had 3 complications, but all of them were managed, and the patient finally had a very good visual outcome, which probably you may not have got if you had a penetrating keratoplasty. This is a video, a case borrowed from Dr. Nitesh. Big bubble was attempted, presumed failed. So they proceeded with a pre-descemetic DALC. And first day when he saw the eye, this is what it looks like. The cornea looks very clear, but the pupil is very dilated. Anterior chamber seems very deep. IOP was high. And he did an OCT. He realized that the big bubble was still there. And he had not realized there was actually a bubble. So all he had to do was go puncture the base, release the air, and this patient then did well. So if you're not careful, you can miss a big bubble. Sometimes if you have a microperforation, I showed you similar, you can have double anterior chamber, but all you need to do is do an OCT if you're not sure and put air or C3F8, and these patients do very, very well. Now we have so many endothelial keratoplasties which we are managing just by doing this, and we know that this works. Infections can occur in the interface and the graft. Interface infections are a little more difficult. Atypical mycobacteria has been reported, so you may have to actually change the graft. Just treating medically usually doesn't cure the interface infections, but if it's a graft infection, of course, that responds well. Astigmatism is a bugbear of any keratoplasty. This is a patient, great graft, looking very clear. We tried astigmatic keratotomy for the astigmatism, but didn't work. Finally did a topographic guided ablation. So topographic guided transepithelial ablation is what I like to do. And of course, at least a minute of mitomycin, sometimes even 2. And this patient again did fabulously well, as you can see in the next slide. So you can see the topography regularized, graft remains clear till date, and patient enjoys a good vision. Rejection can happen. It's not like DALC is free of rejection. This is our series. We realized 82% of our rejections were stromal, but you can have subepithelial, epithelial, and stromal. So these are just some pictures of epithelial plus stromal rejection with vascularization. But the good news is most of these rejections do resolve, but the odd patient can end up with interface haze or some scarring, but most of them clear up very well. This was one patient I borrowed from Dr. Vikas, where FALC was done and presented with interface fluid similar to what you would see in an interface fluid syndrome, but it was actually a rejection. And when treated with steroid, it resolved very beautifully, as you can see in these pictures. Graft melts can occur because of suture or because of a viral infection or immune pathology. This was one of the cases I borrowed from Dr. Sangeeta Wagh. It needed a lot of things like TABCL, antiviral steroids, but could come under control, but ended up with a interface vascularization and scarring. Now, such a case sometimes is difficult to treat because you don't know what to do with the interface vascularization. You could try a ReDALC, but if that doesn't work, eventually you need to go for a penetrating keratoplasty in some of these patients. So to conclude, intraoperative and postoperative complications can happen in DALC just like any other surgery. Perforations are the main bugbear. Most of the complications can be managed without converting to penetrating keratoplasty. That's the good news. Rejection can occur in DALC, but most rejections resolve very beautifully and have a good outcome. Thank you.
Thank you, Rishi, for a very comprehensive presentation and some neat little tricks. Any questions, or we can, because I think we have two
more talks. Yes, so
yeah.
we can proceed with the next talk.
Rishi will be around in case there are questions.
Yes, yes.
Okay, thanks.
I'll probably have to leave by 4:30. I have another session.
Okay.
Yes, Uma ma'am is taking the next talk. Acute high drops, management of acute high drops.
Given to me was acute high drops. We heard Praveen saying that the numbers of high drops was less, and Ashu was asking why. High drops means abnormal accumulation of fluid in tissues or cavity. Fetal swelling in utero is also called hydrops fetalis, often due to Rh blood group isoimmunization. Incidence in keratoconus is about 3% on an average, up to 11% in pellucid. It can also occur in post-classic ectasia, post-RK ectasia also in. The age of onset on an average is 25 years, more in males. Incidence may be more with eye rubbing, with atopy, with BKC. We have seen a lot of children with Downs having high drops. It is a compromise of the barrier function of the Descemet's membrane and a fluid uptake by the corneal stroma. The resolution by 2 steps. One is the reattachment of the Descemet's membrane, and the second is the migration of endothelium from the reattached Descemet to cover the ends between the broken ends. Now here there is one paper which showed the curled up Descemet's membrane, and after a few months you can see that the 2 edges are there where it was broken. And in this paper, the electron microscopic studies were done, and also a detailed analysis of the collagen of the cornea. Now, the investigations that we can do in an acute hydrops would be an anterior segment OCT, a UBM, and a confocal microscopy. Now, you can see the break in the Descemet's membrane, the fluid clefts in the stroma. And so how do you manage them? So there is either you can leave it alone, be very conservative, or you can have a medical management with hypertonic saline, anti-inflammatory agents, like steroids, as the patient has a lot of pain, photophobia, watering, and a bandage contact lens can be used. The surgical treatment commonly done is pneumatic desmetopexy with 20% SF6 or 14% C3F8. Now only air. So what happens when you use only air? The corneal edema lasted average 20 days in this study, 9 patients getting intracameral air, as opposed to 65 days average in the patient where nothing was done. And these patients who had air could reuse the hard CL in 1/4 the time in which the control group could use. And there was no difference in the BCVA in the two groups after the edema resolved. Now this paper is by Miyata et al. Now Panda et al. Have seen a resolution in average of 4 weeks in 9 patients receiving SF6 as compared to, can I just have this closed? Sorry, in previous slide. Yeah, in patients in the control group, it took a much longer time. And Basu et al. Also saw that it was an average of 57 days in 62 eyes as compared to 104 days in control group of 90 eyes. Now, one of the authors of that paper, Praveen, was here. We could have asked him. The BCVA was not much different after a period of the resolution. Now, here you find that pneumodesmetopexy has also been reported in this case report. You can see the pre and post-op pictures in this study. Now, Ting et al. Also used C2F6, and everybody found that there was no difference in the need of transplantation in the control group or the group which received the pneumodesmetopexy. People have also used compression through and through sutures to attach the Descemet's membrane. Cyanoacrylate glue and amniotic membrane grafts have been used. Venting incisions like you would do in a DSEC in the interface pocket has been done in this study where they have injected intracameral dye through a paracentesis, and then the trypan glue was injected there, and there they found the clefts, and they could kind of do the venting incision. Also, this paper from RP Center has also described anterior segment OCT guided technique for management of acute corneal hydrops, where they used venting incisions. Now, just a small video. I think all of us know how to inject and how to prepare the C3F8. It's already been injected here. This is a young girl who had Down syndrome. I had injected it in both her eyes. After a few years, I had to re-inject it. And in this patient, one could not think of any kind of penetrating or lamellar keratoplasty. And all her symptoms resolved after it scarred. This is another patient who had, you can see that injection and then scarring. And post the scarring, the contact lens could be fitted with kind of, at least her vision was 618. She thought she had lost that eye. Now, the grade of hydrops has also been described by the RP Center. When you see it in the OCT, you can see whether it's a 3 mm, 3 to 5 mm, or more than 5 mm break. And you can decide on the procedure that you can do, and larger breaks may necessitate the suture and the venting incisions. Use of intra-op OCT may help to decide the procedure in the OR. Now, in the paper by Miyata et al., who used just air, they found that 78% needed rebubbling because air lasts just 2 to 3 days. The post-operative complications can be elevation of IOP, infection, endothelial damage, intrastromal migration of gas has been also described. A few people, they do an inferior PI and then they give a full fill of, they give a fill of air. Preferably the air should be only 2/3 fill, and also the C3F8, because, and the expansile gases, obviously, one should not do a full fill. The rehabilitation after setting of edema, maybe the scarring may flatten the cornea, leading to better fit of contact lens. DALC may be done, as my next speaker would say, but it may be challenging. PK is usually done. Basu et al. Found that 98% success of clear graft and no rejection in patients who did not have hydrops versus 83% success rates in patients who had hydrops. Thank you for your attention.
Thank you, Uma. Very nicely presented. And I do believe that C3F8 has an important role in managing patients of hydrops, although the net outcome may not be any different, but yeah, the rehabilitation time or the recovery time is really enhanced. Can we have the next speaker? Susan is here, right? Susan, can we have your presentation?
Yeah, sure, sir.
You'll be talking on DALC in acute hydrops.
Yes, sir. I'll be talking on primary predesematic DALK and acute hydrops, which means that we don't wait at all for any resolution. We operate as soon as the patient presents to us. So what I'm going to do is I am going to just play this video, which I had prepared for the film festivals. And I think it's a very comprehensive video, and I'll just request the audience to listen to this.
None of the producers have any financial interest in the products or procedures shown. Advanced keratoconus can progress to the dreaded acute hydrops, a break in the Descemet's membrane with aqueous seepage into the stroma and stromal edema. Resolution occurs with stromal, pre-descemetic and descemetic level scarring and often decreased vision. All current treatments result in a scar, often involving the visual axis. A devastating condition. Many patients eventually require a deep anterior lamellar keratoplasty at a second stage, or very often even a penetrating keratoplasty. Can the visually significant scarring and other complications secondary to the currently accepted treatment modalities be avoided? We introduce a modified technique of primary pre-descemetic DALK for acute corneal hydrops as primary management to avoid post-hydrop scarring while providing visual, optical, topographic, refractive, structural, and biomechanical improvement, while also decreasing contact lens dependence and avoiding other complications. There are three important considerations for successful surgical outcome. First, the edematous stroma above the Descemet's tear should be dissected without stressing the tear. Second, thin layers of pre-descemetic tissue should be retained over the tear in order to avoid opening the anterior chamber. And third, the Descemet's tear should be air tamponated from within. These principles help early recovery without scarring. The host cornea is trephined to partial thickness, and the groove is further deepened with a bevel-up crescent blade. A 26-gauge needle is bent bevel up rather than down, unlike conventionally done. It is then mounted on a 1 ml syringe, and the needle is inserted tangentially at multiple spots around the tear, injecting small aliquots of air slowly in a graded manner, avoiding acute buildup of air pressure. The aim of injecting air is only to induce emphysema and not to obtain a big bubble. The anterior stroma is then debulked with a blunt crescent blade using the emphysematous cornea as a guide for the depth of dissection. Air is then injected into the anterior chamber, and using the Meles technique, deeper dissection is performed circumferentially from all sides, starting from the periphery and working carefully towards the center. The central undissected stroma is removed at the end, dissecting carefully over the area of the break. Finally, Descemet's membrane is removed from a donor graft, and a same-size button is sutured to the recipient bed. In eyes with extensive edema or marked thinning, an inked trephine mark is manually deepened. Minimal stroma is intentionally retained over the tear in order to maintain a closed anterior chamber. In contrast to our technique, the current conventional techniques leave much to be desired. The cornea heals, taking 2 to 5 months, and forms a scar. During this period, complications such as perforation, non-resolving edema, scarring, thinning, and ectasia can occur. Intracameral gas and transcorneal sutures can have intraoperative and postoperative complications. Because of the unsatisfactory nature of the current techniques, a second-stage rehabilitation is needed, which can take one of three forms. First, rigid gas-permeable contact lenses when scarring doesn't involve the visual axis. Patients are exposed to all the disadvantages and risks associated with contact lens wear. Special, expensive contact lenses are often required. Second, deep anterior lamellar keratoplasty when the scarring doesn't involve the visual axis. But as a big bubble technique may result in micro and macro perforations in a scarred cornea, only manual dissection pre-decimatic DALC is possible. Full scar removal is not possible, as the scar is full thickness, unlike our modified technique where scar formation itself is avoided. Third, penetrating keratoplasty. This becomes inevitable if perforation occurs during a second stage DALC or if scarring involves the visual axis. Unfortunately, the patient is then exposed to all complications of a penetrating keratoplasty. In our published case series of 9 patients, all cases were completed uneventfully, with none converted to a penetrating keratoplasty. Visible emphysematous cornea below the dissector allowed dissection depth to be gauged safely. The slowly injected air did sometimes uneventfully enter the AC without any enlargement of tear. No other intraoperative complications were encountered. Pre-operatively, the visual axis was involved in all cases. The ASOCT slit lamp and intraoperative endo-illuminator can be used to locate the tear. Post-operatively, the torn Descemet's edges with clear overlying cornea were seen in all cases. Our technique thus allows excellent outcomes in these eyes with end-stage keratoconus. Successful anatomic and visual outcome was attained in all cases. Rapid break closure with rapid removal of edematous stroma and accompanying inflammation is probably responsible for lack of any significant scarring with our technique. Intracameral gas under an ectatic cornea keeps the torn Descemet's edges widely separated. Primary DALC brings these edges close. The area over the tear is clear because of a narrower area for adjacent endothelial cells to migrate over. This contrasting case of 2 adults with Down syndrome, one treated immediately to prevent complications and the other referred after conventional treatment, illustrates the importance of immediate pre-decimatic DALC with our technique. Thus, the advantages that our modified technique gives are that of a single-stage treatment that gives early and rapid visual and anatomic rehabilitation. It retains host Descemet's and endothelium and avoids the comorbidities and costs of a second surgical procedure. One might wonder why so much fuss about a rare condition. However, with a reported incidence of up to 3% in patients with keratoconus and even up to 11% in patients with pellucid marginal degeneration and keratoglobus, this can add up to significant numbers. For these patients, instead of a scarred, thin, ectatic cornea with poor vision and awaiting a second surgery, with our technique, we are able to achieve a clear cornea with anatomical, visual, refractive, optical, structural, topographic, pachymetric, and biomechanical rehabilitation, with less risk of complications and a single surgery.
So I think that brings me to the end of my presentation. I'll just stop sharing. Thank you.
Thank you, Susan. Nice presentation. Any questions? I think we've already overshot. We can probably take just one last question. Rishi, any comment?
I've seen this before. It's a very good technique.
Yeah. Right. So that brings us to the end of the session. Thank you, everyone. And over to Dr. Rishi Mohan for the next session.
Thank you. Thank you so much.
Thank you. Thank you, sir. Dr. Rishi? So for the next session, I think...
Yeah, we are here.
Dr. Rishi Mohan, Dr. Vinod Arora, Ajay Dave, Himanshu will be joining us 20 minutes later, and I'm there. Can we start the next session now? Dr. Rishi?
Good morning, Ashu, can you hear me?
Yeah, I can hear you, sir.
Wonderful. So we have a wonderful faculty and excellent talks. And I'm looking forward to
Himanshu is logged in. He'll be coming in 20 minutes later.
Okay, so he's supposed to be moderating the session.
Hi, good evening, everybody.
Yes, sir.
I'll be there in 10 minutes.
Oh, it's all right, Himanshu.
I thought I heard Himanshu, but I don't see him.
No, he'll be joining us 20 minutes later.
Oh, I see.
He's in the car at the moment.
All right. So I think we all know about cross-linking, and it's become now the craze, or it had become the craze about 15 years ago when it came in. And we've got a number of speakers, and we have lots of very small talks. We hope everyone will stick to their times. We're already starting about 7 or 8 minutes late, but we'll try and see if we can make up time. I was looking at the sequence of the talks, and I see a talk in the middle on complications and another one by Dr. Lionel on stromal augmentation. So maybe we can put those at the end and go with all the technique related talks first. So if Dr. Vinod Arora, who's co-chairing with me, can please start the ball rolling. Welcome, Dr. Arora.
Thank you. Good evening to all. I'll be just sharing my screen. My slides are visible?
Yes, they are.
Okay. So basically, we are going to talk on current protocols, what we are using nowadays in CXL as such.
Your slides haven't come on, Dr. Arora.
Pardon?
Your slides haven't come on. We are on yours. We are seeing your screen, but not your slides.
Okay, I'll do it again. Just give me a minute.
Is your presentation on your screen?
Yes. Just a minute. I don't know why it's happening.
No, you need to open your presentation. Your presentation is on your screen?
Yes.
Excuse me, sir.
Can you start the second meanwhile?
All right, we can ask, is Dr. Sanjana here?
Yes, sir.
Hi, Sanjana. Good afternoon. Can we start with your talk? In fact, it's a good talk because it's on different techniques and recent advances. So please go ahead and let's hear while Dr. Arora sets up his presentation. Go ahead.
I cannot share the screen because the other participant is sharing.
You have to, Dr. Arora, you'll have to shut your screen, please.
Yes. Okay.
Yes, great. Sanjana, yes, we are ready to have you.
Is it seen, sir? The screen?
I don't quite see you yet.
Yes, no, it's okay.
Excellent.
Good afternoon, everyone. I would like to thank DOS for this wonderful opportunity. So today I will be talking about the cross-linking techniques in keratoconus and the recent advances. Now, I don't have any financial interests. Now, we know that there are various techniques of cross-linking. Mainly, we have the conventional cross-linking, accelerated cross-linking, pulsed, then the customized cross-linking, the Athens protocol and the Cretan protocol, where we combine the cross-linking with other techniques. And then we have the pixel, and lastly, the cross-linking in thin corneas. So the different talks are also included in this. I would not be going into too much details of each, but would be just giving the overview of them. Now, first of all, we know the conventional cross-linking is a normal Dresden protocol, and this is commonly followed where the corneal pachymetry thickness is more than 450 micron, where the epi-off technique, we use a riboflavin 0.1% with 20% dextran soaked for 30 minutes, and we give the ultraviolet radiations at 3 milliwatt per centimeter square for 30 minutes, and total fluence of 5.4 joules per centimeter square. And I guess the details of it will be covered in other topics. So I would just move on to the next one. That is the accelerated cross-linking. Now, in the accelerated cross-linking, it mainly follows what is called the Bunsen and Roscoe law of reciprocity, which says that the effect of a photochemical reaction is directly proportional to the total irradiation dose. That means to say that even if we increase the intensity of the radiation and decrease the duration, we would still get the same effect. And here we can see that There are different power modulations and durations, most commonly being followed the 9 milliwatt per centimeter square for 10 minutes. Now, this has shown to have a good efficacy, which is comparable to that of the conventional cross-linking. However, it has been seen that the depth of demarcation line is slightly shallower in the accelerated group, probably because of the decreased oxygen or reduced oxygen availability because of the shorter duration as a comparison with that of the conventional cross-linking. But yet it has the various advantages that it reduces the procedural time and also it decreases the patient discomfort. And since the duration is shorter, it reduces the excessive stromal thinning and thereby it protects the endothelium. Now, next, moving on to the pulse cross-linking. So first, we need to understand what exactly is the basis of cross-linking. Now, we know that there are mainly two pathways. One is the oxygen-independent, which is the minor pathway, and the oxygen-dependent, which is the major pathway. So the oxygen-dependent pathway mainly produces a reactive oxygen species, which forms the covalent bonds and thus forms the cross-linking to improve the biomechanical strength. Now, when we are giving an accelerated cross-linking, either we can give the ultraviolet radiations in a continuous manner, like 30 milliwatt per centimeter square power for 4 minutes, or we can give it in a pulsed manner where we can increase the duration to 8 minutes. Now, during this time, we have a 1 second on cycle and a 1 second of off cycle. Now, what exactly happens during this time? So basically during the on cycle, there is oxygen utilization. During the off cycle, there is oxygen replenishment. Thus, it provides a greater oxygen availability and thus a greater cross-linking effect and a deeper demarcation line and a better biomechanical strength. Now, again, there are so many experiments which show that the oxygen utilization takes about 1 minute or 1 second or 2 seconds, but the replenishment takes a longer time, maybe even more than a minute. So just giving a 1 minute on and a 1 minute off, how efficient would it be to provide a greater oxygen for greater biomechanical cross-linking is something still questionable. Now we have another technique called as a customized cross-linking. Now for this, we need to understand that the keratoconus is considered as a focal disease where there is a focal biomechanical change. There is a focal steepening with a thinning and weakening of the cornea more than the generalized weakening. And thus they came up with the concept that when we provide greater amount of radiation or to the concentric, rather we concentrate the treatment on that particular area where there is a greater weakening, would provide a better biomechanical strength. Now, this is what has been followed with the recent Avedro KXL2 system, where we can see that the ultraviolet radiation can be given in the sectoral manner or in the concentric manner. Now, as we can see that the center part of it is where there will be the maximum biomechanical weakening. That is where we give the maximum the energy. And then we have the surrounding area with the lesser and then the peripheral area much lesser. So similarly, we can see that the central concentric circle as well, and this will be the maximum energy provided, which is the area of maximum steepening and weakening. There's greater biomechanical strength in that area. And the studies have shown that this has provided good results in terms of safety and efficacy. We also have got certain combination treatments. Now, the main thing is that in keratoconus, it is not just that we are bothered about the biomechanical strength, but also about the visual acuity, because there's a lot of corneal irregularity, which can resulting in the drop in the best corrected vision. Now, we have certain combination protocols like the Athens protocol, where we mainly combine the cross-linking with the topo-guided partial PRK. Now, this is mainly done in 4 stages. The first stage being the topo-guided partial PRK is done. And usually we reduce the ablation depth to, we limit it to less than 50 micron. And then we have...
Hello.
मैं convener वगैरह हूँ.
Ashu.
बच्चा बुला लो.
Hi, Ashu. Hi, Ashu.
Please, everybody keep silent. Yeah.
And finally, this is followed by the cross-linking. Now, basically, combination of this one, it is going to improve the biomechanical strength and thereby it stabilizes the keratoconus progression. Second thing, it also regularizes the corneal topography. And this would be of a greater help in case of keratoconus patients because it improves the best corrected visual acuity and also the tolerance to glasses or even contact lenses. Then came up the Cretan protocol, which was introduced by Carminos et al. Now here mainly it concentrates upon the way of epithelial removal technique. So we have the manual technique and then we have the trans-PTK mode. So the Cretan protocol involves the epithelial removal in the trans-PTK mode. So this is being combined with the cross-linking later. So according to this, it says that the PTK mode of epithelial removal would be a smoother way, and also it brings about a slight underlying stromal ablation as well. Thus it regularizes the corneal surface in a better way and again improves the best corrected visual acuity and at the same time provide a biomechanical strength when combined with the CXL. Now we also have something called as a photorefractive intrastromal cross-linking called Pixel. Now this is mainly used for the correction of low myopia, particularly less than 2 diopters, where high fluence irradiation is being concentrated on the central part of the cornea and which produces a localized flattening and thereby provides a myopic correction. This again is done with Avitro KXL2 system. It also has got an integrated pupil tracking device. So the pupil tracking would help us in concentrating it in the central part where the treatment effect is most required. Now we will be moving on to the cross-linking the thinner corneas. Again, this is a different talk in the same session, so I'm not going to go into details, but just the overview of it. Now we have the hypoosmolar cross-linking. We know that when the corneal pachymetry is less than 450 microns, it is not safe to go ahead with the normal protocols. Now, one of the technique is using a hypoosmolar riboflavin without the dextrin, which would artificially increase, or rather it causes a corneal hydration and thereby increases the intraoperative thickness and also reduces the endothelial toxicity. Now, then we have got the transepithelial cross-linking. This again has got certain advantages that it reduces the post-op pain, irritation, and infections, but has got a limited penetration of riboflavin and also not very satisfactory result in terms of the efficacy. So to improvise on this came the iontophoresis cross-linking, where mild electric current is used, which facilitates better riboflavin penetration through the intact epithelium. And then we also have got the customized pachymetry guided epithelial debridement. Now the customization is that wherein the epithelium is left intact over the area of the thinnest cone, and thereby it provides better safety, but yet again the penetration of riboflavin would be lesser, and we have got a shallow demarcation line, thereby reduced efficacy. And we also have got the smile lenticule assisted cross-linking introduced by Sachdev et al. Now here they use a smile lenticule which is being placed over the apex of the cornea. This causes a physiological increase in the thickness and then is followed by the cross-linking. But it has got certain limitations that there is a limited access to the donor lenticule, and also we need a lenticule of sufficient thickness, probably about 7 to 8 diopters to give the required thickness. And also there is unpredictability and variability of the donor tissue pachymetry, sometimes based upon the cylinder powers, and also the storage would be another big question. So now what we have been commonly following in our institute is the contact lens assisted cross-linking, CSEXL, introduced by Dr. Susan Jacob in 2012. And we have been following this technique with great results. So we use basically the ultraviolet barrier-free contact lens soaked in the riboflavin solution. And this contact lens approximately increases the functional pachymetry by about 100 microns. So this is placed over the cornea and then followed by the ultraviolet radiation with the continuous accelerated protocol. Now, we have seen that in our results, there is a good stromal demarcation line depth of 250 micron comparable to the other techniques. And we have not seen any progression of keratectasia, and regression was observed in 4 eyes. There was no significant endothelial loss as well. So there are important points to consider in this, that we need to avoid excess riboflavin installation above and below the contact lens. And also it would be better if we use a riboflavin which has a lesser viscosity. For example, combining the riboflavin with HPMC rather than dextrin would be better because it reduces the corneal dehydration and also it would provide better safety. And here again, we have seen that the riboflavin penetration is deeper when used with HPMC and thereby gives better results. So the advantage of using the CSEXL technique is that it is independent of any swelling properties of the cornea, and we don't require any expensive additional requirements. And also we have our experience and a lot of unpublished data as well, which says that it can be easily and safely performed in pediatric patients as well. Now, lastly, I would like to just touch upon this. So usually in cross-linking, we either think about increasing the corneal thickness or we change the riboflavin concentration. But now the new concept being about variation in the ultraviolet intensity or the adapted fluence. Now, this is being introduced as a sub-400 protocol by Hafizi et al. Now, it says that basically in cases of cornea thickness, let's say the corneal thickness is about 400 micron. Normally, we would use 5.4 joules per centimeter square as the total energy. But if the thickness is lesser, then the duration would be lesser, such that the total amount of energy will be adjusted so that it is going to provide a safe dose. Safe dose as in that the demarcation line would be at least 70 micron meter above that of the endothelium. So yet we are about to, we have to receive what exactly would be the duration that would be required for what thickness. It's not yet been published, but this is the newer technique that's been coming up. Now, finally, I would like to conclude by saying that in case the cross-linking is something which is constantly upgraded and also it's evolving and there are various techniques and each one has its own advantages and limitations. So customizing the treatment would be a better option so that we take into consideration the safety and efficacy and also in terms of visual and refractive outcomes altogether. Thank you all for your patient listening.
Thank you, Sanjana. I think you brought in the overview very, very nicely, and I'm going to request since Dr. Arora's talk is.
I'm ready. I'm ready.
Yeah. Shall we start?
Yes, please. Can you unshare, Dr. Sanjana?
Sanjana, can you
yes, sir.
Exit the screen, please? Hi. Sanjana, can you exit the screen, please? Can you stop the share screen?
Yeah, sure. Yeah. I guess it's fine now. Yeah.
No, not yet.
Dr. Sanjana,
I have stopped, sir.
No, it's not unshared.
It's still sharing.
Yeah, it's unshared now.
No, it's okay.
I think I'm visible now. Yeah?
Oh, yes. Excellent.
Thank you. Thank you so much. Sorry for the initial hiccups. Basically, it was a new laptop I'm using, doing first Zoom on it. Okay. So there will be some repetition of the talks also. So we are going to see what is the current protocol. Basically, CXL is a dynamic process. It's changing rapidly. Here we are finding newer applications, newer ways. So with our understanding, we are changing the protocol also. So let us see what is there. The standard protocol was you doing a epithelial removal, then using riboflavin with Dextran, 3 bits for 30 minutes. Then UV exposure again for 30 minutes. Ribo has to be used for every 5 minutes. It was followed by bandage lens, medicine like antibiotics, lubricant, and steroids. This was a standard protocol and remained for years. Now we got a lot of choice with us. First, we go to the riboflavin. We have got now variety of riboflavin depending on the procedure we want to do. It's a transepithelial with HPMC and BK. Then the most commonly used with HPMC, Dextran is not used anymore. And we have hypertonic solution with riboflavin. Then for LASIK extra, we have the little stronger 0.23% of the riboflavin. So depending on the procedure, we can choose what sort of riboflavin is suitable for us. So the most commonly used for standard is with HPMC. Then coming to the epithelium off or on, epithelium off is approved by FDA. Epithelium on is not yet approved, but there are a lot of things is going on and being very, very safe. Probably epithelium on is catching on, but as on today, epithelium off is a standard procedure. If we have to remove epithelium, we can do it manually. We can do it with the alcohol, but PTK is the most standard procedure because it takes care of the cone of the apex of the cone. So it gives a more regulation. So PTK is preferred once we have to remove the epithelium. It may be manual or local, should not be done. PTK is a better choice. If you got a facility, do it. Then comes the thin cornea. I think Dr. Sanna has already covered is 400 is the normally we do it. What the thin cornea is up to 360 micron, even thinner than that, we can use it. First thing is the corneal swell up. We can use a hypo solution that can swell up. Then we have to use a contact lens. The important thing is it should be non-UV. Or we can use a corneal lenticule from the smile. Or if there is a small point which is thin, that's mostly on the cone, we can leave a button there and we can do the cross-linking there also. And ribo has to be used with the methyl cellulose. Now we have got the customized CXL based on the thickness. That's called the adaptive fluence, where we can just adjust the amount of CXL we want. So the thinner point can be safely done once we set the limit, whatever amount we want to achieve there. This is Dr. Farhad Hafizi has just shown we can do it in a sitting position also. I'm not a great fan of it, but it's a newer technique. Let us see how it's more comfortable than lying on the table. This is an instrument used for sitting CXL. This is the Epion. The success of Epion depends on intelligent combination of various factors. Iontophoresis has added an advantage to it. Then pulsed, slow, high fluence, and there should be air or oxygen should be there. So Epion can take place. But still, the process is on and we are waiting for the long-term results. Now coming to the very end, Dr. Sanjana has told that we can reduce the time depending on the energy increase, but it's not in linear fashion. Once we reduce the time and increase the energy, the demarcation line starts coming up. Once just see if it's 30 minutes, the demarcation line is somewhere around 350 or 300 plus. But once we reduce it to 10 minutes, it comes down to 288. But once we reduce it to 4 minutes, it comes down to 160. That's too low. So we have to have some compromise. So at present, 10 minutes is supposed to be a more popular thing where we are getting the limit reduced time, but also getting the same efficacy. So 10 minutes or the 9 minutes is a standard procedure now as on today. Coming to the customized cross-linking. Now we can do cross-linking in various ways. Conventional cross-linking achieve conventional cross-linking causes a uniform stiffening. But the problem is our weak point are stiffened same way while the rest of the part is also stiffened. If we stiffen it the focally, that provides the uniformity. That means we have to provide more stiffening on the weak part so that we can customize now. It's much easier. Earlier, we were using thinnest part of the cornea. We were using mask for that. Now we have got inbuilt system. We have axial map. We can tangential map. We can do sectoral beam. So we can change the shape of beam and do maximum cross-linking on the weak part. So that completely become more stiff compared to other parts. Then pulse CXL, it's a more depression of oxygenous there in accelerated CXL. So providing pulse CXL causes deeper demarcation. So if we are going to reduce time further, we have to use pulse CXL. There is a better diffusion of oxygen and we got a deeper demarcation line. The combining with PRK has been already covered. The only thing we have to do PRK first. Our aim is not to eliminate the refractive error. Here we just want to regularize the cornea. If the cylindrical number is too much, then it's help. We have to combine it with PRK. So it's basically topo guided. And the results are very, very good. It reduces a lot of higher order aberrations in these cases, but we have to follow certain restrictions and follow the nomograms for that. Then corneal remodeling in KC. This is basically a new technique described by Kaisar Kizio just a few months back. There he giving a wedge type of resection like this and stitching them. So it causes corneal flattening. Just like we do Intex or we put a Intex inside and that causes flattening, it is just putting a wedge incision, then resuturing it. That causes flattening of the center. But it can be titrated depending on various geometric figures. Of course, the long-term results are still awaited. This was introduced a few months back. Then we all know LASIK causes weakening of the cornea. So in risk cases, we can combine it with LASIK and the correction can be done. It's a short term, but it provides a good strength. It's called the LASIK extra. CXL with Intex have an additive effect. We should combine the two to get the maximum effect. It causes the flattening also and strengthening of the cornea also. Then hyperopic shift following LARK in some cases responds to LASIK, this CXL, but not all cases. So sometimes it halts the progression of these cases. Then CTR for refractive effect. We all know the C3R causes flattening of the cornea. So can it be titrated to give a myopic correction to the patients? If we do it, say, as epi-on, that will be great. Because the reason is all the refractive process so far are the ablative process. We are taking a tissue from the cornea. Here, this is the process where we can strengthen the cornea. But you need a lot of term study and can be alternative to a LASIK visit correction. Then CTR for pediatric keratoconus, it's a little controversial. I think it will be covered by the subsequent speakers. PK has poor prognosis in younger age group. CXL is a good alternative in these patients. The first report was published on pediatric CXL is in 2011. Since then, a lot of reports have come. Some are in favor, some are not in that favor, but it's catching up. Pediatric KC is a very good option because the progression in young patient is very, very high. In PMD, we have to use eccentric treatment. In pellucid margin degeneration, we can use a Merosal sponge for the protection ring to protect limbal cells, and eccentric corneal light exposure can treat this thing. Then in pseudobullous keratopathy, is it proven to be very good, and lots of efforts are being done. People are trying to standardize it, but it has proven a good alternative to these things. Then cornea melts, lower radiation, 2.5 milliwatt per centimeter square, to compensate thinner cornea. This causes resistance to increase of the digestive enzymes. So digestive enzymes can't work on the cornea. Then infectious corneal ulcer, there is a lot of positive reports. It is called the PAC-CXL, where photoactivated chromophore keratitis corneal cross-linking. It's proving very, very good results, and a lot of cases are being treated now. But still, we have to see the standard protocol for this. We are waiting for that. And we have to remember, once you do the C3R, the cornea becomes stiff, and there is a false IOP values in C3R, post C3R. So we have to take a base IOP value before doing the procedure and compare it afterwards. Then we can know the exact values by using both the readings. So just to summarize, it's not a rigid procedure. This is under development, and modification are part of this development. Careful evaluation of the efficacy and safety of this modification by means of several methods and several study groups should be done. So we got a no choice, and we can do it in various ways, in various things. Thank you. Thank you so much.
Thanks so much, Professor Arora. And I think we are going to be running short of time, and we have lots of speakers. So I think it may be nice if we can continue with the next talk. And the next talk would be by Dr. Chintan Malhotra, which is on the outcomes of transepithelial cross-linking.
Requesting everyone not to exceed 7 minutes, because even then we'll go beyond the time. So please stick to 7 minutes at the most.
Thank you, sir. And a big thanks to DOS. And I'll be speaking about the outcomes of transepithelial CXL and keratoconus. I'll try to keep it as brief as possible. So we know that the standard epithelium of CXL protocol has been the gold standard in terms of evaluating efficacy and safety. The epi-off procedure is, however, associated with potential complications of epithelial removal, that is infection, delayed healing, scarring, discomfort, and pain. And thus, eliminating the step of epithelial removal seems desirable as well as logical. There were some challenges associated with CXL. One is that there is the attenuation of the CXL effect due to the absorption of UV light by riboflavin-soaked epithelium, since we are keeping the epithelium intact. And the second is that since riboflavin is a negatively charged hydrophilic molecule, it has limited penetration through the intact epithelial tight junctions, the epithelium being lipophilic. The second part is, however, taken care of, and the epithelial permeability can be increased by various ways. For example, the most commonly used is the chemical enhancers, where we have the EDTA, BAK, tetracaine, and trometamol. Secondly, most PECXL riboflavins use an increased riboflavin concentration. We can do mechanical disruption of the epithelium, create stromal channels, or apply a weak current across the cornea, that is iontophoresis, to increase the permeability. So what are the disadvantages of standard epi of CXL? Are the advantages of TECXL? It's proposed to have less pain, less infection, less haze, And it's, of course, the most important thing, it's an option for treating thin corneas, which is where it's been mostly used for. But the results that I'll be showing for various studies have been using TXL even in corneas with normal thickness and compared it to the conventional CXL. So the downside of TXL, apart from its advantages, is that for the Dresden Epi-Off procedure, the biomechanical strength of the corneas was shown to increase by approximately 320%. And the demarcation line occurs at approximately a 60% depth, that is 300 microns. And the common thing is that demarcation line represents the depth to which the CXL has been effective, although we are beginning to question that now. On the other hand, TECXL has been associated with only a 60 to 65% increase, that is a 1/5 increase of the biomechanical strength, and much shallower demarcation lines, and hence doubts exist over its efficacy. Now, what does literature say about TECXL? So this is a busy slide, multiple studies comparing the standard Epi-Off CXL versus TECXL. The ones in red show that the Epi-Off CXL is more efficacious. However, most of these studies also say that TECXL had less complications and more patient comfort. The ones in blue show that both techniques were equally efficacious and TECXL was a less painful procedure. So there's no clear consensus, although most studies, the balance seems to be in favor of Epi-Off CXL. This was an interesting meta-analysis which was published 2 years ago in Cornea, and it was a strong analysis. It had 8 studies with a total of 455 eyes, almost 225 eyes in each group. And what they showed was that for the keratometry, the standard Epi-Off CXL and transepithelial CXL with the chemical enhancers were almost equal in reducing the mean K and as well as the Kmax. However, iontophoresis-associated TXL induced a lesser reduction of the K. The visual outcomes were comparable across these studies for both protocols of CXL. Adverse events like stromal haze and edema were more common in the standard CXL. However, these were transient. It did not induce a significant visual impairment. So this meta-analysis seems to suggest that at least transepithelial CXL is comparable to the standard Epi-Off CXL. And it had a comparable effect on most parameters which were evaluated at 1 year after surgery. The other sticky field is TXL in pediatric population, because we know that keratoconus in pediatric population has an aggressive course per se, and it has a high risk of rapid progression. So this again was a meta-analysis which reviewed 115 publications, and this seemed to tip the balance more in favor of standard CXL because it caused more flattening of keratometry. It showed a greater halt in the progression, while the results with TXL showed inconsistent results. However, the refractive improvements were comparable with both protocols, and this meta-analysis definitely favored a standard Epi-Off CXL for the pediatric population. Another comparison of all the studies, so it's not that all have shown that TECXL does not work. A couple of studies have shown that it's equally effective as standard Epi-Off CXL. However, I would like everybody to concentrate on the last row, where it's been shown that in accelerated TECXL, there was a high rate of progression. 20% progression was noted in the pediatric age group, and perhaps accelerated TECXL is definitely something we should not be considering in the light of this data. However, the jury is not out on this as well. So when literature is conflicting, I thought reflecting on personal experiences helps, although we have a very small case series, but I've been doing transepithelial CXL mainly for thin corneas for the last 4 or 5 years now. And we published some of this data in the International Journal of Keratoconus and Ectatic Diseases and some unpublished data. So the article that was published, what was interesting was, what I want to highlight is that we've always been using riboflavin in HPMC, and HPMC, the role of HPMC was highlighted by the previous speakers. Most of the previous studies have used Dextran, where they showed a shallower effect of transepithelial CXL. Dextran, as we know, retards to some extent the penetration of riboflavin, whereas HPMC enhances it and it works at a much deeper level. So we saw good demarcation lines in most of the patients, well delineated, and the depth was almost comparable to what is seen in standard Epi-Off CXL, which is 294. And this is just a small study we were doing now, comparing the CA-CXL, TE-CXL, and conventional Epi-Off CXL. The parameters were comparable at baseline, and what we saw was that the TECXL induced a gentler effect on the keratometry, but it was significant. It was clinically significant, although the magnitude was less than what was seen in conventional epi of CXL, though the statistical difference was not there. So TECXL induced a milder but comparable reduction of the K values vis-a-vis epi of CXL over a 2-year period. And all these parameters in the CDVA, MRSE, and the rates of stability or regression were comparable across all the 3 groups. Sorry. So just a couple of cases, just 3 cases. This was a 21-year-old male, 6 months after transepithelial CXL, a flattening of almost 2 diopters. Another patient, flattening of 3 diopters, 4 diopters, even 3 years after CXL, and 4 years after CXL, flattening of almost 3 diopters. So in conclusion, the debate about epi-off versus epi-on continues. The only clear-cut indication for transepithelial CXL perhaps is a patient with a thin cornea or apprehensive patients. Literature suggests that patients with poor compliance, e.g. Down syndrome, may be considered for transepithelial CXL, although I would disagree here because these are the patients who have much more severe disease and frequently all of them progress to hydrops. So if there is some doubt about the efficacy of a procedure, we should go for the gold standard. And in the end, after going through all the literature, I don't think I can make a particular recommendation, and I'll leave each one to decide and take their own call. Although if properly chosen, in individual patients, it does seem to have good results, and the effects are not as less as has been shown in literature. Thank you very much.
Thank you, Chintan. I think that was a very nice presentation. Thank you so much. I think I'm not sure, has Dr. Satyamurthy with us on the panel?
Yeah, I think I saw him earlier, but don't see him around.
I don't see him. His talk is up. I would request Dr. Twinkle, I think is she there?
He.
Hi, Dr. Shah, how are you? Good. Are you presenting? You're on mute. Please unmute yourself.
Okay, sir. Yeah.
Right. Can you give us your presentation then? You are presenting instead of Dr. Rupal, is it?
I am Dr. Rupal, sir. Dr. Twinkle is my husband.
Sorry.
Yeah, Twinkle.
Okay, there you are. All right. Wonderful. All right, Rupal, please go ahead.
Yeah. Sir, can you hear me?
Yes, we can see your slides and we can hear you loud and clear.
Yeah. So good afternoon, everyone. I'm thankful for DOS for giving me the opportunity. So we all know the pediatric keratoconus is totally different from the adult keratoconus in many ways. Like most of the children, when they come for the first time diagnosis, they are in the very late stage of keratoconus. There is a very high incidence of progression, and also due to the less biomechanical rigidity, there is a rapid progression. Further, the many children are associated with the coexisting allergy and mainly the vernal keratoconjunctivitis, and they are frequent eye rubber. So due to all these factors, there is a visual impairment occur into the children which affect the social and educational development of the children, and that's why they require the very early intervention and the treatment. There are so many treatment modalities are available, but most of them are for the visual rehabilitation, while the corneal cross-linking is the only true treatment for the keratoconus, which address the underlying pathology and prevent the progression. So there is pediatric keratoconus. In pediatric keratoconus, the cross-linking was started in 2011, and they give some protocol to follow for the pediatric patient. They says that use only the standard Dresden protocol for the pediatric patient. Then they says they do not wait for the sign of the progression or documentation of the progression in pediatric patient, and it is very necessary to treat the associated allergic or inflammatory condition before doing the cross-linking, and it is also necessary to counsel the parents. So patient may require the retreatment, and that it is necessary to treat the associated amblyopia. But nowadays, between 2016 to 2019, there is a multiple other cross-linking procedure are studied, like accelerated cross-linking with the epi-off technique and the epi-on technique. transepithelium cross-linking and transepithelium cross-linking with the iontophoresis in pediatric age group. So accelerated cross-linking, as previous speaker says, it is the Roscoe law that photochemical effect of the ultraviolet rays is equal to the energy regardless of the relative irradiation time and the intensity. So accelerated epithelium of cross-linking was studied in 2014 by the Dr. Sethi. In his study, he used the various energy setting, that is 30 milliwatt for 3 minutes, 10 milliwatt for 9 minutes, or 9 milliwatt for 10 minutes. After that study, there are 8 other study was published in 2017, but the 3 most important studies are the Badwi, Benninger, and the ISA. Their study report says that there is a statistically significant improvement shows in uncorrected and corrected visual acuity, mean corrected corneal astigmatism, mean maximum anterior elevation, average progressive index, Q value, Kmax reading was reduced after the 12 months. But some endothelial changes are seen in the early post-op period, which resolved after the in follow-up. So they conclude that the accelerated cross-linking epi-off that show a stabilization and beneficial clinical outcome in the pediatric keratoconus. It seems an effective and safe procedure in this age group. Other is the accelerated transepithelium cross-linking. This study was done by the Henry in 2013. And they used the different riboflavin that is contain the HPMC and sodium chloride. That is, they administered the riboflavin every 5 minutes for 30 minutes, followed by the rinsing with the balanced salt solution. And the ultraviolet irradiation for 18 milliwatt for 5 minutes. Hello? There is no statistic, the study report says there is no statistically significant difference in the various parameters between the conventional transepithelial group and the accelerated transepithelium group. But there is some reduction in the endothelial cell count following the accelerated CXL in the children, but the changes was not statistically significant. So in conclusion, they says that the accelerated transepithelial CXL is equally effective as the conventional transepithelium CXL. Simple transepithelium cross-linking, the only major difference between the transepithelium and the Dresden protocol is we know the corneal epithelium on and the change in the riboflavin, which include the trimetamol and the sodium EDTA, which enhance the penetration through the intact corneal epithelium. So advantage of transepithelium CXL is we know it is improve the safety profile and reduction in the post-operative discomfort. And main advantage in pediatric age group that we can do this procedure under the local anesthesia. There are only 3 studies available in the pediatric age group, but all the studies shows the variable outcome. The some study says that it is a very good result, while other studies says that there is a less or no response to the transepithelium cross-linking in pediatric age group. So there is no comparative or long-term studies are available for the pediatric age group. Then transepithelium with cross-linking with the iontophoresis was studied by the Bazon in 2013. The iontophoresis is used to increase the penetration of the molecule through the intact tissue in the presence of the low intensity electric field. They use the riboflavin 0.1% without dextran or sodium chloride and with the addition of 2 enhancer, iontophoresis with the 2 electrode and the connective cable. In this protocol, the iontophoresis performed for 5 minutes, followed by the ultraviolet rays for the 10 milliwatt for 9 minutes. This is the only single study done for the pediatric age group. This study concluded that the main disadvantage of the transepithelium cross-linking was less penetration of riboflavin in the stroma, and so it is less effective treatment. But with the help of iontophoresis, the acceptable penetration of the riboflavin in the corneal stroma is possible. So it gives all the advantage of the transepithelium treatment without compromising the treatment efficacy, and it is safe for the children. But further long-term study is necessary to complete the evaluation. So most important in pediatric is a safety profile. So there are some complications seen in the pediatric age group. One is microbial keratitis. Study says that there is definite cases of the microbial keratitis seen reported after the epi of both standard as well as accelerated cross-linking, but no reported case of microbial keratitis after transepithelium cross-linking in the pediatric population. The second one is transient mild haze. It is reported in most of the children following the cross-linking, any type of cross-linking. There is a reduction in the endothelial cell count following the accelerated cross-linking is seen in the children, but study says that changes was not statistically significant. So overall, the cross-linking in the children has a good safety profile with low incidence of vision-threatening complications. So my take-home message is the cross-linking in the pediatric population is a relatively new field with promising result and good safety profile. You have to consider the cross-linking in the pediatric population without waiting for the documented progression. CXL also treat the astigmatism and the visual rehabilitation in the children. Studies shows the improvement in the uncorrected and the corrected distance visual acuity as early as 1 year following the cross-linking. But the further investigation with the larger prospective randomized control trial, that longer follow-up period as needed. Thank you.
Thanks so much. Thank you very much, Dr. Rupal. I think that was a nice talk, and we're going to carry on. And hopefully, if either Abhishek or Dr. Ashok Sharma are here, we can go ahead with their presentations. I don't see either of them.
I saw Dr. Ashok Sharma earlier, but I don't see him now. So,
okay. You want to take a couple of questions then? We may have a couple of dropouts in that case, because I don't see Dr. Satyamurthy either.
I think I saw him earlier, and both Ashok and Satyamurthy.
I think let's finish the presentation, then we'll take questions, because as such
in case they come back, in case they come back.
Right. So then I don't see Abhishek, and I don't see...
Abhishek was also... Ajay Dave, okay, no, Abhishek.
No, Abhishek Dave also isn't here. So we can go ahead with Himanshu. Are you ready with your talk?
Sure, I can surely join.
Yeah.
Then why don't you give us your talk, and then we'll go to Shrish as well as for the complications, and then go to Professor Lionel for the stromal augmentation.
Okay, done. So good evening, everybody, and my talk is very precise, very small, and I'm going to talk about cross-linking for post-LASIK ectasia. It's very specific regarding post-LASIK ectasia. I do not have any financial disclosure here. Post-LASIK ectasia is like sitting on a volcano and just waiting for it to erupt, or rather it's already erupted and you're looking at what to do next. Post-LASIK ectasia, by definition, we know that it's a progressive steepening of usually the inferior periphery or mid-periphery of the cornea, with increase in myopia and myopic astigmatism, with the loss of uncorrected, best-corrected vision, which can occur after a few days to years. Whenever we see any topography, especially the Scheimpflug imaging and posterior elevation, there should not be any change following a refractive surgery. Whenever any elevation starts showing up on the back surface, well, that means post-LASIK ectasia is set in. Post-LASIK ectasia was first described by Theo Seiler as a case report, and till then we were possibly not aware that there is some entity like this thing existing. And then we realized that, well, it's not uncommon. Many of us have burnt our hands with such kind of thing. The pathophysiology-wise, it's related to the altered biomechanics, especially of the anterior stroma, which leads to thinning and compression of the collagen bundles in that region, and in the area of mid-periphery inferiorly, where the maximum stress comes, and there would be loss of structural integrity, and which leads to post-LASIK ectasia. The best way to treat it is to prevent it, and prevention is the best cure, as they said. And there are many theories and many criteria, risk scores given. Many of us use Randerman scores, but believe me, whatever we do, irrespective of whatever strictest of criteria we follow, there are cases where we may end up in post-LASIK ectasia. Management-wise, management hovers around cross-linking and the vision improvement, combining cross-linking with intracorneal ring implants or topo-guided PRK. The cross-linking part is pretty similar to the regular cross-linking, and we know that the question arises as the etiology is different. It's not keratoconus. Similar to RK, where the cross-linking does not work, we question that does it actually work? And the outcomes do show that it actually works. The most common cross-linking studied here is epi-off cross-linking, and which is pretty similar to the cross-linking for keratoconus. The only difference is that here we prefer not to disturb the flaps. So the epithelial debridement is usually using alcohol. I prefer viscohol, using viscoelastic with alcohol, and which helps you to easily remove that, and making sure you do not disturb the flap of LASIK. The UV exposure can be Dresden protocol of 3 milliwatts for 30 minutes, or it can be accelerated. Also, I prefer accelerated protocols. So the question arises, is there a long-term stability which can be achieved with cross-linking these kind of PLE corneas? And the long-term outcome, there are quite a few papers which show that, well, it does work, and it actually is quite necessary to cross-link such kind of cornea. In fact, if you look at one quite large meta-analysis of all post-LASIK ectasia cross-linking, they found that most of the studies show that it improves the best corrected vision compared to cross-link cornea. It also flattens the cornea in most of the studies. It proves that, and it actually does not affect the endothelium. So safety-wise, it's decent, as most of these cornea are pretty thin cornea. So it does work. It's pretty safe. Now, protocol-wise, the cross-linking, epi-off cross-linking, the advantage would be it's time-tested, and the disadvantage is a little longer discomfort and healing in such cases. There can be chance of DLK because you're creating large epithelial defect there. The epi-on cross-linking, as Chintan and Rupal showed earlier about the keratoconus, the epi-on cross-linking here in post-LASIK ectasia has not been studied very well, though it's very minimally invasive procedure, but we are not sure about the efficacy of that. One more interesting cross-linking method which has recently taken up, which is under-flap cross-linking, where for the better penetration of riboflavin and less discomfort, you lift the flap and put the riboflavin and do the cross-linking. The advantage is, well, less discomfort because you're not creating large epithelial defect. But disadvantages are that it's certainly not non-invasive, it's more invasive. There can be chance of DLK, there can be chance of epithelial growth also. The technique-wise, what's done is under topical anesthesia, you lift the flap, you use a riboflavin, 0.25 riboflavin for 3 minutes and reposit the flap and then do cross-linking. And they show that outcomes are pretty decent. Remember, whatever we do, the most important goal is to visually rehabilitate these patients. So doing cross-linking alone would stabilize the cornea. But for the visual rehabilitation, you have to combine them with something else, like either intracorneal ring, topo-guided PRK, or the contact lens. Coming back to, again, the triad of treatment, the next part is the intracorneal ring implants. If I have to tell in a nutshell, if I have to use only one indication for intracorneal ring implants, and that would be post-LASIK ectasia. So one such case, young female, a dentist would come to me with a post-LASIK ectasia in one eye, another eye was pretty decent. I did a single ring implantation, and again remember, in post-LASIK ectasia, single ring implantation is the choice, because If you remember, the ectasia, if you can see from the picture here, ectasia is inferiorly, the superior cornea is pretty flat. So you do not need to flatten that cornea with the other ring. So what you need to do is put a ring here and do cross-linking, and you can see here, it brings the shape of the cornea almost as if there is a LASIK done, and their visual outcome is pretty good. So post-LASIK ectasia with a single ring implantation combining with the cross-linking works wonderfully well. So you do ring first, and then you do the cross-linking. The third part is topo-guided partial PRK, where we know that we do a small amount of correction, and we heard earlier speakers talking about that. This was reported by Kanellopoulos and Perry Binder, and they found that it actually works. However, it does sound counterintuitive that the laser treatment or weakening of the cornea which led to the ectasia, you're doing something similar to that, but it still works. Now, in any case, wherever there is significant irregularity on the surface, you cannot take care of the complete irregularity. So I would still prefer Intex over the partial PRK. If you look at the cross-linked cornea alone, the problem here is that it flattens the flatter cornea also. So with the time, the flatter cornea gets further flattened, and the steeper cornea gets relatively steepened. So though it's not, so the visual outcome may not be as great. With Intex, the ocular surface or the corneal surface becomes much more natural. And I would rather say that the outcomes are pretty early, and you can see the effect much earlier. Topo-guided treatment, well, the outcomes are decent, but you cannot regularize the entire surface, and it partly treats the irregularity. So to summarize, cross-linking following post-LASIK ectasia has to be done immediately. You do not need to wait for anything. Subflap cross-linking is a newer treatment. We have to wait for longer outcome. Insertion of single segment intrastomal ring brings the best visual outcome along with the cross-linking. If the corneal thickness is decent, we can do topo-link PRK combined with cross-linking. Thank you very much.
Thank you so much, Himanshu. It was a very nice presentation. And I think we'll go on and go into the complications next. And I think I'll request Shrish, I can see here. So go ahead, Shrish, give us your presentation, please.
Okay, thank you. So, good evening. At the outset, I would like to thank DOS for the opportunity. So my talk is on complications of collagen cross-linking. We all know that CXL has become the mainstay in the management of keratoconus. However, it has its own merits and limitations. So several long-term and short-term complications of CXL has been studied and documented. And it may be a primary due to incorrect technique application or incorrect patient inclusion, or it could be a secondary complication related to therapeutic soft contact lenses, or patient's poor hygiene, or undiagnosed ocular surface diseases like dry eye, blepharitis, etc. So the common complications of CXL include infectious keratitis, sterile keratitis, corneal melts, corneal haze, endothelial damage, and treatment failure. Keratitis can occur following CXL because of the presence of an epithelial defect, use of soft bandage contact lens, and topical corticosteroids in the immediate postoperative period. Or it can be due to poor hygiene or persistent ocular inflammation, as you see in patients suffering from allergic eye diseases, or pediatric patients who are not able to maintain maintain hygiene. And topical corticosteroids postoperatively, immediate postoperative period can be the reason for infectious keratitis. And this is the microbial profile of infectious keratitis following CXL. It's mainly the ocular surface flora which is responsible for microbial keratitis. Staphylococcus is the commonest organism, followed by Streptococcus, Pseudomonas, E. coli. There are reports of herpes virus, Acanthamoeba fungus after CXL. So this is the first case report of microbial keratitis following accelerated corneal collagen cross-linking reported by us in the year 2015, and we reported a case of staphylococcal keratitis following accelerated CXL, and this patient responded to fourth generation fluoroquinolone and steroids, and followed by there was a publication from RP Center. They have described 7 cases of microbial keratitis after accelerated collagen cross-linking, of which 6 of them are staphylococcal group, and 3 cases had mixed infection with Aspergillus fumigatus, Mucor, and Acanthamoeba, along with the Staphylococcus aureus. And we published our profile of infectious and sterile keratitis after accelerated corneal cross-linking. We included almost 1,000 cases, close to 1,000 cases, 968 eyes, which underwent accelerated collagen cross-linking, and we reported 10 cases of keratitis, of which 3 had infectious keratitis and 7 sterile keratitis. So the development of herpetic keratitis after CXL treatment has been reported, and it seems that UVA light could be a potent stimulus to trigger reactivation of latent HSV infections, and significant corneal epithelial and stromal trauma or actual damage of the corneal nerves could be the mechanism of HSV reactivation. Sterile corneal stromal infiltrates, they occur as a result of enhanced cell-mediated immunity to staphylococcal antigens deposited at high concentration in the areas of static tear pooling beneath the bandage contact lens. And steep fit is another reason for sterile infiltrates. So these are some of our own cases. You can see the typical pattern of these infiltrates. It's in the mid-peripheral, small infiltrates. This actually, most of these infiltrates are seen at the junction of epithelialized and non-epithelialized cornea. This is one observation, and they respond very well to topical steroids. This is another case. You can see the pattern of these sterile infiltrates. This particular case, who underwent CXL with intacts and came back to us on the second day with a small infiltrate in the paracentral area close to the entry wound, and there is a hypopyon. We thought it is a fungal infection. Patient was not symptomatic. There was a drop in vision, but symptoms were less. There was congestion, and so we started on antifungal. There's hardly any material to be collected for microbiological examination, but it deteriorated, the symptoms worsened, and then we thought it could be a case of sterile infiltrate and started her on steroids, and she responded well. And this is another case with the peripheral ring infiltrate. There is a clear space between the limbus and the infiltrate, and this patient again responded to steroids. And this particular patient developed rashes all over the upper half of the face, so it could be an allergic reaction to riboflavin. And in the cornea, I could see a peripheral marginal infiltrate with a clear zone in between. It could be hypersensitivity reaction to riboflavin, and again the treatment is the topical steroids. Coming to corneal melt, keratocyte damage after CXL may affect the wound healing process and collagen deposition, and the epithelial defect after CXL may increase matrix metalloproteinase levels in the cornea and tears, therefore increasing the risk of this corneal melting. And corneal haze is another common side effect or a complication of CXL, and the subset of patients developing steroid-resistant haze appear to have more advanced keratoconus thin corneas, and higher keratometry value of the apex. And this haze peaks at 1 month, plateaus at 3 months, and significantly resolving at around 3 to 12 months after the procedure. And some cases may show aggressive healing response to CXL in the form of dense scar formation, and yes, OCT shows flattening of the curvature. These patients wind up with an extremely flat cornea with a reduction of the myopia to minimal levels post-op, and even occasionally the development of hyperopia. Another complication is endothelial damage. The endothelial damage threshold was shown to be at an irradiance of 0.35 milliwatts per square centimeter, which is approximately twice compared with 0.18 milliwatts per square centimeter that reaches the corneal endothelium when using the currently recommended protocol. It may be due to a stromal thickness less than 400 microns, or incorrect focusing, or increased energy level reaching the endothelial layer. So the last complication is a treatment failure. It is an undesirable outcome of CXL. The failure is largely defined as the keratoponic progression and loss of best corrected visual acuity. And the researchers actually concluded that changing the inclusion criteria may significantly reduce the complications and failures of CXL, avoiding patients with too thin corneas or steep corneas beyond 60 diopters, or scald corneas. Severe allergic eye diseases can improve the outcome of CXL. So in conclusion, so complications following CXL can occur, but given the revolutionary change that CXL has brought about in the management of keratoconus, we cannot overlook the much greater benefit-risk ratio associated with CXL. Patients have very little to lose and everything to gain. Thank you.
Thank you so much. Thank you so much, Shrish. That was a very nice, comprehensive overview of the complications. We have Professor Lionel now, who's going to be telling us about one of his favorites, which is intrastromal augmentation, and I think he'll follow up with an IOL. Go ahead, please, Lionel. Are you ready?
Yes, good evening. Is my screen and my voice clear?
Yeah, we can hear you well.
Thank you. Thank you so much, sir. I thank Das.
But we can't see your slides yet.
Is it?
Yeah.
Okay. Let me share again. Now?
We are seeing your screen, it's blank.
Yeah, screen sharing, but started, but we see blank screen. Have you kept your slides open?
Yes, I did.
Okay.
Try again.
I'll do that.
Meanwhile, Chintan, are you there?
I am, yeah.
So Chintan, you have now trans-epi cross-linking you can do, and you can do the conventional epi-off also. Now, you have a choice of both of them. So which would you choose, and which cases you would choose which one?
So for what mostly I've been following for the patients who have a decent corneal thickness where they can, sorry, should I carry on? Yeah.
No, you please carry on.
You can just finish, then he can start. I mean, if you start, it's not fair on our part.
I still prefer the conventional epi of CXL, but transepithelial definitely where there's a thin cornea, or also I'm also preferring it in patients where, we still have a decent, relatively, like patients, sometimes we do cross-linking for patients who have 6'9", 6'6" vision, but they are showing a slow progression because it's gentler on the cornea. There I prefer to go in for transepithelial. The conventional sometimes tends to cause a little bit more of haze, I feel, and more flattening sometimes and irregular topography. So those are the cases, but definitely in thin corneas, that's the primary indication.
Thank you, Chintan. We'll come back to that again.
All right. Now it's visible, right, sir?
Yeah, very clear.
Okay. Thank you so much. Thanks, Das, and respected panelists and dear viewers. I do not have any financial interest. The entire session is meant towards cross-linking, but my talk is on corneas which cannot be cross-linked. Corneas which are less than 400 microns or even less than 350 or 370, even hypotonic cannot be done. So to us, as we know, keratoconus is a disease of cornea which is characterized by thinning and steepening. When there is only thinning and steepening, the need for removal of cornea and replacement by another corneal tissue is something which we need to rethink again. So in cases which are not scarred in extremely thin corneas, we thought of doing a corneal stromal augmentation procedure, and we wanted to study its outcome by 1 year, and following which cases which had a higher level of refractive errors, we thought of going ahead and correcting in the lens plane using toric phakic IOL. So it's a conceptual analysis. The aim, as I said, is to analyze the effectiveness of implantation of toric phakic IOL as an add-on refractive measure to corneal stromal augmentation technique in the management of advanced non-scarred keratoconic eyes. A prospective exploratory clinical trial in Department of Corneal Transplantation at Dr. Agarwal's Eye Hospitals in Tirunelveli, down south, near to Kanyakumari. So we had two phases, as I said. One is phase 1, where we enrolled 15 non-scarred keratoconic corneas, which were contraindicated for cross-linking, and a femtolaser-assisted donor stromal lenticule of somewhere around 220 microns, 8 to 8.9 millimeter in diameter was fashioned. And similarly, a mid-stromal bed was created using femtosecond laser in thin corneas of the recipient with 2 incisions, 180 degree apart and 1 to 1.5 millimeters in size, into which the donor corneal lenticule was transplanted for a successful augmentation. The difference in the preoperative and the postoperative vision, central pachymetry, anterior and the posterior corneal elevation changes, reversal of irregular astigmatism, and the graft interfaces were analyzed by 1 year. In phase 2, 8 out of the 15 eyes which had residual high refractive errors underwent add-on toric phakic IOL implantation, and the outcomes of vision, contrast sensitivity, and higher order aberrations were measured after 6 months. This is how we did a donor cornea which was mounted on an artificial anterior chamber. We created a stromal lenticule of 220 microns. And this is in the recipient cornea. A bed is created in the mid-stroma with 2 incisions. The bed and the incisions were opened up, and the corneal lenticule is successfully placed inside. We can consider this as a reverse smile, maybe. So these are the surgical techniques of phase 1. This is 1 year later when we saw, we can see a smooth interface on the OCT, a clear graft intrastromally. And this is one of our cases where we had improvement in a successful improvement in flattening of the anterior posterior cornea, reversal of astigmatism, and increase in the pachymetric map. So the results. Corneal stromal augmentation improved vision by 4 Snellen's lines. The uncorrected vision improved from 1.2 logmar to 0.8, and the best corrected improved from 0.9 to 0.4 logmar, which were statistically very significant. The thickness of the cornea improved from a mean of 360 to 583 microns, around 220 microns of improvement, as we expected. The anterior and the posterior cornea showing flattening, 0.67 to 0.44, that is 0.02 millimeter flattening in the anterior cornea and 0.03 in the posterior cornea, and similarly closer to 5 diopters of reversal of astigmatism. It is interesting to note that addition of tight layer of cornea, a lenticule, pushed the posterior cornea further down, more than that of the anterior cornea. That's what we could see. And this is sort of the case where a nipple cone is completely flattened post CSA. Inferior to superior asymmetry as a measure of irregular astigmatism preoperatively was 12.6 diopters, and it has reduced to a mean of 3.2, a difference of 9 diopters and a half, which was noted in our series. And we assumed the test value of 2.5 diopters to be an assumed significant, assumed acceptable difference of inferior to superior asymmetry. And the postoperative post-CSA was no way far from the assumed target. In this graph, if I can share one of these things, closer to 18 diopters of irregular astigmatism is reversed to 2.8 in this particular case. So post-operative inferior to superior asymmetry is much reduced, and it is closer to an assumed acceptable difference of 2.5 diopters. In phase 2, just a simple recap of phase 1. This is the low donor lenticule. Another case, stromal bed is made with 2 incisions and addition of layer. After a year, when everything is good, we went ahead and we did add-on toric phakic intraocular lens, and this is how it is: an additional stroma and added lens inside. So 8 cases underwent this second procedure after 1 year. This is a very good clinical and OCT picture showing added stroma as well as add-on toric IOL. And as I mentioned, the best corrected vision in phase 1 improved from 0.9 to 0.4 logMAR. And in this particular 8-case series, it is 0.62. And post toric IOL, it improved after a month by 0.25 logMAR units, and it's retained after 6 months as 0.23, which is closer to 6.9. And the higher order aberrations was a mean of 0.56 microns, which is comparable to a historical sample of DALC, and it's significantly better than PK, what we could understand. And similarly, the contrast sensitivity function in photopic condition, monocular contrast sensitivity, was within normal limits of 1.68 in 7.5 CPD, and this is very good for any transplanted corneas. So the highlights of this twin procedure: one is it is just mere addition of stroma and no sacrifice of host tissues. It's a simpler technique. Early stabilization of cornea could be done under topical anesthesia. Femto-assisted dissections help in smooth interfaces, as like SMILE or femto-assisted DAL. You can see here very smooth interfaces, unlike blade techniques. And toric phakic IOL restores visual functions which were residue at the lens plane without disturbing the stabilized cornea. To conclude, we could tell that corneal stromal augmentation is effective in improving vision, flattening of cornea, reversal of ectasias, and improvement in irregular astigmatism with excellent interface properties and without replacement of recipient tissue and suture-associated complications. We would tell it is non-inferior to DALC by any means, with added advantages of no sutures and early visual recovery. An add-on toric phakic IOL implantation is effective in overcoming residual high refractive error post-corneal stromal augmentation technique with improved contrast sensitivity and provides a complete refractive solution by the end. And these twin procedures can replace DALC in most of its cases if there is no scar associated with. Thank you for listening.
Very nice talk, Lionel. I greatly enjoyed that. I've enjoyed it earlier as well, so it's even better. So Himanshu, over to you. You were having some questions. I'm not sure if there are any speakers. If there's anyone has joined amongst those who were not here.
Don't think so. I don't think any of the speakers are here.
Satyamurthy or Abhishek or Ashok Sharma.
Dr. Abhishek actually messaged in one of the groups in the morning in hall, see that he won't be there. He's not well.
Oh, I see. Okay. All right. Thanks. All right. So at least we know.
Dr. Lionel, we'll start with you. I mean, it's wonderful. I really like you. You have quite innovative mind. You come up with very innovative techniques every time. Very interesting stromal augmentation. I think many groups have reported stromal augmentation. But the interesting part of any such kind of procedure in keratoconus is the visual rehabilitation part. Now, whenever we do a case like stromal augmentation, in case where you are not able to do cross-linking, where you have said it's very advanced cone, it's pretty ectatic cornea. And with the 8 millimeter tissue, which you 8.5 or 8 millimeter, you said?
Yeah, 8 to 8.9. That depends on the weight of the cornea and and the steep and the diameter of the cone.
Yeah. So if you are implanting that tissue, I'm not sure how much irregularity of the surface you can take care by merely implanting a tissue only. Which I'm not suggesting, which is in an inferior way, but most of the procedures, if we look at there, gives you a little more defined outcome. Now, can your technique be combined with later on either doing a cross-linking or maybe doing a topo-guided PRK partly on this thing, so that at least you can take care of those irregularity and higher order aberration?
Exactly. So yes, I do understand. There are no Vergennes equations to find out how much amount of tissue has to be added, especially when we consider a cone per se. Secondly, there were techniques where we can do tucking. In addition to that, we can do some compression sutures also that were also been described, and also that we can do surface ablation. That can very well be done because we are adding in the mid to posterior stroma. So refractive surgery is possible. One of which what I had taken is toric IOL without disturbing the cornea, but still all these can be done. Minimal one, I had even done PRK to overcome. And some of the cases, not in this series, but some of the cases I had done an irregular type of, the donor lenticule dissection also, where a thicker periphery and a thinner center. And in at least 2 cases, the central area alone, we made 3 millimeter punch, like a pinhole also, we have tried. As you mentioned, there is no actual Vergennes formulas to derive, but all these refractive procedures are possible. And also contact lens fitting over the augmented stroma is very easier than the keratoconus itself.
I think you mentioned about the flattening of the posterior curvature more than the anterior. And I think, would that not be based or dependent on the depth at which you insert the lenticule? The more posterior you go, it would stand to reason that the posterior would flatten more than the anterior.
Exactly, sir.
So what Himanshu was saying, if you wanted to make an impact on the anterior curvature, you might want to put it in a very anterior pocket.
But anyway, I do agree with him because DALK, in addition to adding tissue, it is the sutures that is also going to give some flattening, the curvature. That may not be possible here, but still, in our case series of 15 cases, it's not inferior to DALK in this particular.
Having said that, it certainly opens up a new option. And I really appreciate you taking care to refine the procedure nicely. Congratulations, very nice. So Sanjana,
and just, I'm sorry, and just to answer a part of your question, it is 4.9 diopters of irregularity reversal what we saw. And when it is superior to inferior irregularity, it is closer to 9 diopters.
Sure. Excellent. So, Sanjana, if you're talking about, say, when we are doing customized cross-linking, and so what kind of pattern are we looking at when we do customized cross-linking? Are we looking at the pattern based on which topography output we are looking at the pattern? You're mute, Sanjana. Okay, so it's not Viva question. So let me just refine my question, that I'm not trying to find out what, my only worry is that whenever we look at the topographies are a depiction of the shape of the cornea, and they're not true shape of the cornea. And most of the time when these companies, they take the shape, they take the axial topography based configuration, and which is not actual true shape of the cornea. So treating that based on such kind of shape is partly something which is not very convincing to me. But having said that, what's your take on that, and what does the literature say about this thing?
I do not have personal experience with the customized treatment, but as far as what I have read, so they say that even considering the posterior curvature, where there is a maximum posterior curvature around that area, we take about 0.5 millimeter as an inner circle, lesser than, and 1 millimeter will be from the outer circle. So around that area, if we give the maximum ablation, that would be better. Because if we just take into consideration the anterior aspect, there would be the epithelial changes as well, and even the teofilm, and there are so many things which can contribute to that. So instead of taking anterior, maybe the posterior curvature steepening is what they advise, though I don't have personal experience with this.
So the other interesting part is the customization can also be done in terms of you're delivering in different zone. Now that's really interesting, because if you are delivering the energy more into the zone of your weak cornea, and in the concentric form, you're delivering little less energy to the not so weak cornea, well, that actually makes sense. Having said that, cross-linking is still not a refractive procedure, and if we are able to reduce the irregularity partly, I mean, that's we will take it with both hands. But we still have a role of other procedures there. Dr. Arora, so in your practice, when you are looking at doing cross-linking, do you prefer bilateral simultaneous cross-linking, or that's absolute no-no for you?
Normally we do bilateral cross-linking. So it's more convenient to patients, and we are pretty sure now we can do it in both eyes. The complication rates are very minimal. So we don't, normally we do in bilateral.
But with Shirish talking about infection and those, Shirish, can you come in that after your publications and after your literature review of your own cases, Shirish, do you guys also follow the same thing? Do you do bilateral simultaneous, or do you do sequential, Shirish?
Yes, Himanshu, we do we don't do bilateral simultaneous. So we do.
Are there any cases where you do like pediatric or mentally challenged or any under general anesthesia, or you would strictly not prefer?
Yeah, we don't prefer it. And it's like post-operatively, like we used to put steroids in the first 3-4 days, and that also we have stopped using steroids in the first 3 to 4 days, and we start only after the BCL is removed or the epithelium is healed. So that has reduced. Nowadays, we don't see any infectious keratitis. In the last couple of years, we have not seen any infectious keratitis, and I have shown some 7 cases of sterile keratitis. Actually, I don't know, like that time we had a couple of cases. So it's like a cluster of, it may be the batch of riboflavin, which has caused some amount of immunological reaction in the eye, or maybe the reason for that cluster of cases. So last 3 to 4 years back, we had 7 cases. So could be the reason. Nowadays, we are not seeing any such cases.
Himanshu, we've been doing cross-linking now for what, 13, almost 14 years.
Correct.
And we've been doing simultaneous bilateral and been following the original Dresden Epi-off protocol. And we've yet to see a keratitis. And I think two reasons. One, Shreesh just mentioned, was that we don't introduce steroid till we have epithelial healing, which is usually around day 6-7. Second, we start to pre-treat them with antibiotic 2 days prior. So we have a excellent antibiotic level already in the corneal tissues before we start the procedure. So those are the two things that have actually saved us, I think. I don't see any reason to not do a bilateral sequence or bilateral simultaneous where indicated, of course.
So Himanshu, I personally do one eye at a time, although I don't really believe that infectious keratitis, though a possibility, is a really significant concern. The only time I would do, or rather have done bilateral simultaneous, is in the case of pediatric ones where general anesthesia was given. And second, where it's fairly common, is logistic issues for, let's say, out of Delhi or international patients who find it difficult to come back. So it's not that I'm really against it, but I would be more comfortable doing one at a time, seeing the result, seeing how the eye fares. And sometimes when you have these borderline pachymetries, there it really helps to see how one eye fares, and then you go for the second eye.
I think what comes out from all these things, even when Chintan talk about trans-epi cross-linking, sometimes we have quite dogmatic rules and idea in our mind about certain things, and we stick by that and demonize the other part. And it may not be in bad way, but academically, maybe we become more selective in looking at the things which you want to see. And that's a selection bias which we all can have. And similar bias can come when we talk about such thing that many of us, those who don't do bilateral simultaneous now, earlier we used to do, we become sometimes quite rigid in our outlook. But as Dr. Rishi said, that I don't think we should be quite oblivious to the thing that there can be other way of handling the cases.
Meantime, just to the same concept, I do agree. Infectious keratitis is, in my practice also, it's very, 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 very less.
And I think what Dr. Rishi said, that prophylactic antibiotic of 2 to 3 days, which I normally follow for cataract also, and I follow for my refractive and CXL patients also. That's the most important point here. And if you start that, risk of infection is quite less. But still, I don't know, personally, I'm more comfortable doing one at a time. And but of course,
yes, yeah. I was about to tell, rather than the infection, how about the post CXL haze? How do you manage when we do bilateral?
The downtime of the patient. So yeah, that's one of my concern, which where normally. So another reason why I take a break in between two eyes is that once I rehabilitate one eye, and so that they don't need to spend a little longer downtime.
Exactly. That's mine.
But again, it's based on the individual patient, and I'm sure we all can take a call on individual patient how important. Just one thing about the infection after cross-linking. Remember, when we have infection after cross-linking, the course of event can be quite disastrous because the way any microbial keratitis behaves, it depends on three things. One, the organism. Second, the microenvironment or niche. And third is the immune response. The cross-linking alters two of them. One is the microenvironment. It leads to rarefaction of keratocyte. It leads to loss of keratocyte in that area, like how LASIK does. And the immune response is downregulated because of the topical steroid, what we give, and hypoxic condition, if at all we have given the contact lens. So the way a microbial keratitis behaves sometimes can be quite disastrous. Like a gram-positive cocci organism, which is localized infection usually cause, can lead to melting also. So be aware whenever you are dealing with any microbial keratitis following cross-linking, be aware that can be pretty nasty in terms of the course which it can take. Having said that, all the panelists
point, Himanshu. Just one point. It's actually it's just a mental block. I think we have been doing PRK bilaterally. It's just CXL alone. We are not doing it. So it's just a mental block. I think there is no logic in it. If you are doing PRK bilaterally, same sitting, so we can as well do CXL.
I think there's a quality,
yes, Dr. Arora. Yeah.
The quality of ribo is also important. Sometimes we go long back, we got Indian ribo, which were not at par. And the second part is the contact lens fitting is very, very important. If the contact lens is tightly fit, it can cause problem. If we see debris under it, we just change the contact lens. That's again very important. We have to be very cautious for that.
So what all the panelists said is actually you can do bilateral simultaneous, but it's you who should be deciding that how strict your protocols are, pre-op protocols, post-op protocols, and be very cautious about that. Dr. Rupal, in pediatric cases, Dr. Rupal, are you there?
Yes, sir. Yeah,
so in pediatric cases, when we do a cross-linking, how easy or how difficult it is to follow them up in terms of their outcome, like looking at whether you got decent outcome or not. So what is the age group cutoff where you would possibly look at your topography more seriously? Is there anything practical hint which you would like to give the rest of the people attendees?
Yeah, usually in our setup, we see the patient between 10 to 14 years of the age group, and they are quite cooperative for the topography or the pantacam. But we also see the patient between 7 to 10 years of the age, and when they are coming, most of them are clinically advanced cases. So clinically, we can say that patient is a advanced keratoconus. The only thing we require is the pachy of that patient, whether it is allowing us to do the epi-off technique or we require some other technique. So we usually the patient are allowing for the topography and SIM-FLUG image.
Thank you. I would like all the panelists to answer this thing, that how often in your practice, when you see a case which is not having a high risk of progression, where you have severe eye rubbing which is not controlled, not treated, or any connective tissue disorder or very advanced cone or something, if you're not treating such kind of case, you're treating the regular case, in how many of your case percentage wise you would have seen the recurrence or you would have seen the failed cross-linking, whether you have done accelerated or whether you've dressed in? So how common is a failure of cross-linking? Dr. Rishi, I would start with you. If you can let me, how rough, just guesstimatable. 0. That's amazing. That's nice. Dr. Arora, how about
that said, I will qualify that by saying I do have 3 patients who I am monitoring, where there was an extent of flattening that I was seeing year on year till the 3rd, 4th year. And all 3 of them were actually ladies who got married and had a pregnancy. Okay. And for reasons that we are aware that those hormones do disturb.
So we have something to, we have something to blame for, but I would still consider them as a success earlier because you had flattening earlier also. So your 0 still stands.
Yeah, 0.
Yes. Dr. Arora, how about you? How often do you see a failed cross-linking?
It's almost 0. I've just seen one case which was done somewhere else. It was a pediatric case.
Okay.
So it was the age of patient when it was done was 10 years. Later he came to me around after 4 years. Then still he's having some sign of that one. The patient went there, but yeah.
And to reclassify this thing, what is your protocol? Do you do accelerated and what energy?
Accelerated 10. I use 10 minutes protocol.
Okay, Dr. Rishi, how about you? Protocol and
unchanged in 13 years, Himanshu. Dresden, epi-off. Regardless, if it's too thin, I will thicken with either the hypoosmolar and with some distilled water. I don't use hypertonic saline. I don't think it works. Distilled water works very well.
Ashu, how about you? Protocol and how often do you see recurrence?
So one eye of one lady, 21 years of age, done in 2009. That definitely progressed. And the progression was noticed after 5 to 6 years. She was doing engineering and then she came back from Pune. And after that, she's been lost to follow. But that's the only case that I could establish. Second, as Dr. Rishi said, post-pregnancy, one eye, like I said, I prefer to do one eye. Two ladies operated for one eye, pregnancy, got married, got pregnant, delivered. The second eye progressed.
Again,
the second eye progressed, but not in this. So that was compared.
So again, we have something to blame for in high risk spectrum. I'm talking about absolutely normal people, regular.
So I would say one eye and one and over.
And your protocol. What do you?
Dresden essentially, but for about last maybe 2.5 years, I've shifted to accelerated. I do both actually, but I do a bit of accelerated also. 9 into 10, 9 by 10. Right,
Shirish,
and I do use for thinner corneas. I do use, unlike Dr. Rishi, I do use hypoosmolar. And the only thing is, I need to. What I've realized is you just can't leave it for 2 minutes like the Dresden protocol. Every 20 seconds, I add a drop. So that's it. So a lot of volume is added, but every 20 seconds. So essentially, you could either use distilled water and mix it, or you use hypo with every 20-second instillation.
So Shirish, very short answer. How many progression and what protocol?
Frankly speaking, I have done 4 DALK post CXL and 1 case PK and 2 CXLs, repeat CXLs.
Shirish, I would appreciate percentage-wise if you can roughly tell me percentage, because you would have a large number of cross-linking.
Maybe around it is around 0.1%, I can say 0.01%. That is out of 4,000 cases, maybe.
That's very small number. And what your protocol of cross-linking? What do you do?
Initially, distance protocol, and now it is 9 milliwatts into 10 minutes accelerated CXL.
Chintan, how about you? How many progression? What protocol you use?
Near zero progression, just one case which had severe VKC. Despite that, so that rules out near zero in the normal.
That rules out that.
And protocols Dresden, CACXL, and transepithelial CXL, depending on the corneal thickness and the other factors. So pediatric, no TACXL till now. Otherwise, thin corneas between CACXL and TECXL. More than 440 conventional.
Lionel, how about you? How many progression protocol you use?
It is one single case, but bilateral. Both eyes, I had to go for DALK in both her eyes. That was post-LASIK ectasia, Dresden.
Okay. You use all the patient Dresden protocol? Your current protocols?
Dresden is the one we follow, and a modified Dresden when I make a pouch and infuse riboflavin into the stroma.
Okay, sure. And Sanjana, how many percentage progression? What protocol you follow? Oh, we can't hear you. You're muted.
Not on mute.
Yeah, now we can hear you.
Yeah. So recently I saw a case where both eyes were cross-linked and one eye showed progression, and she was again like 26 years and post-delivery and all that. And her thickness was 320 microns. So normally we do the CACXL technique. That is what I follow here. And but usually for 350 and above is what CACXL is normally advised. But if it is lesser than that, we would still go with.
No, Sanjana, my question is different. My question is how many percentage you have seen progression in a regular clean cut case, and what is the protocol normally you do for the cross linking? Simple question.
Regular case, I have not seen the progression. This is mostly related to the pregnancy.
And your protocol of cross linking, what do you follow?
Normally we follow the accelerated one, that is 9 milliwatt for 10 minutes. And
perfect. So if you actually look at all of them, and in fact I had done one survey asking for the data. Believe me, the progression following cross-linking in a regular case is extremely rare. Yeah. Whether you are using Dresden protocol, whether you are using accelerated protocol, including what Chintan talks about trans-IP also. So I think a cross-linking, whether it works or not, there is no question. the progression following cross-linking is again extremely rare. Whether you're using accelerated protocol or you're not using accelerated protocol, I don't think it's a question here. Personally, I have done many 30 milliwatts, 3 minutes also, and I follow 80 milliwatts regularly. I do for 5 minutes, and I'm yet to see progression. So sometimes progression, we are worried about that, but we also don't know how right is the cross-linking, how much is enough. So if all of us, if we agree that if we get a treatment which just stops the progression, does not lead to flattening, will we call it successful? I'm sure we will call it successful. If it stops progression, it will call it successful. So if a treatment does not lead to significant flattening, is still a successful treatment if it does not progress. So how much is enough, we don't know. And I think Shirish was showing one case where it was significant flattening. So sometime after a few years, we may realize we were overkilling by cross-linking too much of a cornea. So I think we still have a lot to learn from the subject and science and from each other. And it was really wonderful to interact with each one of you. And it was really wonderful session. Thank you, Dr. Rishi. And it was really nice of you to conduct the session in most efficient way.
Thank you very much. I think I've had a wonderful evening, learning a lot and gaining from all these presentations. And I'm sure everyone who participated and was hearing this session would have taken away lots of carry-home messages. Thank you, Himanshu, for moderating it so well, and Ashu for assisting me in conducting this session. I thank all the speakers, and I hope to see you all tomorrow.
Thank you. Thank you.
Bye.
Thank you.
Bye.
Have a great evening. Bye.
Bye.
Thank you.